Up next, we have a performance by Faro from second year MBBS. Let's hear it for everyone, guys.
நான் சொன்னது மழை வந்துச்சா, நான் சொல்லல வெயில் வந்துச்சா, அடி ரெண்டுமே எதந்துச்சா, முத்து முத்து பேச்சு என் கண்ணுல போய் இருக்கா, உன் கண்ணோட மயக்கி இருக்கா, அடி கல்லிய அறிவு இருக்கா, என் மூச்சு நின்னு போச்சு, காத்தோடு காத்தாக உள்ள வந்தியா, காட்டோடு காடாக கட்டி போட்டியா, ஊத்தாத ஊத்தெல்லாம் உள்ள ஊத்துது, என் பேச்செல்லாம் நின்னு போய் மூள சுத்துது. நான் சொன்னது மழை வந்துச்சா, நான் சொல்லல வெயில் வந்துச்சா, அடி ரெண்டுமே தந்துச்சா, முத்து முத்து பேச்சு கருவாட்டு குழம்பானியோ ருசிய திற, ஒரு வாட்டி தின்னு பார்க்க உசு பேத்துற, அடி போடி 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 பொட்ட மயில போத ஏது வந்துச்சா, உன்னை தூக்கி போக நான் வருவேன்னு கிளி வந்து பதில் சொல்லுச்சா, கருநாக்கு கார புள்ள கருப்பட்டி நரப்புக்குள்ள எடுபட்ட நினப்பு தொல்ல நீ களவாணி, ஓ கருவாட்டு குழம்பானியோ ருசிய திற, ஒரு வாட்டி தின்னு பார்க்க உசு பேத்துற. நான் சொன்னது மழை வந்துச்சா, நான் சொல்லல வெயில் வந்துச்சா, அடி ரெண்டுமே தான் தந்துச்சா, முத்து முத்து பேச்சு.
Let's give him a large round of applause, guys. Come on. Up next, back on stage is Taslina from the second year of MBBS. Let's hear it up for her.
എത്രയോ ജന്മമായി നിന്നെ ഞാൻ തേടുന്നു, അത്രമേലിഷ്ടമായി നിന്നെ എൻ പുണ്യമേ, ദൂരതീരങ്ങളും മുഖതാരങ്ങളും സാക്ഷികൾ, la 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 la, കാറ്റോടു മേഘം മെല്ലെ ചൊല്ലി സ്നേഹാദ്രമേധോത്സവം മായുന്ന സന്ധ്യേ നിന്നെ തേടി ഈറന്നിലാവിൻ പരാഗം എന്നെന്നും നിൻ മടിയിലെ പൈതലായി നീ മൂളും പാട്ടിലെ പ്രണയമായി നിന്നെയും കാത്തു ഞാൻ നിൽക്കവേ, മഴ വരും മരക്കുറി എൻ വിഴികൾ തെരിയുതേ, മനമെன்று நனைதேன், இது என்ன காதலா சாதலா, பழகிய காலங்கள் என் பார்வையில் விரியுதேன், பாதைகள் நடுவுதேன், இது ஏனோ ஏனோ, உன் தோல் சாயும்போது உற்சாகம் கொள்ளும் கண்கள், நீ எங்கே எங்கே என்று உன்னை தேடி தேடி பார்க்கிறது, உன்னோடு போகும்போது பூ பூக்கும் சாலையாவும், நீ எங்கே என்று என்னை கேட்ட பின்பு வாடிடுதேன், மழை வரும் அறிகுறி என் விழிகளை தெரியுதேன், மனமென்று நினைதேன், இது என்ன காதலா சாதலா, பழகிய காலங்கள் என் பாதைகள் நடுவுதேன், பாதைகள் நடுவுதேன், இது ஏனோ ஏனோ, அறியாதொரு அதுவாகவே தானாய் வளர்ந்ததுவோ புதிதாயொரு பூவும் பூக்கையிலே அடை யாரது பறித்ததுவோ உன் கால் தாடும் சென்ற வழி பார்த்து நானும் வந்தேன் அது பாதியில் தொலைந்ததடா ஹோ ஹோ நான் கேட்டது அழகிய நேரங்களோ யார் தந்தது வழிகளில் ஈரங்களோ நான் கேட்டது வானவில் மாயங்களோ யார் தந்தது வழிகளில் காயங்களோ கால் தடும் சென்ற வழி பார்த்து நானும் வந்தேன் அது பாதியில் தொலைந்ததடா மழை வரும் அறிகுறி என் விழிகள் தெரியுதே மனம் என்று நினையுதேன் இது என காதலா சாதலா பழகிய காலங்கள் என் பார்வையில் விரியுதே பாதைகள் நடுவுதேன் இது ஏனோ ஏனோ.
That was Taslina for you guys. Up next on popular demand, back on stage is Nidish from the second year of MBBS. Let's hear it up for him, guys.
தேவதை அவள் ஒரு தேவதை அழகிய பூமுகம் காணவே பூக்களும் பூக்குமோ காற்றிலே அவளது வாசனை அவளிடம் யோசனை கேட்கதான் பூக்களும் பூக்குமோ நெற்றி மேலே ஒற்றை முடியாடும் போது நெஞ்சுக்குள்ளே மின்னல் பூக்கும் பார்வையாளை தூக்கும் கண்ணம் பார்த்தால் முத்தங்களால் தீண்ட தோன்றும் பாதம் ரெண்டும் பார்க்கும் போது கொலுசாய் மாறத் தோன்றும் அழகாய் மனதை பறித்து விட்டாரே செல் செல் அவளிடம் செல் என்றே கால்கள் சொல்லுதடா சொல் சொல் அவளிடம் சொல் என்றே நெஞ்சம் கொல்லுதடா அழகாய் மனதை பறித்து விட்டாளே. விளையாட்டு பேச்சில வெசூசி ஏத்திர நீலேசா பேச மின்னல் கொட்டிடுதே ஒளி பாஞ்ச முகம் மனசோட மோதுதே நீ பேசோ பேச்சு ஐயோ அள்ளிடுதே என்னென்னவோ உன்கிட்ட சொல்லணும் தோணுதடா காதல் வந்தே சட்டுன்னு சொல்லட போடுதடா நாடு நெஞ்சில உன்னோட வாசம் என்ன ஏதேதோ பண்ணுதடி தாங்காத சந்தோஷம் நான் என்ன செய்வேன் புள்ள கண்கள் ஏதோ தேட களவாட நெஞ்சம் தானே பாட பறந்தோட அடி ஒவ்வொரு ராப்பொழுதும் உன அப்படி நான் ரசிச்சேன் உயிர் கொள்ளுது உன் நினப்பு கண்மணியே ஓ ஒரு 1000 வானவில்ல ஓம் பூவிழி காட்டுதடி அது சட்டன நீ மறைச்சா நான் என்ன செய்வேன் புள்ள கண்கள் ஏதோ தேட களவாட நெஞ்சம் தானே பாட பரந்தோட.
Let's hear it for Nidish again, guys. Come on. All right. Up next is a performance by Akshaya from the second year of MBBS. Let's hear it up for her. All right. We'll be giving everybody a chance. Change of plans. Up next is Darshini from the second year of MBBS. Let's hear it up for her. Third year. Okay.
Get disappointed. Okay. Oh, we were just kids when we fell in love, not knowing what it was. I will not give you up this time. Darling, just kiss me slow. Your heart is all lion, and in your eyes, your whole in mine, baby, I'm dancing in the dark with you between my arms, barefoot on the grass, listening to our favorite song. I have faith in what I see. Now I know I have met an angel in person. She looks perfect tonight. ஏழு கடல் தாண்டி உனக்காக வந்தேனே, இந்த நதி வந்து கடல் சேருதே, வெண்ணிலவை வெட்டி மோதிரங்கள் செய்வேனே, அது உன்னை சேர ஒளி வீசுதே. அந்த விண்மீன்கள் தான் எந்தன் கண்ணீனில வந்து குடியேறவே கொஞ்சம் இறங்கேக்குதே. இன்று உன் கையிலே நான் உள் பொம்மைய கூந்தல் போல் மாடுதே. அடி உன் பெண்மையே, ஓஹோ பெண்ணே பெண்ணே, என் கண்ணே கண்ணே, உண்மை சொன்னால் என்ன, உன்னை தந்தால் என்ன, ஓஹோ பெண்ணே பெண்ணே, என் கண்ணே கண்ணே, உண்மை சொன்னால் என்ன, உன்னை தந்தால் என்ன. உன் கைகள் கோர்த்து உன்னோடு போக என் நெஞ்சம் தான் ஏங்குதே, தினம் உயிர் வாங்குதே. உன் தோளில் சாய்ந்து கண்மூடி வாழ என்னுள்ளம் மழை பாயுதே, ஐயோ தடுமாறுதே. உன் கண்ணம் மேலே மழை நீரை போலே முத்த கோலம் போட ஆசை அல்லாடுதே. நீ பேசும் பேச்சு நான் தூரம் கேட்டு எந்த ஜென்மம் தீர ஏக்கம் தள்ளாடுதே. தேங்க்யூ.
Good job, good job, good job. That was a magnificent performance. Give it up for her. Up next is Akshaya from the second year of MBBS.
Yele, yelele, yele, yelele. ஒத்தப்பான மரத்துல சத்த நேரம் மடியில் தலை வச்சு சஞ்சுக்கிற சங்கதிய சொல். வாடி நீ வாடி, பத்து கண்ணு பாலத்துல மேச்சலுக்கு காத்திருக்கேன் பச்சலோட. வாடி புள்ள குச்சங்கிச்சம் தேவையில்ல, வாடி நீ வாடி. ஏலே ஏலேலே செவ்வால நீ சின்ன காணி, ஒன்ன சரையடிக்க போற வாடி. ஐயையோ யா உசுருக்கு கண்ணுக்குள்ள தீய வச்சாயோ என் மனசுக்குள்ள நோய தச்சாயோ சண்டாலி ஓம் பாசத்தால நானும் சுண்டலியான புல்ல நீ கொன்னா கூட குத்தம் இல்ல நீ சொன்ன சாகும் இந்த புல்ல ஐயோ என் வெக்கம் பத்தி வேகுறதே ஐயோ என் சமஞ்ச தேகம் சாஞ்சு போச்சே ஐயோ அரளி வேத வாசக்காரி ஆரக்கொல்லும் பாசக்காரி உடம்பு நெஞ்ச கீரி நீ உள்ள வந்த கெட்டிக்காரி ஐயோ என் இடுப்பு வெட்டி இறங்கி போச்சே ஐயோ என் மீச முறுக்கும் மடங்கி போச்சே ஐயோ கல்லுக்குள்ள தேர போல கலைஞ்சிருக்கும் தாடிக்குள்ள ஒளிஞ்சுக்காவா கால சுத்தம் நலல போல பொட்ட காட்டிலோங்கூடவே தங்கிடவா ஐயனார பார்த்தாலே ஒன்ன நப்பு தாண்டா அம்மிக்கல்லு பூ போல வாடி போச்சு ஏண்டா நான் வாடாமல்லி என போடாலி தொரட்டி கண்ணு கருவாச்சியே நீ தொட்ட அரும்பு கரும்பானதே தொரட்டி கண்ணு கருவாச்சியே நீ தொட்ட அருவா கரும்பானதே சண்டாலி ஓம் பாசத்தால நானும் சுண்டலியான புல்ல நீ கொன்னா கூட குத்தோ இல்ல நீ சொன்ன சாகும் இந்த புல்ல
Let's give her a large round of applause. She presented with so many sitters. All right. With that silence, it's time to bring a bang. Let's hear it for Alan Paul from the third year of MBBS. Come on.
துலா தட்டில் உன்னை வைத்து நிகர் செய்ய பொன்னை வைத்தால் துலாபாரம் தோற்காதோ பேரழகே முகம் பார்த்து பேசும் உன்னை முதல் காதல் சிந்தும் கண்ணை அணைக்காமல் போவேனோ ஆருயிரே நிழல் போல விடாமல் உன்னை தொடர்வேனடி போல படாமல் பட்டு நகர்வேனடி வினா 100 கனாவும் 100 விடை சொல்லடி முன்தினம் பார்த்தேனே பார்த்ததும் தோற்றேனே சல்லடை கண்ணாக உள்ளமும் புண்ணானதே இத்தனை நாளாக உன்னை நான் பாராமல் இங்குதான் போனேனோ நாட்களும் வீணானதே Balloons are deflated. I guess they look lifeless like me. I miss you on your side of the bed. Still got your things here. They stare at me like souvenirs. Don't wanna let you out my head. Just like the day that I met you, the day I thought forever, saying that you love me that'll last forever. It's cold outside. Like when you walk down my life, while you walk on my life, I get like this every time. On these days it feel like you and me. Heartbreak anniversary is I get like this every time. On these days it feel like you and me. Heartbreak anniversary. Do you ever think of me?
All right, everyone. 1, 2, 3. Alan Paul, everybody. Up next, last representative of final year, girls, Sneha with the performance. Let's hear it up for everybody.
महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वशिष्ठवामदेवादिवन्दितमहा एक सूरज निकला था कुछ पारा पिघला था एक आंधी आई थी जब दिल से आह निकली थी दिल से रे दिल से रे दिल से रे दिल से रे பனிவிழும் மலர்வனம் உன் பார்வை ஒருவரம் பனிவிழும் மலர்வனம் உன் பார்வை ஒருவரம் இனிவரும் முனிவரும் தடுமாறும் கனிமரம் இனிவரும் முனிவரும் தடுமாறும் கனிமரம் பனிவிழும் மலர்வனம் மலர்களே மலர்களே இது என கனவா மலைகளே மலைகளே இது என நனவா உருகியதே எனது உள்ளம் பெருகியதே விழி வெள்ளம் விண்ணோடும் நீதான் கண்ணோடும் நீதான் கண்ணோடும் நீதான் மலர்களே மலர்களே இது என கனவா மலைகளே மலைகளே இது என நனவா காதல் சடுகுடுகுடு கண்ணை தொடு தொடு காதல் சடுகுடுகுடு கண்ணை தொடு தொடு அலை சிற்றலை கரை வந்து வந்து போகும் மலை என தொடுவாய் மெதுவாய் படவாய் என்று நுரையாக்கும் மலை தொலைவில் பார்த்தாலாமாம் என்கின்றாய் அருகில் வந்தால் இல்லை என்றாய் நகில 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 ஓ விலகிடா தனகில ஓ நகில 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 ஓ விலகிடா தனகில ஓ பழகும் பொழுதுக்கும் மொழியாகி என்ன வெல்வாய் பெண்ணே படுக்கையாய் குழந்தையாகி என்ன கொள்வாய் கண்ணே காதல் சடுகுடுகு கண்ணை தொடு தொடு. Thank you.
Oh my God, let us hear it for Sneha, everybody. Come on. So many talents under one roof. So beautiful, so elegant, just looking like a wow. That's it, guys. Now we take a chill pill and we wait for our guests. All right? Perfect. Thank you so much. And before I close, kudos to everybody who sang today. Let's hear up for everybody who sang today, everybody. Come on. I think it's time to welcome one more performance. Don't you agree? All right. Up next, we have Aisha from the second year of MBBS with a performance. Let's hear it up for her, guys.
Thank you. I want you guys to sing along with me. So, ஒளியும் ஒளியும் கரண்ட் போனா உலக படிச்சும் ஃபெயிலா போனா எக்ஸ்டர்னல் தான் ஸ்ட்ரிக்டா வந்தா டேக்கிடிசி பாலிசி ஸ்ட்ரெஸ்னால வழுக்க விழுந்தா டேக்கிடிசி பாலிசி ஊர்வசி ஊர்வசி டேக்கிடிசி ஊர்வசி ஊசி போல உடம்பிருந்தா தேவையில்ல ஃபார்மசி வாழ்க்கையில் மெல்லவே வாலிபில் வாழ்க்கையில் வாலிபம் ஒரு ஃபேண்டசி சரிகமே பதனிசே மத்தியோசே that's what we say கேட்டுக்கோ லக்கு கால் கிலோ லாஸ் கால் கிலோ லேபர் கால் கிலோ சேர்த்துக்கோ பக்தி கால் கிலோ ஹோப் கால் கிலோ டேலண்ட் கால் கிலோ எல்லாம் தான் சேர்ந்து கட்டினால் பெரிய பட்டலம் சீக்கிரம் ஆஃப் சக்சஸ் சரிகமே பதனிசே மத்தியோசே that's what we say இந்த இசை சொந்த இசை இம்சையிலே வந்த இசை to be a star we show you how reach for the skies and never never give it up வலிதான் வெற்றி என்ற ரகசியமே. Thank you.
Absolutely. Let me take this moment to welcome our guest faculties from various institutions, the in-house mentors, postgraduates, and our beloved undergraduates to this event. This event is specially curated for you guys, and I'm sure by now you know why. So pull up your socks and get ready for the festivities of today. Well, students, the ultimate aim for all of us is to get to the next stage of life and clear our exams promptly. So to orient us and to give us the 10 commandments to cracking a surgery exam, please put your hands together and help me welcome Dr. Chintamani sir once again to the dais. Please, sir, let's give sir the biggest round of applause.
Good morning, everyone. That's better. Now, I'm actually very happy to be here in the morning. Like yesterday, I'm sure we're looking forward to a great day of academics and lots of fun. Fun and learn should be your attitude, so don't get bored of it. I'm sure you all had your breakfast and you're fresh with very new ideas. So do ask questions like you guys did yesterday. So, what are the various approaches to cracking a surgery exam? This attracts you all, and once again I would like to thank Dr. Alex for having us here. He's the one who's keen on this. Most of you know how to crack an exam. You should prepare for it. You should study hard. So there is no shortcut to making it. So don't think you wouldn't study and I'm giving you some, some kind of a formula to crack it, but that's not what I'm doing. When you talk of 10 commandments, the commandments usually are referred to the ones that Moses brought from Mount Sinai for the good of the Jews. And these are those 10 commandments roughly. And Jews never followed those and they were all over the place. And finally, every time he failed, he came back to the laboratory with the same enthusiasm like you guys have come in the morning today. And his associates will ask him, how can you keep coming back after? You are looking at differently. I found out 10 ways of how not to do it. So that's one way of looking at it. So don't think there is anything called failure in life. I never fail. Either I learn or I succeed. That should be the attitude. So there's no failure. Failure is a negative way to look at it. So I never did anything worth doing by accident, nor did any of my inventions come by accident. They came by work. So work hard. If you don't work hard, you're in the wrong profession. If you don't work hard in the beginning, you'll have to do it later. The amount of work to be put in is just the same. Life has become a little complicated with these MCQs coming in your, day-to-day working, but it is better at the other side. So that's one way of looking at a hill, that there is a valley beyond it. So that is how you should look at it. The first thing is the fear of unknown. I made this talk very generic for the purpose of undergraduates. That is what I tailored it for. 2 roads, you heard this, Robert Frost. He's famous for that, the Forests of the Night. You all read it, and it's a part of the curriculum, like the woods are lovely, dark and deep, I have promises to keep. Miles to go before I sleep, miles to go before I sleep. So similarly, this is a beautiful quote that I use very frequently when I have to teach my students. 2 roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. So if you just do because X has done it, Y has done it, somebody who you know has done it, and you do it for that purpose, I think that's not a great idea. So take the one which is less traveled, less beaten, and you will enjoy it, because you will make that difference. If you stick to what others do or to the beaten path, it's not going to work. So let's move to each commandment, as I call it. First thing is the poor approach to your examination. Yesterday we had wonderful presentation by students, especially the second batch. They looked very confident, very composed. And they would have scored the marks they got yesterday in any exam. So don't worry about whether you are at All India Institute of Medical Sciences, where I have been examining for 20 years, or you are at here, it doesn't matter. With the marks you got yesterday, or you would know soon, are the same you would have got anywhere. So that is good, good performance. Congratulations to you. The first thing that I observed in them was the mindset. They were ready to take on. Let me fail, but I'll do what I can do. And in that process, the mindset makes a difference. So go with a positive mindset. Don't think you're going to fail. It's going to be a bad day for you. No. When you walk into anything, we as surgeons, of course, when you walk into the theater, we go with a very positive mind. Otherwise, there's no way out. And I have it on evidence. The day if you're appearing for an FRCS exam, everybody comes and tells you, this is my 8th attempt, 9th attempt. I had a Pakistani friend who was 9th attempt. So they would come and discourage you. So you start getting depressed. So you don't pass it easily, etc. Then you have to get over it, and that's your own willpower. They took 9 times because they're blighters. I am good, I'll do it today. That's how you should do. The first thing is to be confident. Obviously not without working hard, because if you're foolhardy, that doesn't make sense. The turnout should be good. And I must compliment your faculty for this. I was commenting yesterday also to both Praveen and to Dr. Saha that they have a dress code. The reason for a dress code is the turnout should be uniform. It makes a very poor show of a student who comes in torn jeans with a t-shirt with all sorts of stories written on it and shabbily dressed. He hasn't taken a shower for a couple of days. It doesn't make you a smart medical student. A medical student's turnout should be different. And you will only be respected for how you look initially. And they say you wear your attitude. So if you're from within clean and positive, you will dress up the same way. Otherwise you'll come shabbily dressed. Growing your hair. You're not one loafer film star who's to basically be a loony for 3 hours to entertain you. A doctor's job is very, very serious. There is evidence to show that patients who were treated by doctors, dressed and groomed well, they did better. When you come to the hospital, you run into a doctor, the resident walks in with slippers, I have no disrespect for anyone. I'm just trying to talk to the students, and I'm being very, very honest and fair. Because if I'm diplomatic, politically correct to my students, I will never teach them. I personally think, I have a presentation for teachers also. which in the medical teachers course of the MCI I used to teach. Don't hold back. Tell the truth so that they get better. You cannot hide it. So turnout is mandatory. Always be in your white apron. It's a blessing to be in white apron. If you don't like it, you shouldn't have joined this profession. A lot of people stop wearing it later on. But how do I show off my t-shirt or my jeans or my whatever? That makes no impact. Lack of self-belief and confidence. You'll be surprised that this is applicable to your exam, also to your life. So in general, I'm talking to you, conversing like I should converse with my undergraduate dear colleagues. If you don't have self-belief, the world is going to take you for a joker anyway. Why should they trust you when you don't trust yourself? Isn't that funny? You don't trust yourself, you want the world to trust you. He's an uncertain doctor sitting there who's not clear on his own terms. How is anybody going to give you the respect? First thing first. Yesterday I corrected a few things. No males and females to patients. The gentlemen and ladies. Correct. Males and females is to dogs, cats, he dog, she dog. No. Gentleman, lady. Unless proven otherwise, he's a gentleman. So for you, 50-year gentleman. Don't make 20-year-old, 20-year-old would be not old. So 20-year boy, young man, whatever. So always take, in MRCS exam there is a communication bay, I must share with you. Communication bay is where most Asians fail. Whether it's Indians, Pakistanis, Bangladeshis, they fail in the communication bay. You know why? They are not taught to do it. They learn only for the exam. And when you guys are preparing for a US Assembly, the same thing you do. You prepare for the US Assembly without being that. But if it becomes a part of you, you will be doing it every day. So if I'm talking to you, like I asked somebody yesterday, you get up to ask a question, introduce yourself. In the exam, the first thing that we observe in an MRCS exam is the candidate says to the patient, and we are marking. Good morning, sir, or namaste, my name is this, what is your name? Can I talk to you? Can I examine you? He gives the consent. There's a mark for it. And the second consent is when I'm talking to you, I'll also talk to my examiners. Is that okay with you? He says yes, then you proceed. Introduce yourself wherever you go. Don't be shy of it, because if you're not introducing yourself, it's taken as a rude and impolite behavior. And when you're talking to the patient, don't force a history. Let him speak. And yesterday somebody answered that beautifully, that the best mode of communication is listening. So if you don't listen, it is quite likely that you would miss points. Doesn't it happen when two people are talking? If both are talking, who's listening? The world. And that to a clutter. If you're examining a lady, which we mentioned yesterday also, always have a lady chaperone. Now, there is a very important question asked. Can this be the girl's mother, girl's friend? No. It has to be a nurse, dedicated nurse. We think it is not possible. I work in the largest government institution of the country. It's got 4,000 beds. Teaching students, there is a challenge because there's so much of patient crowd. But even there it could be introduced. It takes a little resistance initially, but it gets sorted. So respect the privacy of the patient. At the same time, even a lady who's examining a male patient needs a male chaperone. It's important. It's not to protect that lady. It's for the patient. You get my point? So it cannot be, okay, you can stand, you're the brother. No. Every patient needs that respect and dignity. We are still with the first commandment. We have just moved in and we are talking to the patient. Impolite gestures. Especially, I don't think it is relevant here, but in winters, say in Delhi, or when you're going to a place in UK, it is very, very important. When you're examining a patient, always warm your hands. Don't start with a cold hand. And cold hand reflects a cold attitude. Cold attitude shows. If you think it won't be seen, it will be seen. The patient should get that warmth out of you. So when you're doing this, patient is happy. It doesn't warm the hell out of you, but It is okay. That's a good gesture. So make that a point. So warm your hands and try to cover the parts you're not examining. Somebody mentioned yesterday, I expose the patient from the nipple to the mid-thigh for hernia examination. Nobody does it. Practically zero. Have you ever seen it being done? Honestly, no. So we are preaching what we don't practice. Why? Because it is not required. It was taught so in the past. If you really need to examine, you can expose that part one by one. The purpose was to tell you that you should examine from there to there. But that doesn't mean you expose, then you go for a cup of coffee, come back, and then start examining. It should not happen. So don't need to unnecessarily expose. These are old schools which are gradually losing thoughts. Somebody asked, even one faculty asked, if you're examining any organ which has got a twin, that is breasts, eyes, limbs, always examine the normal side first. Make that a habit. Unless I know what is normal, how do I know what is abnormal? Common sense. Number two, many women, the texture of the breast is different, individually. You may call it a nodular breast, lumpy breast, but when you compare to the normal side, it is normal for them. So it's important. Don't get angry. Don't lose your shirt on everything. Why are you wasting my time? I have so many things to do. Morning my boss scolded me. And now you are also taking so much time. So you take your anger and frustration out on the patient. Remember, you owe it to your patient. Now what will make you a doctor at the end of the day? You came as 12th pass students, fresh out of school, right? What is going to make you a doctor? Patients and your teachers, faculty. Have respect for them equally. So don't treat them like, this looks shabby and a poor patient. I don't want to see. I'll rather see a clean patient. If they could clean up like you could, then there would be no difference. But a lot of them come from a rural background. They cannot speak a language clearly. They may not smell to your liking. They don't use deodorants. But that should not make you feel, there was a beautiful one act I was discussing with Dr. Shah yesterday. And he was playing the old man, the father of the patient. You could see the more he was grateful, more you were laughing and clapping. Because you believe that why should somebody be so grateful? But they actually are. So if you want to earn that love and respect, what we have lost in the last few years, you need to have that warmth towards your patients. You're dealing with a human being in distress. If you're not kind and compassionate, it's a wrong profession to be in. There's so many better things to do in life. If you wanted to make money, there's the wrong place to be in. You'll put in a lot of effort, you'll get very little. And it happens to a lot of medical students. I've been part of the counseling sessions for the post-graduation. And a lot of them take up specialities where there's no hard work involved, which is white-collar job. Why? Because they think they'll get a lot of money quickly. It is not a profession for making money. If you think you joined it for making money, you will be a sad person, let me assure you. Next is the language barrier and a poor historian. What do you mean by a poor historian? I'll give you must be reading books, and your faculty also must be teaching you. Reproduce the history in the language of the patient. Yes or no? Yes, louder? Now please reproduce what I'm saying. The patient gives this history verbatim in Hindi, local Delhi. He has a lot of wind in his tummy, which climbs up to the thorax, goes up in the neck, and comes out of the right ear. And that is how he's relieved. Translate. You can't. So when these books were written, having worked in UK, I can tell you, they can understand because they created those books in English for the patients there. They are not applicable everywhere. So you can't literally translate it into the patient's words. We know he's talking of some dyspepsia, some retching and some belching. You know, the wind doesn't climb up that way and comes out of the right ear. It doesn't happen. Or he'll give a very funny thing, I just got up, then I bent forward, the pain was relieved by stroking at my back. Now this you can't give as a history. The only thing which is positive here is there was acute pain which was relieved on bending forward. So you're talking about pancreatitis, where the pancreas falls forward, the splanchnic plexus is not irritated, pain is made better. The stroking was extra. So if the patient is not able to give you history as per your textbook, he has not read that book, so don't get angry. Communication skills, you don't have a language barrier when you understand the language, but when you come to North India, you may have it initially when you don't understand the local dialect. Or you go to Bengal, they speak in Bangla. When you come to Tamil Nadu, they speak in Tamil, or wherever. So the language barrier these days is being taken care of by translators. If the patient is taking longer in the exam to answer, don't be angry, right? He can be speaking in his own staccato way, but pick up the words, because many a times the language is telegraphic, like we were talking to our driver in the morning. So it can be telegraphic conversation. Hotel, venue, you just can be. Same thing applies to the patient. Second one, you are now into history taking. And don't examine and take history simultaneously. I gave you the joke, the Scottish joke of digital rectal examination and taking the history of smoking. Do not do that. It's a wrong time to ask. Students in the exam are very anxious. So they want to checklist everything. I didn't take this history, I didn't take that history, I didn't take this history, I didn't. So what would they do? They would want to take it whenever. And his mind is, he's examining the limb, but the mind is in the history. That should not happen. Finish with it. It puts off the patient, especially when the patient is in left lateral position, nobody likes it. And then you miss the finding. What you're examining, you miss. Yesterday I told you this, examine the whole, don't examine the hole in the patient. Examine the whole patient. So when you have a patient with ulcer in the limb, right lower limb, examine the limb as a whole after having examined the normal side. So if I was to teach you the examination of a limb, there's an ulcer on the greater malleolus, medial malleolus. And you know it is looking like a varicose ulcer, but don't start with that ulcer. That's what I'm trying to teach you. Examine the limb as a whole would mean what? The attitude of the limb, the apparent lengthening, shortening, visible scars, sinuses, any swellings, visible dilated veins. Everything is covered now. Then neurovascular deficit, neurological examination of the sensory. We know sensory system is lost first, motors later. So if the sensations are preserved, the patient is fine. Looking for the dermatomes. And you know the dermatomes? Yes? Who's going to answer that? Yes? What are the dermatomes of the lower limb? No, if you don't know, you say you don't know. That's okay. Yes? Start. Anybody? You taught dermatomes, no? Well, part of the neurological examination. So, if you put your hand in your pocket like this, 2, 3, 4, 5 is lateral, S1 you walk on, S2 medially, S3 you sit on. Dermatomes are over. So it's simple for us, if you understand, rather than cram it up. So everything should be complete. So if I have an ulcer on the oral cavity, I will examine the head and neck as a whole, so that I don't miss the lymph nodes, I don't miss the other lesions, I don't miss the mouth opening. Most people start by talking about tongue. Tongue has an ulcer. No. So examine the whole patient. We will discuss that. Now, the chances are that you may examine a lot, but everything is not found there. Present only the limited one. But it is believed, like yesterday you all did very well, nutritionally patient is undernourished. But don't say without doing it. But that doesn't mean you'll start describing the carbohydrates, fats and proteins. You got it? You heard yesterday. You can say, no, patient is moderately nourished, but I will assume that you've already done it. If you start talking about BMI separately, mid-arm circumference separately, triceps fold thickness separately, pallor separately, then it will look all over the place. When you say moderately nourished, averagely built, performance status I taught you yesterday, everything will come out as a question to the examiner. There is no examiner who is not going to ask you, okay, how did you assess nutrition? So you've got a question which you wanted to answer. You must have seen the boxing bouts. The guy who's hitting more is not the winner at the end. The guy who's hitting at the right spots gets the marks. So don't just blabber it out. Each time throw a question when you're answering. And then this is called a great case syndrome. This is general. What is I got a Parkinsonism, or I got a pontine hemorrhage case, or in medicine, or in surgery I got a very complicated obstructive jaundice case. Don't be lost into it. If somebody gives you a diagnosis before your examination, you're bound to fail. Why? Because you are mentally preoccupied with a particular diagnosis. It is like you have a square frame, which is the only thing you have. Now the picture is round. You will stuff it into this because you can't trim it. So be intelligent enough. I gave you the example of this case where this case changed and the student kept on talking about incisional hernia. Patient was inguinal hernia. And the examiner internally is trying to remind him, have a look once, at least once have a look. He says, I have seen 3 times. Because he was so confident about it, because the senior resident or the postgraduate told him the diagnosis. Dangerous. Never do that. If you find the case is very, very complicated, like yesterday there were 2 or 3 presentations, today also there will be one. Become very basic. Your presentation should be very basic. You always pass. Do the basic things right. What we taught you yesterday in general examination, if you make that presentation as general examination was done, you're already 50%. The examiner has decided this student needs to pass. But don't make it very, very complicated. Well, this was important to just highlight. And keeping it simple and safe. I said keeping it simple and stupid. That was the reason. Don't try to think too much in your examination. Let me give a very, very strange differential diagnosis. Very, very strange differential diagnosis. Things that don't even happen, you talk about. Rarest of the rare you want to talk about. Common things common. See, common things are common, rare things are rare. It's simple. So don't try to unnecessarily bring in complicated things. We know that tuberculosis can be seen in any part of the body. It can mimic any condition in this country. Any other disease. Tuberculosis can mimic everything, including pregnancy. It produces amenorrhea and pseudocysis. And the lady thinks she's pregnant. There are no periods, and it's the most common non-physiological cause of amenorrhea in this country. Commonest is pregnancy, of course, and non-physiological is tuberculosis. And then ascites appears, so the tummy is distended, and there is amenorrhea, and they're celebrating, the lady is pregnant, but she's got tuberculosis. So it mimics anything. So if you say tuberculosis in any diagnosis in India, lump of the breast, any lymph node, abdominal conditions, he showed you some beautiful peristalsis yesterday, or otherwise. Tuberculosis can always be one of the causes, because it's so common here. And then tuberculosis has some sisters. The latest one, or the youngest one, is HIV. The older one is diabetes. They coexist. Because immunity, when it's down, makes everybody tubercular. You all have tuberculosis right now, but it's not showing up because your immunity is good. You know, tuberculosis is a part of this endemic world. Amoebiasis is a part of your endemic world, so no problem with that. So don't try to make it very complicated, right? As they say, this is a satire. So making simple things complicated, don't do that. This is something which I teach postgraduates more commonly. When you hear hoofbeats, think horses, not zebras. That's a common tendency. Hoofbeats, when lots of horses are standing here. So you want to say something different. Everybody is saying horses. Let me say zebra. So I'll stand out. So when I say zebra, what would I expect? Oh, the examiner would say he talked of something very, very extinct. Rare. You had it. And if you say horses, you may be wrong sometimes, but generally you'll be right. And at least the common sense would be appreciated. Common sense is extremely uncommon, we know that. But common sense is appreciated. When there is a swelling in the neck, midline, moving on deglutition, center of the neck, you don't know it's mostly thyroid. Don't think of rare things, pretracheal lymph node, which also moves because it is attached to the, the system. Or you have subhyoid bursitis. These are rare conditions. What is the most common cause of swelling in the midline which moves on deglutition? Thyroid. Yesterday, that case, hernia. Most common thing is a groin swelling which appears on cuffing, reduces on its own. What is likely? Which swelling appears on Valsalva, including hernia, and another one? Diagnostic for that condition. You do Valsalva, diagnosis. Anybody? Have you seen a frog croaking? So laryngocele. So as soon as you do Valsalva, it bulges. And you will be able to make a diagnosis. You don't have to waste time even thinking about it. So these are the 4 varieties in which cases would present in your life. Not only surgery, medicine also. So it is applicable to all. I have generalized it because I didn't want to make it totally surgical. A common disease presenting in a common way, horses. No confusion. Example. No rocket science here. Don't try to now say inguinal lymph node. It's possible, but not probable. So when you read your books, having written a few, myself, and the other gentleman who has done the same thing, you write down many, many conditions because that's a compulsion of a book. But they don't happen. It's not that they will happen every day. Actinomycosis for the cause of a lymph node enlargement. We don't have to talk about it. It doesn't happen. A common disease presenting in an uncommon way, like you have amoebiasis presenting with amoeboma in the brain, rare, but it happens, it can happen. Or amoeboma in the cecum with an abscess in the liver, now it is commonly seen because of the immunity going down, but earlier it was rare. So this would be the other possibility. The bottom line is an uncommon disease presenting in an uncommon way. Nobody fails because of it. I can give it to you in writing. If you didn't make a diagnosis, you don't fail. If you didn't examine properly, you fail. If you couldn't discuss the treatment properly, don't fail. So what is the bottom line? Good history, good examination for you. But don't try to complicate it unnecessarily. Answering a question, I am trying to extrapolate a small thing into big things, but this would happen. An uncommon disease presenting in a common way, like you have, somebody talked of Richter's hernia yesterday, and somebody would talk of Litter's hernia, or somebody would talk of right iliac fossa pain due to Michelmer's. What is Michelmer's? What are the causes of right iliac fossa pain? You heard yesterday. One is appendicitis, of course. You can have colitis, cecal typhlitis. You can have ovarian twisting, ovarian cyst. And it can rupture also mid-cycle pain, which can mimic appendicitis classically, because it will have the same features of tenderness, guarding, because there is blood there. And you open up, the moment you find a shattered ovary, you try to clean it off. Don't do a oophorectomy in a hurry, because it could be a young girl. Usually it's in the young girl. And a water lily appendix, as they call it. You've not seen a water lily, but you'll call it a water lily appendix. A normal looking appendix is a water lily appendix. It doesn't look like a water lily flower. It has been given a name. Like you have the clay colored stools. That clay doesn't exist here in India. That kind of white clay is seen at the banks of Thames in London and UK in many parts. But it's not seen here. We keep saying clay colored stools. So the only thing you would say is the color of the stool was discolored or it was undercolored stools. There's no clay colored stool. I've never seen it. So you're trying to say the pigment is missing. Obstructive jaundice, the pigment is not coming. That is what is making simple things easy. This is common. Now we come to fear of the examination, which is persistent in all of us. Everybody fears an examination. Everybody means everybody. And every day you'll walk into your clinic, you're going to appear in the exam. Every patient is your examiner if you're alert. He's examining you for what you know, in a very subtle way. The classical examinations are, sometimes very, very disturbing, annoying, irritating. You lose your confidence. And I told you yesterday, in the initial 5 minutes of your examination, you are a spinal animal. I'm using the spinal creature. Why? Because you don't think. So to be able to speak correctly in those 5 minutes, you need to practice many times. That is why hard work is necessary. If you believe I'm reading it and I'll be able to reproduce it there, it won't happen. It is very similar to somebody coming and singing a beautiful song yesterday. Even singer which is what examination is all about. So should you prepare for part 2 first? No, part 1, which means hard work. Every student, every individual born in this universe is equally special. There's no better student than the other. Please understand this. I have it on evidence. It all depends on how hard you work. It is totally dependent on hard work. It's utter nonsense to say that look at this fellow, he's a gifted one who can do everything. No, that's not true. I believe in it. Everybody is equal and special. But he needs to do that by working hard. So nothing in life is to be feared, it's only to be understood. Marie Curie is my favorite scientist. She's the only scientist who won the Nobel Prize twice. Imagine. And when she died, she and Pierre Curie and Marie Curie, read these stories, they're important. Enough of this WhatsApp crap. If you read these stories, they'll inspire you. They used to collect the pitch blende from the entire village. And the village was throw it as dust. And when they'll collect, everybody will laugh at them. Look at these jokers, they're collecting the garbage. So they were collecting the garbage. In their backyard, they created a space. They reduced their sitting place to almost half a room. They collected this garbage and they'll burn it in the night. And turn by turn, they'll sit and watch for these radium particles to appear. After many days and months, the sparkle, and that she has written about. That sparkle was the sparkle of life. And radium was discovered. And with radium, radiotherapy came. And with radiotherapy, treatment of cancer happened. This is how we evolved. Somebody worked that hard. And both of them would cycle their way to city for their classes. They were teachers, both of them. And finally, when she died of leukemia. And on the bed, when she was dying, in her hand was the particle which caused leukemia actually, radium. She was so much in love with it. So please understand, it is the fear of unknown which makes us absolutely zombies. Nothing is to be feared. If you want to love, don't be scared of God. God fearing is a dangerous term. God loving is good. So don't be afraid of the exam. Now you're presenting your case. Knowing the diagnosis is the surest recipe to failure. I've told you already. It's very common. I gave you the example also. Because what are you doing? You're putting the cart before the horse. Horse is wisdom, cart is information. You people today are living in an era of information. There's an information boom. You want an information on anything. You just got to click a button. Is it good? Good, all right. Terrible for somebody who doesn't have the wisdom to analyze. Suddenly you read about, you get these questions from the patients. They walk in with a PET scan. I've got this spot here. Could this be cancer? If you scan 100 people here, they'll all have a spot. Because it's just a metabolic activity. It is not cancer. So all that glitters is not cancer. Tuberculosis will light it up. Inflammation would light it up. Trauma would light it up in a PET scan. So what I'm saying is, information is dangerous also. It's a double-edged sword. Today when your teacher is teaching you something based on his experience, you're opening up your mobile to check. You're doing the wrong thing. Dr. Google cannot teach you this. Information has a problem. And sadly, the training and teaching has shifted to all virtual world. My own student is a part of Marrow, and he is very scared of meeting me whenever he comes. Because he wants to avoid me, because I'll not tolerate it. Because teaching should happen bedside. That's why it's called clinical. It's a Greek word. Clinical means bedside. You can't learn medicine or surgery or any clinical thing sitting at home. If you think you can, then you will not be learning anything. Don't put the cart before the horse. Horse is wisdom. Even if you have less information, with experience and with more wisdom, you can use it better. If you have more information but no wisdom, it's a loaded cart and a poor horse. Then you will be flogging it for no good reason, which is what you do to yourself. You're cracking your MCQs, and therefore don't worry what your NEET rank was, because I think I'll give you the last year's postgraduates. The 4 postgraduates, all of them were less than 10 rank. All 4 of them had no clue of clinical work. There was one who joined later on. His rank was 3,000. He is my best postgraduate. Because these exams have taken the understanding out of people. You're just cracking one after the other. One coaching, then the next, then the next, then the next. Finally, you'll have to take coaching for living also. And sadly, I'm giving you coaching for how to appear in the exam also. You should know yourself. But this is to be done. So don't put the cart before the horse. Wisdom is more important. Don't just be loaded with information. For everything, just don't keep on scribbling. You will not remember this. You'll only remember the story and a part of it. There was a class that he was taking, and it was SECON. I'll divert a little bit. That's my habit when I'm talking to my students, so please don't mind my saying it. So this student of mine takes me to, he says, I need 10 minutes from you, sir. My all students have gathered, so I need to make you talk to them. And he was beginning in this career of coaching, teaching, whatever you call it. So I said, I'm busy. SECON was happening in Gurgaon. I was involved in the scientific program. So I said, I'll not get time. He says, no, you come. I'll take you, drop you back. So he took me, and I thought there'll be 15, 20 students. I walked in, and it was a sea of students. And I said, what do you want? He said, sir, we kept a session, stump the chair. You remember you used to keep it when we started MedSecon in our college. I started it in 2003, undergraduate conference, the first conference of its kind, which was, I seen it at the Royal College happening, which the conference happened in Egypt, so I wanted to do it for my undergraduates. The MedSecon is a very successful conference. It happens every year. You must attend it next time. So, I said, yes, stump the chair means there is a chair there. The professor sits. You can ask any question. I said, yes, I kept that session. So one student got up and said, sir, Rohan sir says that my sir remembers everything. How do you remember everything? I'll come to the point. I said, no, he's lying. I don't remember everything. He's doing it because he's my student. And he loves me as much as I love him. So he's doing it for his mentor. That every student does. They love their teacher. They should. I said, no, I don't remember everything. Rohan gets up and says, sir, but you know I never tell a lie. I know. I said, but this is not true. He said, but I know you remember everything. I said, no, please sit down. I said, I don't remember everything, but I don't forget anything. And that's the difference. I'm not trying to talk about me. I want to teach you something. I saw Ben-Hur, which is the best movie I've ever seen, probably the best made. When I was in school, we were taken from school to this movie. It's a 5-hour movie. The story of Judah Ben-Hur. Jesus Christ story there. Beautiful movie. Very, very well made. And I saw a movie which was on making of Ben-Hur. Can you believe it? The best part of that movie is the chariot race which happens towards the end, that Judah Ben-Hur wins. And that was shot first. But when you see the movie, it's at the end. Correct? I can tell you each part of that movie anytime. So can you when you watch a movie. So how is it that you remember the movie entirely and you don't remember a lecture? Simple question. Is it very complicated? Question is simple. Ask yourself. The answer is, you were there in the movie, but you were not there in the lecture. So be where you are. If you've gone out to freak out, freak out. Don't think of the college. When in the college, be in the college. So the surest way not to forget is to be there. That's it. So if you've come here for the CME, be here. Don't wait for that chip to raise an alarm. If you want to sleep, go to the room and sleep. I have never taken attendance in my class, ever. I hate it. And when my director called me 3 times that MCI needs it, when it started, I said, I don't care. It's an insult to the student and to the teacher. If 10 people want to attend it, let 10 attend. What's the problem? I'm forcing people to sit. I'm not trying to challenge it. What I'm saying is, it doesn't work that way. Only when you want to be there, you should be there. But be there. Then you will remember. Because you will not forget. Similarly, when you answered the performance status question, it was linked to your understanding. Link it to a story. And also remember that somebody came and talked about it. And you link it, and my next person was my friend sitting next to me. Make a story out of your learning. I hope I'm making sense. Otherwise, this is a very, very boring, terribly boring field, where you'll see sick and tired people all through, more doctors than patients. Doctors are very, very angry people. They're angry because they're unhappy. So if you're angry with your patient, basically you're unhappy. Shouldn't be. Now you talked about positive and negative history yesterday. Negative history, there's no such term as negative history. So don't say the positive history is this, negative history is this. You just mention it as you go along. And remember, positive history is what patient tells you, and negative history is what you are asking. So naturally there is a difference. When the patient tells you something, it is positive history. Like, patient says, I had pain in the right hypochondrium or right upper abdomen associated with mild bit of loss of appetite, vomiting, and then you will ask specific questions. Did it happen immediately after taking meals? No, after half an hour. Okay. What did you take out in vomiting? So you'll bring out a negative history. Negative history is, if you ask me, I'll mark a student more for the negative history than for the positive history. But positive history is what patient told you. What's the big deal? You're telling me what somebody told you. And negative history is, but he did not have this, he did not have that, he did not have hematemesis, he did not have constipation, he did not have distension, he did not have anything, he did not have yellowish discoloration. What does that mean? You ask those questions. So negative history is very important. There's nothing like, sir, the positive history is this, negative history is this. No. It comes with the same description, vomiting. Patient had vomiting. We asked you a question. Was it every day? Every time? You should have asked that. It was off and on. It followed an act of intake of meals. It came 1 hour later. And sometimes it contained yesterday's meal, which is what you mentioned yesterday. It makes sense. And negative history would be, there was no hematemesis, sir. Don't say at the end. Finish it here. So don't try to keep it segregated. They've been divided to make it easier. Second thing you heard yesterday, family history. It was brought out, but I'll make it even broader for you so that you understand. Family history, why do you want to know about the family? That is family history. You don't want to know the family history for the sake of it. or how rich the person is. The family history is he's the Ambani's son. Okay. Now you sit down, I have to make some money out of you. That's not why you want to know family history. Technically, clinically, you want to know the family history to make a diagnosis. The whole purpose of history and examination is making a diagnosis. So can it help me make a diagnosis? Yes. Certain conditions are familial, genetic and hereditary. They're different. Certain conditions are not, as of now. When I was training and when I was studying, breast cancer was not considered a genetic or familial problem. In fact, the patient would ask me, my daughter is getting married, I had breast cancer, what are her chances of getting breast cancer? No chances. Cancer doesn't go in families. How wrong I was then. So when you're taking a family history, don't say no similar complaints in the family. You're not yet arrived at these complaints, so you want to rule it out. No, family history is direct. Like they presented yesterday. No family history of, when you're saying gastric outlet obstruction, you're talking of cancer of the stomach or something around it, and you thought of it as a malignant cause. Let's talk of malignancies that coexist. Breast cancer, you want to take history of BRCA1, BRCA2 related cancers and say it. And don't worry about it. How can I say BRCA1, BRCA2? Yes, you will say. So no history of BRCA1, BRCA2 related cancers. Why? The next question will come. What are those cancers? You know, BRCA1 will have breast, ovarian. BRCA2 will have male breast cancer, pancreatic cancer, colorectal cancer. So all these histories become important. Family history is very important. In hernia, when you talk about family history, unless you talk of some specific collagen disorders, not relevant. And prune belly was what we discussed yesterday. So be specific. The father getting a writing while hernia doesn't make his son get it. So there is no family history which is relevant. As of now, at least now we don't know. So that's important. So don't make it into a run-of-the-mill. Then you should know high-risk family history. When does it become relevant? What is a high-risk family history? Can anybody answer that? Yes, you're a bright girl. Can somebody pass her a mic? She speaks very softly. See, I've covered up for you. Start shouting.
Sir, good morning, sir.
Good morning.
Sir, what I think is high-risk family is maybe in cases like endemic goiter or some cases where there is a high risk that the family member could also have that same problem.
One lesson. When you don't know the answer, always say, I don't know. You know, by giving those vague answers, you're saying two things. One, you're telling the examiner, you are a blighter, I can get away with whatever. Most times it can happen, but it's taken negatively. That's not what family history is. Family history has got nothing to do with endemicity. Endemicity is a different history. High-risk family history is when the chances of that cancer coming down are high. And remember, in general, most genetic or hereditary cancers occur in younger age. Do you know why? Try something.
Because it is genetically transmitted.
So I just now gave you a lesson, but
I don't know.
you're persisting. And I tried my hand at it. You know what? It is believed that dysgenesis or oncogenesis has started in utero. And the time it takes to show up is the aggressiveness of the disease. Most genetic cancers occur in a younger age group. So you take a family history of breast cancer, what age did the mother get it or whosoever got it? If it is around 80 years, that's unlikely family history. It's not strong. But she got it when she was 40. Strong probability. So younger age makes it a higher risk. One example I gave you. So you remember that. You mentioned about personal history yesterday. Beautifully done. So I won't waste time. So don't say personal history. Please sit down. Personal history is not vague. They were clear yesterday. So I hope all of you have been taught so well. And I must compliment your teachers for your presentations yesterday. So, but essentially 4 points. The diet, that is appetite. Sleep, which is state of mind, basically. The bowel bladder and addictions. Interestingly, the main complaint of the patient was melena. And if she says the bowel habits are normal, It's contradictory. If the patient is moderately nourished, but then you say pallor positive, it's contradictory, because no patient with anemia is moderately nourished, he's undernourished. So don't use those terms loosely. I'm coming to the sixth one. There are 4 more, so I'll finish faster. General physical examinations, I think we covered it yesterday. I won't waste time at all. It is mandatory to mention performance status, nutritional status, hydration status, which you learned yesterday. So I won't waste time there. And then stigmas of liver disease in a jaundice patient. When you had a patient of jaundice yesterday discussion, in general examination, don't be run of the mill. Everywhere, don't use the same general examination. Low clubbing colonychia, cyanosis, icterus, etc., etc., etc. If a patient has got obstructive jaundice or liver disorder, surgery or medicine doesn't matter. Mention the stigmas of liver disease. What are those stigmas? You want to answer? No, if you don't know, say you don't know, so that we can move on. Anybody here? It's not that we are not asking you. It takes a while to reach here, and you people don't get up. All the gentlemen are this side. Anybody? Yes, first one. Let's talk of some stigmas of liver disease. Quickly.
Good morning, sir. I'm Arun from final year.
Great.
Alopecia, then parotid swelling.
Good.
Gynecomastia.
Good.
Then atrophy of breast in females.
Good.
Spider navy.
Good.
Palmar erythema.
Good.
Testicular.
Why didn't you speak earlier? You know jungle babblers, the birds? I do wildlife photography. And I taught Rohan also to do it. He does a lot of it. Jungle babblers are 7 sisters. 7 of them always will come together. How they'll start. Alone they don't start. Yes, you're doing fine.
So, Dupuytren contracture.
Correct?
Then testicular atrophy.
Testicular atrophy. Pedal edema. Round of applause. Excellent. So, won't it be a shame if he is presenting a case of obstructive jaundice and he knows the stigmas of liver disease but does not mention them? So, use it. I've given one example. Certain diseases have those stigmas, which if you mention, you said no stigmas of liver disease. Don't start rattling out. Then the examiner will ask you, what are those? Starting from the head alopecia or texture changing, bilateral parotid swelling. Keep coming down. Gynecomastia, palmar erythema, Dupuytren's contracture, clubbing. Right? Then ascites, caput medusae, testicular atrophy, pedal edema. We're done. Remember it to mentions, to score marks. This is what I was trying to teach you. So it is important, especially don't say that in a hernia patient. Where are you? Right? Otherwise, that will be the same thing, putting a round thing in a square. And when you're doing general physical examination, highlight the points, which I have discussed already. When you're doing systemic examination, you watched beautiful videos on abdomen examination, head and neck. I'll just quickly take it if we get a time today. Don't stand too close for head and neck swellings. First examine from a distance, then from close. This is what I teach my students. Many a times you'll see a thyroid swelling, only one lobe is enlarged when you're too close. You go a little far, from a distance, ask the patient to swallow, you'll see the other swelling. I do it every day. If you watch my YouTube videos, I've got those students standing and I'm asking them to do it. It's live. We don't create a situation. It's not a one-act play. That they are happening, wild classes, wild rounds. They're all wild. Nothing is planned. So the bullshitting is also wild. Everything is natural. We don't conserve it because that's how you should perceive it. Watch it from a day, like looking at the panoramic view of mountains. You see a big profile. You get very close or too close for comfort, you see a piece of rock only. So examine from a distance first, then get close, especially when you're doing the examination of the head and neck. And most of you, when you're doing the examination for the thyroid toxicity, which you'll be taught, I won't waste time at all, you do the mistake of not describing that I examined the patient in a sitting position, with you sitting in front, eyeball to eyeball. and the distance being 60 centimeters. Important. And don't bring in fingers like this, like this, like this. You see, the problem is something that he was also mentioning yesterday. You get to hear different things from different people, so there are different ways of doing the same thing. There are 100 ways to Rome, as long as you reach Rome and you reach alive. It's important. Do not just believe that this is the only way. This is one correct way of doing it. When you're examining the abdomen, no, I'm not wasting time. The eyes should be at the level of the abdomen. You can examine from the foot end or from the one side. Foot end has an advantage because you can see both sides in one go, but you can come to the bedside. Describe the normal side first. Knee-elbow position is mentioned here to be condemned. Right? No knee-elbow, it's disappeared, it's no longer used. Too cruel to the patient, very embarrassing, and the findings are very limited. So you're causing too much of discomfort for a little gain. Now discussing the case is the last part. Always summarize, and you heard yesterday, you summarized it in one paragraph. You can't. You've spoken all this story, that was yesterday. Summarize with important points, bullet it to score more. These are the points, like yesterday's case, 62-year gentleman with features of gastric outlet obstruction. Don't waste time, now you already mentioned it. Features suggestive of gastric outlet obstruction, probably malignant on account of significant loss of weight and appetite, associated vomiting which is non-projectile, and there are, in abdominal examination, these are the features. Visible peristalsis left to right, the span on ausculto percussion is this. Those things you've already described. Summarize your case before you give the diagnosis. And when you give the diagnosis, you should be careful. Do not give a diagnosis that your registrar told you. Most of the time they do the same mistakes. So they are not special. So they read the case sheet and tell you the diagnosis. Same thing, prostate case 15 one you take. He takes the 15 one, the bed has changed. You keep talking about prostate, incisional hernia, that case has changed. And fitting the square painting into a round frame is a common term that I use. Don't be over flexible. When he's trying to help you, he may be trying to, like I did yesterday, I demonstrated, the long rope is not always for climbing back from the hole. It could also be for hanging. So be careful. Be flexible, but don't agree on anything. I'll give you an example. You're examining an abdominal lump. You call it intraperitoneal. And now you're giving a differential diagnosis. You give a differential diagnosis of all lumps in that region. You say stomach, what do you go? Lesser sac, that is pseudocyst, then para-aortic lymph nodes, aortic aneurysm, but you're wrong. Your swelling is intraperitoneal. So the differential diagnosis has to be an intraperitoneal lump, because you're failing at the very point. Common mistake. If you decided it's a retroperitoneal swelling, the differential for a retroperitoneal swelling is another retroperitoneal swelling, and vice versa. So that is important. So compare apples to apples and be careful in giving those differentials. And don't try to give a laundry list of differentials. Anything and everything, that's not differential. Couple of differentials, that's all. Unless you're really, really, really lost. Apples to apples, like gastric lump, you can give a differential. People giving a differential of transverse colon, pseudocyst of pancreas, retroperitoneal lymph nodes, it doesn't work. Now you're into the management, last two slides. Investigations, I've already taught you this. Investigation should not be all over the place. Somebody said routine investigation. Routine in one setup is different from the routine in another. So what did we teach yesterday? What did we agree on? How do you describe or classify your investigations? So, to confirm, to support, to stage if it is a cancer. You can't stage a hernia. Stage and then to treat. Give her a round of applause for repeating. If you have a patient with obstructive jaundice, you can easily say, I'll first get a diagnosis of jaundice corrected. Yes, serum bill. Nobody's saying you won't do routine. But I have seen it happen. When you mention urine, the examiner is asking about blood. When you mention blood, the examiner is asking about CT. Then when you talk about CT, the examiner is asking about ultrasound. And if you say ultrasound also, they get upset sometimes. Then your answer should be, if I were you, so I would like to confirm do investigations to confirm my diagnosis, to support my diagnosis, to stage a disease if it is a cancer, and to treat the patient. To confirm my diagnosis, I'll do extension of clinical examination, which is ultrasound. He says, oh, so the student knows about both things. It's now considered an extension of clinical examination. It is, I can see the stethoscope. It's an extension, it's a stethoscope for a surgeon. We use ultrasound in every case. And in general, everywhere, we do our own thyroid ultrasounds. I do my own breast ultrasounds. I do my clipping myself of the lump. I'm doing my ultrasounds myself. So it is a part of clinical examination. And do you know, AJCC 8th edition for staging of cancer, for breast cancer, clinical examination of axilla is incomplete without ultrasound. So if you say N1 disease or N0, you've done it after ultrasound. So it's mandatory. Not me or you. You have to follow the guidelines. That's how you go. Lastly, when you're discussing the case, don't start with the controversy. Discuss basic things. Sir, first of all, if it is a cancer, you would not treat yourself and nobody is asking you to treat. You're presenting the case in the exam, and suppose you're an undergraduate or even a postgraduate, you will discuss the case in an MDT. This is a standard drill world over. An undergraduate student, I will go as a visiting to some universities in UK, and they are able to understand this because they do it regularly. So where do you discuss cases? MDT. What is an MDT? Yes. No, if you don't know, it's all right. No shame in it. Anybody? Multidisciplinary team meetings. No decision is taken by individuals. You can't sit in the surgery OPD and take a decision about everything. So it involves medical oncologists, surgical oncologists, radiation oncologist, breast nurse or head and neck nurse. So it's become that way. So are you doing it? That is not important. Do you know about it? Important. So you should know how it is practiced. And when you talk about PET scan in your institute, when you don't have a PET scan, don't say it. Examiners also work in institutions where these things may not be available at the drop of a hat. So discuss basic things. When you're saying, I'll do an inexpensive, non-invasive test first, I taught you yesterday, non-invasive is always first. Invasive, always second. Number 2, anything that you have to do in the knee or anywhere else, it is active examination first, passive later. How? I'll ask the patient to bend his knee so that he can avoid the painful part. You don't start bending the knee. I'll ask the patient to reduce the hernia himself if he can. There is no mark for doing it yourself. Texas, you don't score any marks because it will be less painful for the patient. Non-invasive first so that you don't invade without finding. Suppose you do, your diagnosis was gastric outlet obstruction, but the cause of obstruction is lymph nodes outside. You put in an endoscope, you find nothing there. So you need to do non-invasive test first to know where is the organ which is involved. Same thing to colonoscopy. You think it's a colonic growth, but it's a gist, or it's a tumor which is pressing on colon, or it's a retroperitoneal tumor, whatever, I'm giving examples. And you put in a colonoscope right up there, imagine. And then you suddenly realize, oh, I should have done an ultrasound to know at least it is in the colon. So non-invasive first. Any other reason why you should do the imaging first before you put in a needle? Any student would like to answer that? I'll close with that. So, anybody? Quick. Why imaging before putting in a needle?
So, sir, in case of breast cancer, if
I heard that first part. I heard. You can go on. Huh.
So, when we are looking into an radiology, it will show some hematoma or
You see, the problem is artifacts. you will create a hematoma, which is correct. It will give a different picture. So don't put in a needle before you've seen. And do you know one more thing, since you answered well, so I'll give you something extra. These days, blind FNACs, core needle biopsies are out. It has to be guided. Why? This is one reason. Any other? If I was to do a FNAC of this class to know the standard of performance, I'll send a pulley from top, pick up one person, take him out, check him, put him back. That is FNAC. It has a failure rate, false negative rate, so many, because I could have picked up one wrong student. I'll not take one person, I'll take 10 of you. So my chances of false negative are less, or false positive are less. Correct?
Yes.
If I have an ultrasound or an imaging to see, camera to see, then I'll pick up 10 properly. So that's the advantage. It gives you a better yield. You don't hit a cystic area. So when the tumor has an area where there's degeneration, that's dead tissue. You take that out, you find no report. But on imaging, I can see no solid part, which is where the cancer is. So guided is preferred. Before that, imaging before you put in a needle to prevent any artifacts from developing. Well answered. Very good. Brilliant. Third point is, very, very important. I said don't describe the stigmas of liver disease at one go. I'm talking about brass tacks. You're sitting in the exam. He's examining. He's asked you a question. Don't say more than what he has asked. This is what is common. Why? Before you forget, you say everything. That's a normal tendency. But let me speak out everything that I know, warm it out before I forget, so that he can adjust wherever he wants. That's a poor way to answer. Like yesterday, I corrected you. My question was, so why do you think it's a malignant cause? It's a malignant cause, sir, because patient has lost appetite, weight significantly, and then there is a lump, then there is stop. So we changed it. Points in history and points on examination. One question answered. Okay. Tell us the points in history. Points in history answered. Silent. Points on examination. 4 questions covered. 100 out of 100. Similarly, so the patient has a performance status of 90 Karnofsky. Keep quiet. Don't start saying that because this is performance status of 80 Karnofsky. So what is 80? So 80 is this. What is 90? This. What is 70? 4 questions covered. So intelligent students answer precisely. And with each question, they leave a question, which they know the answer of. So it's an examination art. And wherever you go, answer that question with that precision. And the last part, I told you yesterday, small bites, small mistakes. In surgery, I teach on the table. So when you're using the scissors or diathermy, small cuts. Even if you've gone wrong, you can recorrect. And also 2 one-liners for you in practice in surgery. See what you cut and cut what you see. Because if you don't see what you're cutting, disasters, you see the hysterectomy happening and the urine coming out, ureter, gallbladder being dissected, CBD. So see only what you cut, what you see, and see what you cut. Similarly, tie what you see and see what you tie. You won't tie the ureter wrong. You won't tie. So these 2 one-liners you can actually note down. They're useful. See what you cut and cut what you see. Don't cut it unless you see it clearly. That is why they've created these triangles of safety, or the critical view of safety for cholecystectomy. All these things have been evolved basically to make it simple so that you're able to see. What is not seen is damaged. When we are training to be surgeons, thyroid surgeons would teach you, don't do total thyroidectomy. Don't try to see recurrent laryngeal nerve. Don't try to see external laryngeal nerve. You watch my videos, I've described it there. Parathyroids there. Don't see, you will damage them. No. If you don't see them, you will damage them. So not seen is damaged now. Earlier it was, the concept was, don't go there. Seen is damaged. Now, what is the take home? Not seen is damaged. To believe that, the world is, it's like closing your eyes. And remember, always is always wrong, and never is never right in life. In surgery, surely. In life. So don't ever say, it is always done this way. Wrong. We change every day. So there's no always in science. And there's no never. Never say never. To conclude, life, success or failure, a beautiful quote. I believe in it. So don't judge a person by the position where he has reached, but by the obstacles he has overtaken. I tell this to my students, especially in my college. With a huge volume of patients coming, we have the largest, arguably the largest in Asia. But they may not be interested. While somebody working in a remote corner in backwaters could be struggling to find cases. He is working hard to reach somewhere. So you judge a person and his success by the obstacles which he has overcome. Importantly, enjoy these obstacles. Each hurdle, what you call as hurdle, is a beautiful way to jump higher. That is why it's first prof, second prof, third prof, MS, MCH, FRCS. You keep going. The notch keeps going higher. And do you know, at some point in time, you start enjoying it. Because that's what makes you stronger each time. And that is what you should be looking at. Thank you very much. If there are any questions, I will be happy to answer. Maybe one or two. Anybody? Please ask questions. Make it a habit. You all would be able to learn from each other's mistakes too. Life is too short to learn only from your own mistakes. Learn from others' mistakes too. Thank you.
Thank you so much, sir, for sharing those tips and tricks for managing our finals. I really hope our exam goers make the best use of this session. Thank you once again, sir. Now we welcome amidst us Dr. Elizabeth Ma'am, Professor, Head Department of Pediatrics SMIMS, Dr. Suresh M.K., Professor, Head Department of Medicine, Dr. Nagendran, Professor, Head Department of Biochemistry, Dr. Vijay Kumar, Professor, Department of Pediatrics, Dr. Selvaraj Sir, Professor, Department of General Medicine, Dr. Krishnangutti, Professor, Department of General Medicine, Dr. Tilagar, Professor, Department of General Medicine, Dr. Mohan Dasa, Professor, Department of General Medicine. Also, Dr. Kishore, Professor, Department of Ophthalmology. May I now request Dr. Elizabeth Ma'am to kindly share her thoughts on this gathering.
Very good morning, respected professors, our guest speaker, Professor Dr. Chindamani, and dear students. I really enjoyed every moment of what sir was telling. It was like, we can call it like a summary of all our smart we have seen. That is, this is all to crack the exam and to become sharper in our professional life. And every tip sir has said, and most of it we enjoyed, and these are some of the examples we also say. And like when students come, I used to say, there is a quote, you must read the preface of every book and then the index. If you know everything, don't read the book. If you don't know, read in between. So if you take the preface of one book, it is written, Please save me from those who put science before art. Who said it? And most of the classes I get answer from at least one student. That is what sir was trying to tell. Don't put the cart before the horse. And always and never. And so many tips we got. We are very thankful to you, sir, and for sharing all your wisdom within the short span of time and enlightening all the faculty as well as the students present here. I have one question too, sir. That is, sir, you said when you examine a female patient or a male patient, a female patient, somebody should be there. But usually we keep the nurse, instead of the nurse, we keep the bystander. But is it better to have less litigations? Because nurse is part of our system. I would like to have some little clarification on that, or your wisdom or your experience. Thank you very much for this great opportunity. Kudos to the surgery team. Give them a big hand. Thank you.
Answering the question, I think it's a very good question. That's why I thought I'll take some time out and answer. One is the bystander. You know, legally, you're supposed to get a chaperone now. They ruled it out because it could be a planned, scenario. You can fake it out. That's what they say. And especially with ladies, it's common. Breast cancer, I can tell you more. The decision about mastectomy or breast conservation is mostly taken by the family, which is a tragedy. If you talk to the lady alone in the presence of a breast nurse, the answers are different. We have done a study on that. They are able to speak their mind out, heart out. They don't do that in presence of their mother-in-law, sister-in-law, or even a friend, because they get confused. Legally, you are supposed to get the officer or the person from your place. Your question is very valid, that you may have your own team, one person standing, and there could be a bias. So to neutralize that bias, they want the breast nurse who's authorized to stand by all cases in cases of ladies. As far as the men are concerned, especially since the majority are lady students, when you're examining a male patient, always get your colleague or a male chaperone to stand. It's very important. Gradually it is becoming a challenge. It may be either way that you have a problem. So legally, that's what the law. Both have their good things and bad things. Sometimes the patient is insisting, I want my mother to stand. Definitely. Now you are lost actually. So I'll have both of them standing.
Thank you, sir. Thank you, ma'am. May I now extend my invitation to Dr. Suresh, sir, to kindly address this gathering. Please, sir.
Thank you. So, actually, I haven't heard sir's talk fully. So, what I have heard is very much less. But how beautifully he has narrated how to tackle the examination is very important. Our final aim is whatever tips are there, just passing in the examination is our concern. And so that is our main concern. So from process we have to, they are the giant process. Some process we have to find some tips. Tips will be there. So but final aim is by any means you have to pass. So that is the examiner is having some ego because he is the most important person on that particular day. So you have to be very much humble. So your aim is to pass. Thank you.
Thank you, sir. May I now extend my invitation to Dr. Nagendran, sir, to kindly address this gathering.
So, good morning to all. Morning. So it's a very useful topic by Dr. Sindhamani. So I refresh myself from my own days. So it's very useful for me also, for you also, for the examination point of view. So make use of it and get your pass. Thank you.
Thank you, sir. All right, everyone. Up next is a short recess. All of you are expected to be back in the auditorium by 11:10. So all of you know the drill. Go. See you all soon. Thank you.
Let us give Ital a huge round of applause for that absolutely wonderful performance. Everyone, it's time to go back into the session. Every condition a patient presents with requires diligence and efficiency while treating them. But you also need to give a slight attention to the patient who may have a chance of varying thyroid levels. But how are you going to identify, manage and treat these cases? Well, don't worry. To give us all a refresher course once again on the topic, approach to thyrotoxicosis, put your hands together and help me welcome Dr. Makan Lal Saha sir, Professor and Head, Department of General Surgery, IPGMER, SSKM Hospital, Kolkata. Handing over the reins to you, sir. Let us welcome sir with a huge round of applause.
Good morning. I'll be skipping first through the small video clips of how do you do a thyroid examination. I'll skip the history part and then a outline for approach to patient with thyrotoxicosis. So I'm not going into the details of how do you take a history of thyroid because you have a case for examination and basically most of the patient presents with a thyroid swelling and need to ask questions to find out the detailed history of the swelling. And next is the patient of thyroid disease, you should ask some questions. And by asking this question, you can make out whether the patient has got any symptoms of hyper or hypothyroidism. If you suspect it's a malignancy, you should ask questions to find out whether this patient has got any symptom which will suggest distant metastasis. So they are the basic outline for taking history in a patient of thyroid swelling. The swelling which are large or malignant can cause compression of underlying structures, which thyroid swelling. You ask the patient to sit and you sit at the same level. You start examining from the side and then come to the front. So while doing the inspection, you look at the swelling and there are some points in inspection you should make out by examining the patient. So what are the things you look for an inspection? The first thing to assess is the swelling. You look at the swelling and try to assess the position and extent of the swelling. There is a region in the neck we call as thyroid region. This region is bounded on either side by the sternocleidomastoid, below by the suprasternal notch, and above by the thyroid cartilage. So this region is described as thyroid region. Any swelling in this region to be taken as a thyroid swelling unless proved otherwise. So your basic idea is to describe the position and extent of the swelling, and in extent you see how far the swelling is going in relation to sternomastoid, in relation to suprasternal notch, in relation to thyroid. So again, look at the patient. A typical thyroid swelling involving both lobes is a butterfly shaped swelling, because you have a swelling in the midline, which is isthmus, you have swelling on either lobes of the thyroid gland, and the typical thyroid swelling is butterfly shaped. On inspection, you make out approximately what might be the dimension of the area of isthmus. Isthmus is the area which is overlying the rings of trachea, and the lobes are on either side, extending below up to the sternoclavicular joint, and above up to the level of upper border of thyroid cartilage. So that is how you describe the extent of the swelling. And ask the patient to swallow. This swelling moves up and down with deglutition. Once you find a swelling which is butterfly shaped and ask the patient to swallow, swelling moves up with deglutition, this is to be considered as a thyroid swelling. And try to describe the dimension of the area of isthmus and dimension of each of the lobes. Instead of asking the patient to swallow, it is better that you give a glass of water to the patient and ask him to sip that water. Once you sip that water, you can easily see that this swelling moves up with deglutition. So that is a better way of asking the patient. Instead of just asking him to swallow, give a glass of water and ask him to sip a little amount of water. You can see the swelling moves with deglutition. Once you have confirmed that this is a swelling situated in thyroid region, you have assessed the dimension of the swelling, you have assessed that swelling moves up with deglutition, you now try to assess on inspection how is the surface. Some thyroid swelling surface may be smooth, like in Graves' disease. In some patient with a multinuclear goiter, the surface may appear uneven. Most of the thyroid swelling, we find the margins are well defined and rounded. So look at the thyroid swelling and then comment about the swelling surface and the margin. After this, you look at the area of the thyroid region where the swelling is and comment about the skin. In patient having thyroid disease which is causing obstruction of the thoracic inlet, can have engorged veins running over the thyroid swelling. If the patient has underwent some other surgery earlier, there may be scar or there may be some other pigmentation. So next comes the palpation. There are clear methods of thyroid palpation. In the exam, you ask, you palpate the thyroid gland. So you have to follow a correct method of palpating the thyroid gland, or you may be asked to demonstrate some of the points in palpation of the thyroid gland. So for any swelling, as you start, the examination starts with assessing the temperature of the swelling and looking for tenderness. So the next thing you do, so how do you assess temperature? So you are sitting in front of the patient at the same level and you just palpate the surface of the thyroid gland on either side and compare with the temperature other part of the body. In patient with thyroidochrosis, the gland is very vascular. The gland area may appear warmer than the rest of the thing. And then to assess for tenderness, you just press the swelling gently on either of the lobes and the area of isthmus and look at the patient's face if he is wincing with pain or not. So these are the first two things you should complete in palpation. Then you again ask the patient to sip a little amount of water and you can confirm by palpation that swelling is moved up with deglutition. So how do you do that? Keep the fingers at the lower border of the thyroid swelling and ask him to sip a little amount of water. You will find that the swelling is moving with deglutition. The fingers are kept in the lower border of the swelling and the patient is asked to swallow or sip a little amount of water. You see the swelling moves up with deglutition. We often do this test of asking the patient to protrude the tongue and see whether swelling moves with protrusion of tongue or not. But keep in mind that this test is not required in a patient who has got a butterfly-shaped swelling involving both lobes of the thyroid gland. This protrusion of tongue test is done in situations to differentiate a thyroglosal cyst. So this patient having a thyroid swelling which is butterfly-shaped involving both lobes and isthmus, there is no question of making a DD with thyroglosal cyst. So don't do this test in a patient who has got a butterfly-shaped swelling. This test is to be done in a patient who has got a single nodule in the thyroid gland in either of the lobes. That is a situation you need to differentiate it from thyroglosal cyst. Otherwise, this test is not to be done in a patient who has got a bilateral thyroid lobe enlargement. So next question is, how do you palpate the thyroid gland? You should palpate the gland with the palp of your fingers, and you need to steady the thyroid lobe to palpate the thyroid lobe surfaces. And you have to have some knowledge about the anatomy to do the thyroid examination. Thyroid isthmus has got two surfaces, anterior and posterior. You can palpate the anterior surface, which is looking at you. Thyroid lobe has got three surfaces. It has got an anterolateral surface, it has got a posterior surface, it's got a medial surface. Medial surface of the thyroid lobe is lying on the trachea and esophagus. This surface you cannot palpate. You can palpate the anterolateral surface, you can palpate the posterior surface. So how do you palpate the thyroid gland? The next video is on the particular method called as Leahy's method for thyroid palpation. What is the method? You sit in front of patient. You press one lobe of the thyroid gland with your one hand. The other lobe becomes prominent, and you palpate the thyroid lobe. And while doing so, you have to mark the extent of the thyroid lobe. You mark the lobe, the lower limit, the upper point, lateral, and the medial. Once you have marked this out, you see, come to the upper pole, come to the lateral side, come lower down, come on the medial side. So you mark the upper point. You mark the lateral border of the thyroid. You mark the lower border of the thyroid. So once you start palpating with your finger, you can make out the extent of this. You have to do in the opposite lobe also. So same maneuver is to be done on the opposite lobe, and you mark the swelling. Once you have marked the swelling, now you can make out that this is a swelling which is involving the region of isthmus, which is involving either the lobes. And as I said, don't use a measuring tape to measure the swelling. You always use a vernier caliper to give an exact measurement of the vertical dimension of each of the lobes. If both the lobes are of same dimension, you measure, you find the dimension is same. You can use one liner saying each lobe measures 7.5 by 4 centimeter on either side. So you need not give same measurement on two lines. If two lobes are different dimension, you have to give dimension of each of the lobes. So that is how you measure the size of the thyroid swelling. Then, as I said, once you start palpating the surface, the gland which is looking at you is the anterolateral surface of the gland. You go on the surface of this. How do you palpate the posterior surface of the gland? When the gland is pointing up to the posterior border of the sternocleidomastoid, you press the swelling from the opposite side and place your finger behind the sternocleidomastoid and run your finger along the thyroid. You are palpating the posterior surface of the thyroid gland. If swelling is smaller, not going to the posterior border of sternocleidomastoid, you can insinuate your finger between the swelling and the anterior border of sternocleidomastoid. So this is the patient where the swelling has gone up to the posterior border of sternocleidomastoid, and this is how you palpate the surface. You see, you put your finger behind the sternocleidomastoid and palpate along the whole of the lobe. You are palpating the posterior surface. And whatever is looking at you is the anterolateral surface of the gland. So you make out, yes, you pass your finger along the posterior sternocleidomastoid. What you are palpating is the posterior surface of the thyroid gland. And once you have put the dots on the upper border, lower border, medial lateral border, you can now make out the shape of the swelling. It's a typically butterfly-shaped swelling involving the both lobes and the isthmus. A single nodule on the thyroid lobe may be globular. And as I said, you should use a vernier caliper to measure the thyroid swelling. You already marked the dimension of the swelling, and then measure the area of right lobe, measure the region of the isthmus, and measure the opposite lobe. So that is how you measure the dimension of a thyroid swelling. Then as I said, you can assess the consistency of the swelling by just pressing the swelling. So how do you assess the consistency? You just press the swelling. Most of the time, a thyroid swelling, which is a Graves' disease or a multiple goiter, most of the time they are usually firm in feel. But some thyroid swelling which are malignant may feel hard or firm, or sometimes may feel variegated. So that is how you assess the consistency of the thyroid swelling. Why do you palpate for the thrill? In hypervascular thyroid, where there is a toxic goiter, you will just place your finger at the upper pole of the thyroid lobe. You can appreciate the thrill. I will show this with the carotid pulsation. So, palpation for thrill in the thyroid gland. Then you have to assess for the fixity of the thyroid gland to the overlying skin and the underlying structures. So, looking for skin fixity is easy. That means you just try to pinch up the skin. You see, the skin can be easily pinched up from the underlying swelling. So my inference is the swelling is not fixed to the overlying skin. Patient having anaplastic carcinoma of the thyroid gland grows very fast and can invade the overlying strap muscles and the skin. In that case, you can say that the swelling is fixed to the overlying skin. What are the deeper structures of the thyroid gland? The deeper structures are, first there are two tubular structures, the trachea in the esophagus. Thyroid is attached to the trachea and esophagus by pretracheal fascia. It is not fixed to the esophagus and the larynx. It is attached to these two structures by pretracheal fascia. That's why the thyroid moves with deglutition. And this movement is because of attachment of the thyroid lobe to these tubular structures. If you go deeper, deep to this, more posteriorly, you have prevertebral muscle and the cervical vertebral body. In malignant thyroid, when there is a malignancy of the thyroid gland, this malignancy can first infiltrate into the trachea and esophagus. In anaplastic carcinomas or advanced carcinomas, this infiltration can occur to the prevertebral muscle and the vertebral body. So you have to keep in mind what you are interpreting. Suppose this tumor has infiltrated trachea and esophagus. Will it move with deglutition? Yes or no? If it is only infiltrating into the trachea and esophagus, it will still move with deglutition. Is it clear? That the tumor has infiltrated into the trachea and esophagus. So once the patient swallows, it will move up and down in deglutition. But what will be there in that situation? The intrinsic mobility will get lost. As I said, when the thyroid lobe are attached to the trachea and esophagus by pretracheal fascia, there is the intrinsic mobility of the thyroid gland. That means you can move the thyroid over larynx and trachea. Next part I said that if the lobe is infiltrated into the prevertebral muscle and fossa, what is going to happen? It is attached to the vertebral body or the prevertebral muscle. It is fixed as such. Now the patient swallows, will it move? No. The swelling has infiltrated into the prevertebral muscle and fascia. So on swallowing, it is not moving up and down in deglutition because the swelling has infiltrated into the prevertebral muscle and fascia. It is fixed as such. So your job is to urge the patient to sip a little water. Swelling moves up and down in deglutition. My inference is the swelling may be fixed to the larynx and trachea, but not fixed to the underlying prevertebral muscle and the fascia. Clear? Now you try to move the swelling and see whether you can move the lobe independently from this. So this is the test for deeper structure mobility. You see, you can move. There is the intrinsic mobility. You can move the thyroid swelling from side to side and from above down. So intrinsic mobility is present. The inference is It is not fixed to the underlying prevertebral muscle and the vertebral body. If it is influenced the vertebral body, this intrinsic mobility gets lost. Clear? So that is how you test for the deeper structure fixity in thyroid. This is a test often described, but preferably not to be done in the examination. That is called as Cocker's test. You know it theoretically, but this is not to be done because Cocker's test is done in situations where there is a long-standing thyroid gland which is causing tracheomalacia, and if you press, the lumen get more compromised, patient has stridor. So this is a test which can aggravate patient's symptom. So you can mention this, but you can say that, sir, I have not tried to elicit this test. So Cocker's test in the exam you can mention, but is not to be done. If examiner at all asks you, how do you do that? The answer is, you press on either side. So what I am saying is, don't try to do this test in exam, but if you do at all, you press from the sides. Already the lumen is compromised. Once you press from the side, patient may have stridor. But exam, skip this test. Then another important part of thyroid examination is examine for the carotid pulse. In patient having a large goiter can push the thyroid, this lobe can push the carotid sheath laterally. Or in malignant thyroid, this thyroid malignancy, which is particularly anaplastic, can infiltrate into the carotid sheath. So either the carotid pulse may be pushed outward or carotid pulse may be impalpable. What is Berry's sign? When you palpate the carotid, you don't palpate the carotid pulsation. Berry's sign is positive, suggesting there is a carotid sheath infiltration. So how do you do that? Where is the carotid pulse? Carotid pulse is palpated at the level of upper thyroid cartilage or at the level of cricoid cartilage at the anterior border of sternocleidomastoid. So in large thyroid swelling, this pulse may be pushed laterally. In that case you comment, I can palpate the carotid pulse, but it is pushed laterally. But in malignant thyroid, which is anaplastic, which is infiltrated the carotid sheath, you may not feel the carotid pulse. So that is where you palpate the carotid. Then there is another syndrome known as Horner syndrome. It is very difficult to clinically appreciate this. At MBBS level, you need not do this. It is difficult to appreciate these subtle signs of Horner syndrome, like partial ptosis, meiosis of the pupil, that means pupillary constriction, and loss of ciliospinal reflex. If you scratch the shoulder, there is pupillary dilatation. So these are the things which are found when the thyroid malignancy has infiltrated into the sympathetic trunk. Then how do you auscultate? As I said, when you look for thrill or try to auscultate thyroid gland, the most vascular area in the thyroid is the upper pole, where the superior thyroid artery comes from the external carotid, enters the thyroid gland. So put your bale of the stethoscope on the upper pole of the thyroid gland. So there you put. You put the bale of the stethoscope on the upper pole of the thyroid gland, and you can appreciate any murmur. In thyrotoxicosis, you can have a murmur in the thyroid gland because of hypervascularity. If you suspect the malignancy of the thyroid gland, you have to examine cervical lymph nodes. So I am skipping the cervical node examination because I like to demonstrate you the how do you examine for the toxic signs. It is important to appreciate the toxic signs in a patient who has got thyroid disease. So how do you start with the toxic signs? The first is the pulse. You feel for the pulse. Patient having toxic goiter will have high volume pulse, will have collapsing pulse, and you palpate and try to appreciate whether the patient has got a collapsing pulse. You palpate and leave the hand. There will be bounding pulse, palpated by your hand. Next is look for tremor. You see, this patient has got fine tremor. Ask the patient to show his tongue. Don't protrude the tongue outside. Let the tongue rest on the lip. You can appreciate fine tremor in the tongue in a patient who has got thyrotoxicosis. You can palpate for thrill at the upper pole of the thyroid gland. So these are all toxic signs. Next is eye signs. This patient is a treated patient. His eye signs has subsided and he may not appreciate all the signs, but some signs are present in this patient. So what are the things you look for? For assessment of this toxic signs, there are some signs which are there, some eye signs, tremor, patient may have clubbing, patient may have peripheral myxedema. So what are the different eye signs? First is exophthalmos. You see, he is staring, he is blinking less. You go to the back of the patient, look at the upper margin of the orbit, or look from the side. Normally the eyeball should not bulge beyond the supraorbital margin. If you are finding that it's beyond that, you can say patient has got exophthalmos. So look from back, look from side. This is examination for exophthalmos. What is tail sign? There is no separate test for that. While you are talking to the patient and while examining, you find that patient has a staring look. That means he is having infrequent blinking. So if you can appreciate during your examination talking to the patient that patient is staring most of the time, he is blinking less, you can say that Stalock sign is positive. So that is what Stalock sign is. He is looking at you, you see he is not blinking. One normal person should have blinked by this time. How do you demonstrate bone graphis sign? You often ask in the exam, demonstrate bone graphis sign. Though keep in mind that to demonstrate bone graphis sign, you have to steady the patient head. Otherwise, patient will look up and down with his head taking with the eye movement. So what you do? You steady the patient head by on your hand and keep your finger in front of the patient and take the finger up and down 3 to 4 times quickly. You see? You see? This patient does not have a lead lag. He has exophthalmos, but if it is not there, don't say. It is not necessary you have to say all the thing, but that is how you do it. You take your finger, bring it quickly up, down 3 to 4 times. So in a patient who has got toxic goiter or is exophthalmos may have lead lag. That means you can see the upper sclera. While he is looking down, the eyelid is not moving the same level as the eyeball. So we call that as lead lag. What is Geoffroy sign? Geoffroy sign is you ask the patient to look up towards the ceiling. You steady the patient head and ask him to look up. You see, there is some amount of wrinkling. It's not good amount of wrinkling, but some wrinkling is there. So loss of wrinkling in the forehead is described as positive Geoffroy sign. So you have to steady the patient head for that. What is Mobius sign? Mobius sign is failure of accommodation. You ask the patient to look straight and bring your finger close to his eye. He was looking at a distance. When patient is trying to accommodate to a near object, the eye should converge and there should be pupillary constriction. So, patient with exophthalmos, with toxic goiter, with ophthalmopathy may have failure of this convergence. You will find that this patient has got this sign positive. Right. Yeah. I ask the patient to steady the patient head. He is looking at a distance. You see, the right eye has not converged medially. He is looking at a distance and bring the finger quickly to this side. Yeah. So you see, the right eye is not converging. You see, right eye has not moved medially. So there is failure. Mobius sign is positive. What is malignant ophthalmos? There is no separate test for malignant ophthalmos. Patient having a grade 4 ophthalmos can progress to malignant ophthalmos. You look at the eyes. If you find there is redness in the conjunctiva, there is conjunctival congestion, patient complain of diplopia or you move the eye, you find there is a squint. Patient has gone to a phase of malignant ophthalmos. Then how do you assess for retrosternal prolongation? Look at the swelling. While you are examining the patient, you find that there are no engorged veins over the thyroid region or over the chest wall. We are able to see the lower border of the thyroid gland. We are able to palpate the lower border of the thyroid gland. There is no puffiness in the face. And there is a test called as Pemberton sign. So what do you do for retrosternal prolongation? This percussion is again debatable. Dr. Chintamani has a feeling that this should not be done, but still this is in the book, but it's difficult to appreciate this percussion point. But what I'm trying to say is, look for the lower border of the thyroid gland. Palpate the lower border and ask the patient to lift the hand above the head. If there is a retrosternal prolongation, there will be congestion in the face, there will be appearance of engorged veins over the chest wall, and patient may have distress. So next part will be the system examination. So I'll just quickly go through how do you approach a patient of thyrotoxicosis. First of all, what is thyrotoxicosis? It's a condition when you have excessive thyroid hormone in circulation. It may have varied etiology, and they can manifest with variety of symptoms. Yeah. So what are the different etiology of thyrotoxicosis? It can be a classic Graves' disease. It can be a toxic adenoma, that means a functioning autonomous nodule in the thyroid gland which is hypersecreting hormones. It can be a multinuclear goiter which was pre-existing and started hyperfunctioning, toxic multinuclear goiter. Or some patients are treated with thyroid hormones as a substitution therapy. Or this is described as a slimming drug. Many people consume L-thyroxine to lose weight. There is a condition known as postpartum thyrotoxicosis. After delivery, patient may have evidence of thyrotoxicosis. There are some thyroid hyperfunctioning state in patient having some viral thyroiditis. Patient consuming more iodine may have features of thyrotoxicosis. There may be some drug-induced thyrotoxicosis. Known as secondary thyrotoxicosis, which may happen following a TSH-secreting tumor in the pituitary. Patient having molar pregnancy, this excess HCG can stimulate thyroid receptor, leading to increased hormone secretion. There is a condition known as stroma ovarii. Stroma ovarii is an ovarian teratoma. Some of the cells in the ovarian teratoma may differentiate to thyroid follicular cells and hypersecrete thyroid hormones. Or it can be a functional follicular carcinoma which is widely metastatic, causing increased hormone circulation. So these are the different etiology. And how does it manifest? Thyrotoxicosis is a hypermetabolic state. It causes hypermetabolism in all the system. So if you go by each of the system, there will be some manifestation. So GI manifestation is increased appetite. In spite of that, loss of weight, patient may have diarrhea. Cardiovascular, patient has palpitation, different type of arrhythmias, and even heart failure. In neurological, patient may have irritability, anxiety, insomnia, tremor, heat intolerance, sweating, and hyperreflexia. There may be a clear Graves' ophthalmopathy, exophthalmos, different eye signs, and ophthalmoplegia. Patient may have musculoskeletal symptoms like proximal muscle weakness. Patient may have dermopathy in the form of pretibel, myxedema, or clubbing. There may be menstrual abnormalities in female. In hyperthyroidism, there is amenorrhea or hypomenorrhea. Or in the male, it can cause erectile dysfunction. So these are the varied manifestations of patient having hyperthyroidism or thyrotoxicosis. So how do you diagnose? As I enumerated the different causes of this, for approach to diagnose, you need to take a thorough history, do a good clinical examination, and you need to do some relevant investigations. So I'll just skip few of the slides. So what investigations are important to diagnose thyrotoxicosis. First, the thyroid profile. Thyroid profile includes T3, T4, TSH, and in some cases, estimation of free T3 and free T4. Next important investigation is doing a radionuclide scan with I131 or 19M technetium. There is a role for estimating thyroid autoantibodies in some situations who can help in diagnosis. And some patients, you need to do ultrasonography to assess the extent of thyroid enlargement. So these are the basic investigations. So thyroid profile is important. A low TSH indicates a hyperthyroid state. Patient having low TSH, high T3, T4 is a patient who has got overt hyperthyroidism. You can find some situations where the TSH is low, but free T3, free T4 is in the normal range. We call that as subclinical hyperthyroidism. Radionuclide study is important. You give the patient oral radioiodine, and this radioiodine will be preferentially taken by the thyroid. Looking at the thyroid uptake, we can come to a diagnosis what may be the underlying pathology. So once we give this, it can be that on the left side you find there is this one area where whole radioactive are taken up. Rest of the thyroid is not seen at all. So this is a classic case of toxic adenoma. The hyperfunctioning nodule has taken the whole radioactivity. The rest of the thyroid is suppressed. See the right picture. The right picture is there is increased uptake in the thyroid bed involving both the lobes and isthmus. This is a classic picture of Graves' disease. If you take the next picture, you see on the right upper side, there are some areas of increased uptake. In between there is less uptake. This is a classic appearance of a toxic nodular goiter. If you see the lower picture, patient has got hyperthyroidism, but the uptake is only 2%. There is no increased uptake in the neck. This happens in situations where thyroid is not the primary site for the disease. Thyroiditis, it causes damage to thyroid cells. It causes release only of the preformed hormones. There is no hypersecretion in thyroiditis. Struma ovarii, patient has some teratoma in the pelvis, which is hypersecreting thyroxine, is not from primary thyroid gland. Patient taking exogenous L-thyroxine, more of L-thyroxine in circulation, but thyroid is not hyperfunctioning. Thyroid is suppressed because of exogenous hormone. So looking at the radioactive iodine scan, you can make out what might be the underlying cause for thyrotoxicosis. Then thyroid autoantibodies are important. Patient having Graves' disease may have rise of TSH receptor antibodies. There is another antibody we find in Graves' disease, thyroid stimulating immunoglobulin. That can be elevated in Graves' disease. And some patient having autoimmune disease may have TPO antibodies, thyroid proxy antibodies being raised. Ultrasound is not very helpful. So I'm just skipping the disease part. Just few lines about management strategies. So how do you treat thyrotoxicosis? There are three modalities of treatment. One is antithyroid drugs. Second is radioiodine therapy and surgery. So how do you pick up treatment? How do you choose about the treatment? So there are different groups of antithyroid drugs, which can be either propylthyrosol or thionamides in the form of numarcazole or methimazole. These drugs given from outside can block synthesis of thyroid hormones. So you can easily make out. These drugs are effective when thyroid is hyperfunctioning. So you should not give these drugs in patient who is taking exogenous thyroid hormones. You should not give these drugs in patient of thyroiditis where there is no excessive secretion, only there is thyroid damage of the cells. So these drugs are to be given when primarily there is hypersecretion of hormones from the thyroid gland itself. So these antithyroid drugs act by blocking the synthesis of thyroid hormones. And what is the optimal duration of therapy? The optimal duration of therapy antithyroid drugs are for 12 to 18 months. And another important aspect is, even if you consider treatment with radioiodine ablation or with surgery, these patients should be treated with antithyroid drugs for the primary period so that this patient does not go into a phase of thyroid storm or thyroid crisis in the immediate post-op period. So antithyroid drugs are required for treatment of Graves' disease or treatment of some toxic nodular goiter, or it can be used as preoperative state to take the patient to euthyroid state before taking the patient for surgery. There are some adjunctive drugs along with antithyroid drugs. Antithyroid drugs has their own side effects. Some patients may not tolerate the antithyroid drugs. The effect of antithyroid drugs may be reversed by some drugs. The cardiovascular symptoms can be ameliorated by beta blockers. Patient having thyroid storm may be helped by giving the patient high dose of glucocorticoids. Some patients who are top for surgery, you can give the patient potassium iodide in the immediate pre-op period to reduce the vascularity of the gland. Next modality of treatment is radioiodine ablation. This is a new modality of treatment where earlier this was contraindicated in young females and children. This indication has now been extended, except it is contraindicated in children below less than 5 years. So how does the radioiodine ablation acts? You give the patient a mega dose, maybe 15 to 20 millicurie of radioactive iodine. This is picked up by the thyroid gland, and this causes damage to the thyroid follicular cells. And most of these patients may go to a phase of hypothyroidism in follow-up. So you have to keep this patient under a follow-up to see whether these patients are developing to hypothyroid, and in that case, you have to give the patient substitution therapy with L-thyroxine. There are some side effects of radioactive iodine. These are all radioactivity. So once you give the patient this radioactive iodine, initially patient may have aggravation of thyrotoxicosis because it's going to damage of thyroid cells and increase release of these hormones on thyroid. So you have to keep in mind that you should take care of this period by observation and treatment with some adjunctive drugs. Surgery is one important modality of treatment for thyrotoxicosis. Some of the patients of Graves' disease can respond to your antithyroid drugs, but there are some patients who may not tolerate the drug, number one, and some patients may not prefer to continue the drug for longer time, which is a period of 12 to 18 months. And on stoppage, patient may relapse of hyperthyroidism. So surgery is a form of treatment which can provide you instant cure. If you do total thyroidectomy today, tomorrow morning patient is free of excessive hormone secretion. So what are the type of surgery you do? In surgery, if you have a goiter which is now diagnosed as Graves' disease, the treatment will be a near total or total thyroidectomy. Patient having a toxic adenoma, that means one nodule is hyperfunctioning, confined to one lobe, a hemithyroidectomy will be curative in that situation. You need to do a total thyroidectomy. So what are the advantages of surgery? Surgery advantage is quick relief, no continuation of antithyroid drugs. The problem of surgery is, if you have done a total thyroidectomy, you render the patient hypothyroid for lifelong. You have to continue the L-thyroxine. There are some intrinsic complications of thyroid surgery, like recurrent nerve palsy and parathyroid insufficiency, although the incidence is about 1 to 2%. In thyroiditis, there is no excess hormone secretion. There is release of hormones because of thyroiditis. So in that case, you should keep in mind that the treatment of choice should not be antithyroid drugs. These are the situations where you can use some NSAID for pain or steroid. And if this patient goes to hypothyroid situation, you should give the patient L-thyroxine. So there are some ATA means American Thyroidism Guidelines for Management of Hyperthyroidism. What are these? Graves' disease may be treated either with antithyroid drugs, radioiodine or surgery. If you are treating the patient with antithyroid drugs, the optimal duration of treatment should be 12 to 18 months. When do you stop antithyroid drugs? In Graves' disease, when you find that TSH receptor antibodies have become normal, the thyroid profile has come down to normal, at the end of 12 to 18 months, you can take the drug off. If you do surgery, what should be the extent of surgery? In Graves' disease, it should be near total or total thyroidectomy. For toxic adenoma, it should be hemithyroidectomy. Radioiodine ablation therapy is contraindicated in children below 5 years. Patients with Graves' disease who are for surgery or for antithyroid drug therapy may have deterioration of ophthalmopathy. In that case, you may need steroid therapy. Pregnancy is a contraindication for giving radioiodine ablation therapy. Gestational thyrotoxicosis is a transient phenomenon. You need adjunctive drug, not antithyroid drugs. So in conclusion, all patients with thyrotoxicosis need early diagnosis and treatment to prevent the complications. TSH level is important for screening for thyrotoxicosis. Accurate diagnosis is required for planning treatment. In addition to thyroid profile radioactive iodine scan, they provide a good diagnostic yield. In some patients, thyroid receptor antibodies are helpful for diagnosis. Thyroid ultrasound is seldom useful for diagnosis. Therapeutic measures will include your antithyroid drugs, radioiodine and surgery. Thank you.
Thank you so much, sir, for conducting that absolutely needed session with such passion. Students, if you would have paid attention, then I'm sure you guys will crack any question coming your way. Thank you once again, sir.
Okay, everyone. Since we just discussed on the approach to thyrotoxicosis, I think it is time we make the best use of this opportunity to recollect and understand as to an approach to head and neck cases in surgery. It is a booming field in the present scenario and can be taken care of with an apt outlook and approach. Please put your hands together and help me welcome back to the stage once again Dr. Chintamani Sir, Professor and Head, Department of General Surgery, VMMC, Safdarjung Hospital, Delhi, to expand our horizons. Please, sir.
So we'll quickly move to, I'll try to cover it as fast as I can because most of the things are covered. Can I have your attention? Are you okay to listen or we need a break? But this is a break. Well, you should know that in males the most common cancer is, it's controversial, but it is oral cancer that we see in most Indian males. And the reason for that is tobacco abuse, and usually in the smoked form and smokeless form. Correct? So pay attention, I'll quickly finish it. And how does smoking cause oral cancer? You must have been reading. Can anybody answer that? Let's wake up. Yes? How does oral cancer happen with tobacco? Can you be faster? Yeah. Come forward, grab it. Yes.
Chronic irritation with
chronic irritation. Anybody else? Yes. Give her a round of applause. Well, it's a summarized form which is there in my videos, and that's what, it's good you saw it. So she has answered that. But nowadays we know there's another risk factor, which is HPV, human papilloma virus, and we know the stains 16 and 18. You are all taught very regularly. Cervix and oral cancer both. And nowadays the AJCC 8th edition, which is the American Joint Committee on Cancer, which defines stages cancer, has now divided them into HPV and non-HPV cancer. This is one change which has happened. So HPV-related cancer is a totally different cancer. Now the tobacco can be in a smoked form or smokeless form. Smoked form, you know, the smoking. And the reverse smoking also is there, which is called as chutta bidi, you know that. That increases the risk further. And smoking is a more common cause in the West, while chewing is commoner in our part of the world. That's it. The chewing is in the form of a smokeless form of tobacco, where you see all sorts of these film star jokers coming with one pan masala or the other. They're all with tobacco. Don't use tobacco. Tobacco is a killer. Now, so what she mentioned is the classical quid cancer, or the gutka cancer, or Kenny cancer, your various names. They usually prepare a quid and keep it in the gingiva buccal sulcus. So 3 things are mandatory for this. How many things are mandatory? Please don't talk. Keep quiet, keep quiet, keep quiet. No talking, no talking. So 3 things are mandatory. One is presence of nicotine. 2 is adequate contact time. And 3 is presence of bacteria that convert it into nitrosamines, which are carcinogenic. So now all 3 are achieved in a quid cancer. They put the nicotine in the space, it stays overnight, the oral hygiene is poor, bacteria are present, so the changes would happen. So that is how the oral cancer happens. Smoking is commoner in the West, therefore the most common Indian oral cancer is the lateral sulcus cancer. Which one? Louder? You people don't speak? Do you rely entirely on them? This is the outsourcing that you've done, right? So lateral sulcus cancer is also called as Indian oral cancer. So if you are asked a question, which of the following is the Indian oral cancer? Tongue cancer, buccal mucosa cancer, lateral sulcus cancer. Answer is lateral sulcus cancer. Correct? Also called as quid cancer. Now, smoking is mostly associated with tongue cancer, lip cancer, etc. And coming to HPV, the human papilloma virus is responsible for conversion of the fertile mucosa into cancer. So human papilloma virus, the strains 16 and 18 contribute significantly. Do you know what? The human papilloma viruses produce warts. You know that, venereal warts we knew always. And the cancer that develops from the warts is called the warty type, which is like a flower, which is varicose, which means flower-like. You seen a flower, it keeps growing out. and then some of the petals keep dropping away. So it doesn't cause that much of a damage because it doesn't go inwards. It goes into air. And the most common reason for a bad outcome in cancers of the oral cavity is presence of neck nodes. The moment the neck nodes are involved, the survival drops by 50%. So gentleman A has oral cancer, and gentleman B has the same size oral cancer but a neck node. What's the difference in the survival? 1:2. So you understand how important it is? Therefore, we need to not only know about the primary, we also need to know about the lymph nodes. Clear so far? Yes or no? Now the HPV induced or the varicose type of cancer is growing into thin air. So it doesn't go inwards. That's why it tends to do a little better. And naturally what is coming out will be seen also more clearly. It is visible. Let's move on. What is the role of alcohol in it? You take that history in all patients. And anybody would answer that? Most of you read about it. How does alcohol contribute? So it is vasodilator everywhere? No. It is vasodilator in the periphery only. So whenever you hear of the Saturday night deaths in the West, very common, and especially around New Year, because the outside temperature increases, right? People take alcohol to feel warm. But this warmth doesn't come from nowhere. This warmth is stolen out of your core to the periphery. So actually you're more vulnerable to cold. So the mistake is that I'll have my alcohol and I'll stand out in the cold. You're worse than the other person who's not taken it because his core temperature is all right. And with alcohol, the core temperature drops. So they used to find a lot of these Saturday night deaths. People found lying in the street, dead, just dead. So that is not the reason, I'm sorry. The reason is it potentiates the effect by taking away the protective role of the lining, that is the oral cavity lining. So any ulcer in your mouth does not become cancer. But if the protection from the, now I'll have to further extrapolate. Everybody sitting in this hall right now has cancer. I'm sorry. But it won't show up. Because all cancers are somewhere affected or controlled by the genes. We know that. The mutation can be you inherit it or you acquire it. What you acquire is induced by environment. So a lot of you would have the cancers, but it won't show up. 80% of individuals, males, that were more than 80 years, post-mortem revealed 80% had prostatic cancer. Women, ductal carcinoma in situ of the breast. So cancers are chronic diseases. With mutation they precipitate. So be clear. So protection is with the help of certain genes which protect. You heard of mismatch repair genes? So whenever the mismatch happens, they repair it. So you're all right. And you heard of tumor suppressor genes, P53. You're all taught, somebody spoke just now. So they prevent the change to tumor. So when they undergo mutation, cancer happens. Right? So the changes can happen due to environmental factors, like we talked of tobacco here, radiation exposure, lots of alcohol, obesity, many factors. I won't name them here. So this is important, therefore, to know. Alcohol potentiates. What do the mismatch repair genes do? They take care of the changes that happen with irritation. Irritation, you're right, but irritation in your mouth may not produce cancer if you can keep on protecting it. You can keep on repairing it. These are the important histories you must take. Plummer-Vinson syndrome, you all know about it. Chronic syphilis, not seen now, fortunately, because of the drugs and also because of many awareness has come. And HIV-related oral cancers are well known. So you should be clear on taking that in your history. You know about P53 mutation is in 50% of them. So P53 is a tumor suppressor genes. So somewhere most cancers are controlled by the genes. When you inherit a mutation like BRCA1, BRCA2, it may not immediately produce it, but the chances increase. That's why the Angelina Jolie got her bilateral mastectomies, oophorectomies done beforehand, because her risk of developing cancer was about 20-25%, which is high. Or you keep them under observation. And a lot of people get the risk-reducing surgeries done now. That is bilateral mastectomies, oophorectomies, hysterosalping oophorectomies, whatever. I'm not getting into the details. So you should understand that. So tumor suppressor is important. It can be spontaneous or it can be induced. I'll skip this to prevent confusion in your mind. This much if you digest and importantly assimilate, useful. You can digest anything, but you should use it, right? Then is radiation. Take history of radiation exposure in all patients, whether it is thyroid cancer, breast cancer, head and neck cancer. This history is general. So pay attention what I'm saying now. So you would always take that history. The patient had an exposure to radiations in the childhood, yes or no? Patient says yes. The risk is increased. The next question comes, is it the high dose radiations or low dose radiation? Common sense. High dose radiation will ablate the organ. They are therapeutic. So they cause less damage, chances. It's a low dose radiation. At a young age or an older age? Young age. So young age, low dose. How young is young? Less than 20 years. And how low is the low dose? Less than 20 centigrades. 2020. You know 2020? All of you are into 2020 era now. Everything is 2020. 2020 matches. Finally, take this history. You know, most of the time the therapeutic low dose radiations don't exist. You don't give radiation for benign conditions. But in the past, it was used for adenoids, for tonsils, and in lymphoma, they were using the low dose radiation. Nowadays, most of the time, radiation is adequate, therapeutic. Clear? So what are those conditions? Where the dose is constant and low. Chernobyl, Hiroshima, Nagasaki. These were explosions where the radiations are still coming out. So there is a Chernobyl-induced papillary carcinoma of thyroid, which is a known, established entity. Lots of surgeons I know in Russia, I visited Russia 3-4 times for lectures and workshops. There's a friend of mine there who developed papillary carcinoma thyroid because he was actually working in Chernobyl. So low dose radiation increased the risk. There is something called as field cancerization. I'm covering a few terms, then I'll come to the answer. What is field cancerization? Field itself indicates a particular background. So wherever there is squamous epithelium, you know, stratified squamous epithelium is in the wear and tear part. So oral cavity down to the esophagus, stomach is okay. From below up, anal canal, some part, you will get squamous cell carcinomas there only. If you get multiple cancers in the same soil, you know, there is one theory for cancer, which is called as soil and seed, or seed and soil theory. There has to be a fertile soil and the right seed. That's how cancer happens. So wherever in that area, if another cancer happens, we call it field cancerization. What do we call it? Louder? You also, it means both of you. What is it called? So the field is, suppose this side is not the field. Whatever happens here, multiple places, that's field cancerization. Okay? This you should know because classically you will find that the whole of the oral cavity may be affected by tobacco chewing, and you can get, pay attention please, you can get not predisposing conditions, you get pre-cancers. Oral cavity is one place where you get pre-cancers. Pre-cancers are different from pre-malignant conditions. Don't get confused. Pre-cancers are waiting to change into cancer. Things like submucous fibrosis, leukoplakia, melanoplakia, erythroplakia, melanoerythroplakia. Wherever the two join, risk increases. So if you are asked a question, between leukoplakia and erythroplakia, what is the risk? More for erythro. What about leukoerythroplakia? More. It will rise. Typical Indian oral cancer. That's it. In the gingivo-buccal sulcus. But you can see the changes all around. Can you see here? You can see here. These are all areas of field cancerization. But they can occur at many places. I am skipping that part. These are the zones of oral cavity. You are taught in your anatomy. I am teaching you surgical anatomy. The only difference between the anatomy that you learn in first year and the anatomy that you learn all your life is the anatomy of the dead and anatomy of the living. And you know, living problem is better than a dead solution. So you will have to deal with living. The colors are different, the cases are different. So basically, these are the parts. Lips, anterior 2/3 of the tongue, buccal mucosa, floor of the mouth, lower and upper gingiva, and retromolar trigon. Trigon is a triangle. Right behind you see a triangle, right? Where the teeth end, the wisdom tooth, if you have it. Some people don't get it, ever, right? So beyond it, there is a triangle. That is the retromolar trigon. Retromolar trigon is a very dicey area for cancer, because the moment cancer reaches there, there is a connection of pterygoids, medial and lateral. One is for opening of the mouth, the other is for closing of the mouth. So if the cancer goes there, they get infiltrated, mouth cannot open. That is painful, restricted mouth opening or trismus, which makes a surgery not possible. It's late. Why should it become not possible? Because the other end of the muscle is attached to the skull base. So it is taken as a skull base disease because you can't clear the posterior margin. I hope it is clear, or was it too much? Did you understand what I said? Yes, repeat.
So it is attached to the base of the skull, so surgery is not possible.
Because you can't get a posterior margin. So that is about the rough anatomy which you should know. What are the important points in history? Most points in history we have covered. So I'm not going to touch those parts. But some specific history which is relevant to head and neck should be taken. Onset, duration, location and progression of the lesion. Associated complaints of pain, type, intensity, character, radiation. Now where does the pain from tongue radiate? Anybody? Anybody can try, I don't know. To the ear, and you're right. Why does it go there? Give her the mic, she's answering. You can give it to them only, so that they can, don't return it now. Keep it with you, and you run and give it to the person who speaks now.
Glossopharyngeal.
Okay, so a round of applause for her. There is more to it, but I'll not waste time there. And suppose the patient tells you there is a gingiva, keep standing please. Patient tells you there is a lesion in the oral cavity, in the gingivo-buccal sulcus, and he has numbness in the chin. That's his history. You know, eyes cannot see what the mind doesn't know. To an average person, every bird is a crow. But somebody who's into wildlife viewing, I've seen in your campus, at least 40 varieties of birds already. Because as I was going, I was watching. Drongos, green pigeons, rocktails, shrikes. Now you're probably getting alarmed. I don't want to bank manners, grey manners, pied manners, kingfisher, white-breasted, blue kingfisher, night jay, pond heron, grey heron, they're all here. But you don't know. Because you don't know they are those. You know, they're another crow. Same thing applies here. When the patient tells you a history of numbness of the chin, you got such a blessed, beautiful campus. People travel to places to see good things. You're already there. But the trouble is, we always look beyond, right? We never see where we are standing. That's the trouble. Yes. Numbness here. Lesion here. What does it mean? Anybody? No, if you don't know, it's all right. Say you don't know. You don't know. Give it to her, give it to her. She's itching to answer. And then she'll get up and start looking around. She's the one who's asking.
Any facial nerve injury?
No. Facial. Facial comes to the parotid. Look, it's an inferior alveolar nerve involvement, which has got a cutaneous supply here. See, indicates the involvement of mandible, which you cannot make out otherwise. Because this nerve has to go through the mandibular, that canal. So if it is involved, numbness is one of the features of involvement of mandible. So you would be clinically able to make out, even without getting any investigation done. Because the eyes are open and mind knows. Because you don't see with the eyes, no, you see with the mind. There's an article of mine you must read on PubMed. With the mind, not the eye. Training of a surgeon. I wrote it 10, 15 years ago. If you read it, these things are covered. Why we don't pick up things? Because we actually don't know about them. So first you have to know about them. Keeping your eyes open is not enough. People will take you for a person lost. Unless you know what you want to see. Clear to both? Sit down, please. Now we come to your... So don't worry. There is drooling of saliva. What does it mean? No, doesn't mean that. I gave you that hint, but that was a broad one. Angle of the mouth, only drooling of saliva. So there is marginal mandibular nerve, which comes to supply the angle of the mouth. It gets involved in the lesions involving the submandibular triangle or buccal mucosa, because it comes from one of the divisions of facial nerve. There are 5 divisions you're taught. There are at least 7 of them. Okay? So basically 2 trunks, temporozygomatic, cervicofacial. They further divide into branches. So there are many branches, more than 4, 5, right? And then there is pes and serinus. You've been taught now? What is pes and serinus? You said yes? You've seen a goose, the connections? So between them there are connections, right? So, please sit down. So angle of the mouth is affected. And this is due to injury to the marginal and mandibular nerve. Are you okay with what I'm saying? Can you name a cricketer who used to be a good commentator? So whenever he spoke, the angle of the mouth would be drooping. Jeffrey Boycott, if you heard his commentary any time. So the angle of the mouth affected would be a feature of involvement of the facial nerve. Also, there can be weakness on that side, contralateral pulling of the, the angle of the mouth. And it becomes more evident as you open. I'll move on. Take this history, which you do in any case, but the history of high-risk behavior is important. What do you mean by high-risk behavior? What people used to teach in the past, and maybe they're still teaching because God bless us all, it goes on, many things go on. What is history of contact? Yes, you. No, please come and pick the mic. No, why should she come? You come running, pick it. And stand here and answer.
I'm Arshad Raj from final year MBBS.
Very good. Round of applause for him. No, only applause. Oh, yeah. Now answer. They already clapped for you, so do something. patient contacted Dr. 1, then he contacted the skin specialist, then he contacted the surgeon. So history of contact is present. So that is this history got taken for a ride. It's a wrong way to ask this question. High risk behavior means any risk or any behavior which predisposes to possibilities of developing HIV and other related disorders. Now tell me the answer. What are those conditions?
Sexual contact.
Multiple sexual partners, infected, unprotected sex, carry on.
Blood transfusion.
IV drug abuse.
IV drug abuse.
Yes, very good. And
blood transfusion.
that also is possible. So that is what you should say now. If you're taught or you read history of contact, don't follow that. High risk behavior, it's taken in truckers or sex workers and multiple sexual partners. And what he mentioned about IV drug abuse, they become important. I wanted that to come through. Family history, when you're asking, please sit down. Keep it with you and pass it on to the next person. Keep it in your hand. Now, if you have taken this history, you're more or less clear about the possibility of, or the, we talked about family history. I've already covered that. Take a specific family history. There are some cancers that run in the families. Even thyroid cancer is now, there are some genes that you look at. What are those? 2 more minutes. No, you had the mic. Run. Give it to her. Come running. Yes. She got it.
So HLA gene,
No, if you don't know, it's all right. You're answering very well already. So don't worry about it. So we earlier never believed a lot of these genes existed. The only one we knew was with medullary carcinoma of thyroid, which was?
it's a P10, men genes, men 2A and 2.
What is that gene? Red proto-oncogene, correct? And also, now we know in papillary cancer the genes have come. One of you mentioned P10 is general, even P53 tumor suppression, and there are cases where we look for some specific gene which makes them a high risk. If you answer that even towards the end, I'll give you the marks. marble size, coconut size, groundnut size, absolute rubbish. It's gone. Because that is also approximate. So say in approximate centimeters. When a patient tells you, he doesn't say marble size, you say this much, you say marble shape size. This used to be done in the past, not used. Lemon. Lemons come in all sizes now. You've seen a lemon this big also. An orange this big. So the reference point should be fixed. So the reference point is centimeters. So approximately 2.5 centimeter. That is it. And it became 5 centimeters. So one knows it is doubled. So that you can quantify the change. So no longer these peanuts, groundnuts and coconut appearance. That is not done. 3 fingers is out. Because it will vary every time then. Isn't it? 3 centimeters is correct. How much is it?
3 centimeters.
Otherwise the question would come, how many would be the 3 fingers of that fighter, Khali? This much? You can't open that much, your mouth. So inter-incisor distance, thank you, sit down. Inter-incisor distance, 3 centimeters. Then you quickly move on to trismus. If the mouth opening is inadequate, you're asked a question, what is trismus? Most of you would say inadequate mouth opening, but that's not a correct answer. Inadequate mouth opening can be painful or painless. Painful is trismus. And what are the painless causes of inadequate mouth opening? You see people who chew tobacco, submucous fibrosis. They can't open their mouth. They can't open their mouth. So don't buy that idea. Pan Bahar and all that rubbish that you see the film stars advertising. Sand. They are all tobacco. And mouth opening should be adequate. Restricted mouth opening is not trismus, I'm repeating. So trismus is painful restricted mouth opening, please understand. Is trismus always due to malignancy or can be due to benign conditions? Please be faster so that we save time. What are the benign causes for trismus? Somebody sitting on the mic. Okay, pass it.
Sir, infections can lead to painful mouth opening.
Like?
In tetanus, there will be painful.
Tetanus, very good. Next. See, mouth opening would be restricted whenever the muscles of mastication are in spasm. I've given you a hint. Muscles of mastication are masseter, pterygoids. We know about it. Some bit of temporalis also. So, benign conditions can be peritonsillar abscess, quinsy, that you taught already. Parotitis, parotid getting inflamed, parotid abscess, fracture of the mandible, displacement of temporomandibular joint, tetanus. Rest are all malignant causes due to infiltration of pterygoids, infiltration of masseter. What is the difference between infiltration and invasion? Infiltration, it grows into the system. So that kind of freezes the system. Thank you. Now, they can cause erythema and all around. I'm not going to take you there. Sometimes they can go through the skin and come out to present as this. You can see the daylight through and through. These kind of cases we get very regularly. So, you see that the cancer has gone through and through. He was on some vague treatment by a quack in the village. It happens. We get patients referred from all over, including SAARC countries. So we get lots of patients from Nepal, Bangladesh, etc. This is orocutaneous fistula. The tumor has gone right across the skin, through the mucosa. So we should be able to make that impact. And you can see the saliva is dribbling down. It's all dribbling down. You can see a big tumor, mouth opening is restricted. What else is visible? You can see the angle of the mouth, submucous fibrosis, tobacco chewer who had this. Now, asking the patient to show the teeth. You see the deviation? Before showing the teeth, it was not visible. Which side is involved? This side or this side? Right or left? Shout. It's the right which is involved because it's getting pulled to the left. This is what happens in usually the facial involvement. Which organ goes to the same side when its nerve is affected? Louder? Why? Oh, you can pass it. Don't worry, I'm not pointing at you. You can answer them. You got the mic, no? You know it or you don't know it? Don't take half an hour to get up, then think. If you don't know, say you don't know.
I don't know, sir.
No, pass it on to the next one. You're taking half an hour to say that. All right, stay there. Keep the mic. Stand up. You know it. Which muscles of the tongue would be affected if hypoglossal nerve is affected?
Genioglossus.
Good. So, what is the characteristic of genioglossus? All extrinsic muscles, genioglossus is one. It's a fan-shaped muscle. Okay, you've seen a fan being made. The fibers have to crisscross to make it into a fan. So for projection of the tongue, it fans out. So if the left side is affected, it won't be coming out. So this side will be able to push it through. Can you get my point? Projection is happening, both sides of the tongue, straight. Okay? But left hand is not working. It is called wheelbarrow phenomenon. What is it called?
Wheelbarrow phenomenon.
Repeat again.
Wheelbarrow.
Once again.
Wheelbarrow phenomenon.
No. Wheelbarrow is what you see in the mowing you do in the lawn. You've seen that machine? It's got two wheels. Or you've seen that regular thela that people carry. Two wheels and they're carrying weight on it. So if the wheel breaks, which side it falls? Same side. So that is why it is called wheelbarrow phenomenon. So the only time it moves to the same side is then. You can see the submucous fibrosis clearly here, and the mouth opening is an issue. Examining the oral cavity, most lesions in the oral cavity would be in the form of either an ulcer or in the form of a patch. And we call them ulceroproliferative. Right? What do you understand by the term ulceroproliferative? We are going to use it regularly. You know what is an ulcer? Yes, doctor? Yes. Both of you want to answer together? Okay. What is an ulcer? Pass on the mic, please. Fast.
Sir, break in the epithelium. Discontinuity or a break in the epithelium.
Very right. Discontinuity of epithelium.
Yes.
Correct. What are the parts of an ulcer?
Sir, margins, edge, base, floor.
Very good. And what are these? Because you've gone in a haphazard manner. Imagine a swimming pool. You've seen a swimming pool and take the water out. That's an ulcer. Okay? So what you see is the floor. What you walk on is the margin. What is connecting the two is the edge. And what you cannot see but it is underneath is the base. So you cannot see the base and you cannot feel the floor. So edge and margin. Margins never get everted because they are a line. Edges get everted. Clear? This far clear? Yes or no?
Yes.
So there is an ulcer which has to be now healing. You are trying to fill it with sand so that it becomes plain. What will happen? You will keep filling the sand, it will become slopy as you keep going. So sloping edges would mean healing ulcer. Easy? It slopes, evened, finished. It is cancer, slope, but it doesn't stop, it spills over. Ulceroproliferative, edges get everted now. Nothing happens, it stays punched out, non-healing. Very difficult? No rocket science, very simple. So chronic ulcer, non-healing ulcer would have punched out edges. Healing ulcer will have sloping edges. Malignant ulcer would have everted edges because they have everted. It's very, very simple. And a chronic non-healing ulcer will have a wound callus because there is a white line around which disconnects this ulcer from the rest of the body. Because healing happens with pain. Pain is a good thing. When you don't have pain somewhere, it's a dangerous thing because it's not going to heal. Pain is what stimulates healing, and that's how healing starts. You read about the first chapter in your book on response to trauma. What is it? Trauma, spinothalamic tract, thalamus, hypothalamus sends cytokines, interleukins. All the energies move, healing starts happening. No pain, no healing. That's why trophic ulcers don't heal. Diabetics have delayed healing because they don't perceive the ulcer. So important to understand. The types, so most of them are ulceroproliferative, and base is indurated. What do you mean by induration in the base? The rest are all pictures, so I'll finish with this. Yeah? What do you mean by induration? If you know, it's all right. If you don't know, it's okay. You know or you don't know? No, then it's okay. You don't know, pass it on to the next person. She may know. You don't know? Induration is hardening, you know. Some people say due to fibrosis at the base. So induration will happen in any inflammation because fibrosis will happen at the end of all inflammations. But if the induration is beyond the boundaries of the ulcer, it may be malignancy because it is infiltration. So important to feel for induration. And if it is tender, more likely to be inflammatory induration. This is how you differentiate malignant infiltration induration from inflammatory induration. How do you differentiate? Which one is tender? Inflammatory. Which one is beyond the margins? Malignant. Clear? Sit down. So that's how you examine the ulcer. Look for any bleeding on touch. Why do they bleed on touch? If you answer quickly, I'll move on. Why does a malignant ulcer bleed on touch?
Increased vascularity.
Speak loudly. Increased blood supply. Or is that what you say? No, there is increased blood supply due to angiogenesis, neoangiogenesis, but most of these vessels are immature. So they are fragile. So they break on touching. Because they quickly divide to feed the tumor, but they are immature. It's like putting too many child labor. So they will crack at any moment. So therefore, most malignant ulcers bleed on touch. That is the reason. Understanding is more important than remembering. So try to be clear when you're dealing with it. Tenderness I've already talked about. You can see now, this is a warty lesion. And look at the teeth, they're looking so good. Dark and nice. This is tobacco staining, submucous fibrosis, but warty. Patient has HPV infection. We continue to think tobacco is the only cause. This was a case with history of high-risk behavior, and he developed multiple lesions later on. Typical oral cancer in the lateral sulcus, but can you see the black change here? Yes or no? You have to say yes or no. Yes. That is melanotic change. Can happen. And what would be the first feature of involvement of the mandible? Patient will give you history of loosening of teeth. So that history becomes important. But if he was losing teeth even before the lesion happened, it may not be related. If the patient underwent a dental procedure and then it happened, we don't know. But lesion came first and then the teeth started shaking. It means the tumor has gone into the socket. It's involved. This is a feature of involvement of mandible. Ulceroproliferative growth involving the angle. It will have a different outcome altogether. You can see the node also. And multiple lesions would be there. Now, you can see multiple lesions inside as well as outside. So this is sort of a field cancerization, but not classical. And the growth has gone through the mandible. Tongue is involved usually in the lateral part, and they keep getting treated for various things, including a normal ulcer. This patient had gone to a dentist also for something. It gets missed out. This should be looked for. And when you're looking for a cancer, look for the precancerous conditions around. That is leukoplakia, melanoplakia, erythroplakia, etc. On the shortage of time, I may not take you through all. This is another one, lesion infiltrating into the floor of the mouth. And look what has happened to the teeth. They got pushed around and they are loosely hanging. The oral hygiene is very poor, but what is one more thing you observe? Oh, the mouth opening is adequate. which means it is still resectable. It may look ugly, but it is manageable. Trismus would mean not manageable. That is the difference. So especially you see this is the entire anterior segment is available for us to do. Posteriorly it is gone into the tongue. It is involving the floor of the mouth, not likely to be resectable. So look for the retromolar trigon, and then finally look for the parotid and submandibular ducts opening, because they may be obliterated, blocked, infiltrated. And where are they opening? Where do the submandibular ducts open? Where do the parotid ducts open? Somebody needs to answer for me to carry on. Otherwise, it looks like a monologue. Yes? Simple question. Where does the parotid duct open? No, you, first one. No, you start speaking. Mic will come.
Second molar.
Opposite the?
Up. Second molar.
Second molar in the vestibule. Okay? And where do you palpate for the parotid duct? You want to answer? Give it to her. Last one. This is where you see it. Where do you palpate?
Masseter muscle. Masseter muscle.
Where? Please, good, you're right. All of you clench your teeth. Clench it hard. Take your finger. I have to speak, so I'll not be able to do it. So take your index finger, clench your teeth, and go anteriorly, not there, in front. And as you roll it, you feel a cord-like structure. That is your parotid duct. Most of you have been able to feel it. Movements of the tongue you need to see, as I mentioned. Lastly, examine for cranial nerves. 9, that's done. You got it. Everybody has got a parotid duct, don't worry. They're searching whether I have or not. So, okay. Examine the 9th, 10th, 11th and 12th cranial nerves. Where do you look for them? I'll quickly wrap up in one go. Ask the first thing you did, you already checked for the facial. So I don't need to waste time on that. Ask the patient to open the mouth. Listen carefully, no talking. I'm not wasting time. You listen so that I don't have to repeat. Ask the patient to open the mouth, no deviation, facial is all right. Ask him to stick out the tongue. If there's no deviation, 12th is fine. Okay? Are you hearing? Ask him to take the tongue inside, but to say ah. As he says ah, look at the soft palate. It moves up. Speak.
9, 10, 10.
Very good. 9, 10, both sides moving up simultaneously. But one side moves, the other side doesn't move. It is called upturned curtain sign. What is it called? What is it called? You two different classes or what? Why don't you speak simultaneously? When they speak, then they wait. Upturned curtain sign is, you've seen in old theaters where they would put two curtains, one boy to do it. So he'll go to the one corner, lift up one side. So one side is up, one side is down. That is the basis to it. 9th cranial nerve. And gag reflex is 10th. But general movement takes care of it. 12th, I've already told you. So 9, 10. You're saying something? So 9, 10th, 11th and 12th. 11th would be seen where? What does 11th supply? Sternocleidomastoid, but more importantly, trapezius. And what does it do? Shrugging. So make the patient shrug his shoulders, and your book says against resistance, but that's not required. You should be in front watching it. If it moves up, all right, the spinal accessory is also normal. So you will then do the systemic examination. Now I'll give you a test. Examination of the neck is the last thing. These are the levels of lymph nodes. You all know that. Most of the students know it. Most of the books have it, even his book has it. Neck nodes start from here.
Mental, submandibular, upper jugular, middle jugular, lower jugular, posterior triangle.
So there are 1, 2, 3, 4, 5. One is divided into 1A and 1B. Submental is 1A, submandibular is 1B. And then you divide sternomastoid into 3 parts, upper, middle, lower. 2, 3, 4. 5 is posterior triangle, and 6 is central, or what you we're seeing in thyroid. That is the pretracheal, paratracheal group of lymph nodes. The center one being the Delphian node, which you are taught in your ENT with the larynx, pre-laryngeal lymph node. Which group of lymph node is involved? Yeah, so level, shout, level 2 most probably. And this would be level 5. And once you have done that, you've done very well. Now you can't make out anything. There's a node here, level 5. Tell me, what do you observe in this picture? It's a quiz test for you. There is a lesion, and there's another one, and what do you see generally? It's a predisposing condition, that's why I'm asking. It's a skin condition. This patient has no pigments, you can see that. So I've given you a background. He's an albino. I operated on this patient 6 times. He had 6 cancers at different phases in head and neck. 6 times. Okay? Actinic keratitis, predisposing. Seborrheic keratitis, predisposing. And absence of pigment predisposes to both squamous cell and other cancers, and melanoma included. Don't confuse it with basal cell carcinoma. This is what happened. Patient kept getting treatment for that. You see it is infiltrating. It is a squamous cell carcinoma looking at the appearance of the edge, but it's lying in that dangerous area. So you think it is a basal cell carcinoma. One last thing that I want to share with you is you will have to tell me all the findings. I hope it plays. It's a 30 seconds video. That's how it's playing. You see this? Mouth opening is adequate. The lesion is involving the lip. Gingivobuccal sulcus, keep talking. Going through the floor. No, it will play. I have stopped it. It's not playing there. Okay, I'm sorry. But you are still answering. I'm wondering how. Well, this is Pavlovian, right? Now you can see all the findings. Lip, gingivobuccal sulcus, mandible, floor of the mouth. All in one. But the mouth opening is still adequate. So don't write them off. They're still manageable. So we'll take care of these cancers after investigating. I will not take you there. You can watch my videos on head and neck cancers, breast cancers, penile cancers, thyroid cancers. They're all there. Most of the things are described. I'm just trying to give you a light. We move the tongue up to see that tongue is also free. So it's just confined to anterior segment. See that? Tongue is free. And the cranial nerves are also free. So they look ghastly, but they're manageable. And this is the most common cancer that you'll encounter, especially in the rural areas. I tried to touch some parts of head and neck examination and tried to give you a background to some of the other examinations. If there are any questions, you can ask me, otherwise I'm done. Any questions? Thank you. Thank you very much.
Thank you so much, sir, for helping out our audience and participants set things straight. I really hope that all our students have made best use of your session today. Thank you once again, sir.
All right, everyone. It is time to put your UG minds to work. Time for a case presentation. Well, to present a case on the topic of thyroid swelling, let me welcome to the stage Daphne, Nishita and Nitya from the final year MBBS SMIMS to assess and evaluate our students. Okay. May I have the privilege of welcoming back to the dais Dr. Chintamani sir, Dr. Nirmal Kumar sir and Dr. Makhanlal Saha sir. Please help me welcome them with the largest round of applause.
To introduce our guest speaker for the session, may I extend my invitation to Dr. Alexa, Professor, Department of General Surgery, SMIMS.
We're in a hurry. We've taught you also you should make a presentation, and we'll quickly wind up. Can we have the slides, please?
So I'm very happy to introduce Dr. Nirmal Kumar. He is Associate Professor of Surgery, Thoothukudi Medical College. I am proud that he was my postgraduate when I joined as an assistant. So he's a very enthusiastic surgeon. He was a very good PG. He, along with Dr. Kannan, was a plastic surgeon now. So I am happy to have him, my student, as the guest speaker. So he is interested in laparoscopic surgeries, and he is a very innovative and a very pleasing surgeon. He's a very good teacher for the PGs as well as UGs. Thank you, Nirmal, for coming.
Good afternoon, one and all. Good afternoon, sir. I'm Daphne Sharon, final year MBBS. This is Nishida and this is Nitya. We'll be presenting a case of thyroid swelling.
You already know it. We'll find out, right? Use this mic and start presenting.
51 years old lady residing at Takkalai, who is a housewife by occupation, belonging to the lower socio-economic status according to the modified Kuppuswamy scale, presented with the chief complaints of swelling in front of the neck for the past 2 years. History of presenting illness. The patient was apparently normal 2 years back, after which she noticed a swelling in front of the neck which was insidious in onset and has gradually progressed to attain the present size. No treatment was taken during this period. No history of sudden increase in size. No history of difficulty while breathing, difficulty in swallowing, change in voice. No history of unintentional weight loss, tremors, insomnia, excessive sweating, anxiety, palpitation, diarrhea. No history of weight gain, lethargy, excessive hair loss, cold intolerance, constipation. No history of pain over swelling. No history of bony pain. Not a known case of diabetes mellitus, hypertension, asthma, epilepsy. Past history. No history of similar complaints of thyroid swelling in the past. No history of previous surgery. No history of radiation exposure. Drug history. No history of drug intake. Allergic history. No history of significant allergic history. Personal history. She follows a mixed diet. No excessive consumption of goitrogenic foods. Her appetite is normal. She has adequate sleep. Her regular bowel and bladder habits. No addictive habits. Menstrual history. She attained menarche at 13 years. Regular cycles every 28 days. She attained menopause at 50 years. Family history. No history of thyroid swelling in the family. Summary. 51 years old lady presented with a painless, gradually progressive swelling in front of the neck for the past 2 years with no features of hypothyroidism or hyperthyroidism, no features of malignancy and no history suggestive of pressure symptoms.
Good. Housewife is now called home baker. They also are doing something, right? So home baker. Most of the history is self-explanatory. You mentioned about, if you can go back, I can tell you a few more things, but we'll keep it very simple. Unintended weight loss was smartly done. Drug intake was smartly covered, and the size of the swelling.
You said there is a swelling, but you have not mentioned when she first noticed the swelling. What is the size? How it is growing? Is it confined to the midline or it is extended to the sides? Because that will give a lead that it's a swelling involving the both lobes of thyroid gland, or it's a swelling confined to one lobe.
In any case, swelling, you have to tell us approximately how big.
At the onset, when she first noticed it.
So it was, she must have told you, this big, this big.
It's a peanut shape.
Oh, there you are. I wanted you to say that again. No peanuts. When you throw peanuts, only monkeys come. No peanuts, groundnuts. So tell me the size.
Across, around 2 centimeters.
Excellent.
initially.
Give a round of applause. At least that gets corrected. And what is the size now?
It is 7 centimeters horizontally.
So how many
and 5
times it has grown? At least 3 times. So we know that is all that we wanted to know. Whether it looks like a groundnut or peanut or that is not important.
And the next part, when you say about the symptoms of hyper or hypothyroidism, make it methodical. Start with the GI.
Yes, sir.
No history of loss of appetite, no weight loss, no diarrhea. Come to cardiovascular, mention that. Go to neural. So you are writing diarrhea here, and after 2 lines writing constipation. So make it sensible that you are starting with the system and taking each of the system, ascertaining whether patient has any symptom of derangement system which will suggest hyper or hypothyroidism. That is a better way of presentation.
In any case, for future you can do that. He is very right. There is no history suggestive of hypo or hyperthyroidism. Leave it to them to ask what are those features. Or if you want to be extra, smart, then you can say no history suggestive of hypo or hyperthyroidism in the form of 1, 2, 3, 4, 5. Then symptom-wise you can describe it. Otherwise you don't need to keep that. You can keep that answer up your sleeves. When you're asked, reply. But reply based on systems. That is absolutely right. Any question?
Regarding the pain over the swelling, when do you get that? What do you expect?
Thyroiditis and in hemorrhage and in malignancy.
Yes. Let's go to the examination. In the menstrual history, what was your interest actually? I'm sorry.
Oligomenorrhea or...
So she's postmenopausal, right? So the moment you say she's postmenopausal, the menstrual history is not going to be important for us. But it is important to know, you mentioned 13 years menarche, regular cycle every 28 days, menopause 50 years. Now if she's postmenopausal, how would that history help? It can still help, but let us know.
Estrogen, long acting.
No, that's okay. So you would specifically be asking in context of hypo or hyperthyroidism. That is what I was trying to ask you. But now she has got no, menstruation. She's postmenopausal. So it may not be that relevant. Otherwise it's important. Any relevance of obstetrics history? In general, in patients with thyroid?
Suppose patient is infertile. She has not born children.
Or patient has, right? A patient has missed abortions, history of missed abortions, or menorrhagia, which you mentioned in the menstrual period. You're basically linking it to something. No? In obstetrics history of abortions, infertility, would they be relevant? They will be. Because they are features of hypo or hypothyroidism. So they become important. Otherwise it's okay. Examination.
General examination. Consent was taken. The patient was examined in a well-lit room. The patient was conscious, cooperative, and oriented to time, place, and person. Performance status according to Karnofsky scale 80. Moderately built and nourished. Hydration was adequate. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. Vitals. Pulse rate was 86 beats per minute. Regular rhythm, normal in volume, no specific character, no vessel wall thickening, no radiofemoral delay, equally felt in all peripheral vessels. Blood pressure was 130/80 millimeter mercury, measured in the right upper arm. Respiratory rate 14 breaths per minute, and temperature was 98.6 degree Fahrenheit. Examination of the neck. The patient was examined in a well-lit room with adequate exposure and privacy in sitting position, with myself in front of the patient with eyeball to eyeball and in the presence of an attender. Inspection. And avoid swelling of approximately 7 × 5 centimeter situated in the thyroid region, extending superiorly up to the level of thyroid cartilage, inferiorly about 2 centimeter above the suprasternal notch, and laterally up to the anterior border of the sternocleidomastoid. The surface was nodular, lower border was seen. The swelling moves with deglutition. Skin over the swelling was normal. No other visible swellings in the neck. The trachea appears to be in the midline.
Palpation. All inspectory findings are confirmed. No local rise in temperature, non-tender. Swelling of size 7 × 5 centimeter, ovoid in shape, involving both lobes and isthmus. Surface is nodular, well-defined margins. Multiple nodes were palpated, firm in consistency. Lower limit palpable. Trachea confirmed to be in the midline. No other swelling palpable in the neck. No palpable thrill. Carotid pulse felt on both sides. Percussion not done. Auscultation no bruit heard. Other system examination. Cardiovascular system S1 S2 heard. No murmur heard. Respiratory system, normal vesicular breath sound heard. Central nervous system, no focal neurological deficit. Per abdominal examination, no organomegaly, no free fluid. Examination of skull and spine is normal. Summary, 51-year lady presented with a painless gradually progressive swelling in the anterior aspect of the neck for the past 2 years. On examination, an ovoid swelling of size 7 × 5 cm with nodular surface, well-defined margins and firm in consistency. Diagnosis, 51-year lady with multinodular goiter, clinically in euthyroid state, likely benign with no pressure symptoms.
Huge round of applause for them. Very nice. Now, you mentioned about carotid pulsations.
Yes.
Where did you palpate for them? You were taught, so I'm asking.
Transverse process of the 6th cervical vertebra.
At the level of? Upper part of the thyroid cartilage. Some say cricoid. But actually, you're not palpating the carotid, you're not palpating carotid loosely. It's a common carotid. That's where the bifurcation happens. You feel it against the shy shag next tubercle, which is also called the carotid tubercle, C6 transverse process. Did you palpate both sides at the same time?
No, sir.
Why no?
It could produce syncope.
Speak.
It could produce syncope.
Why?
So because of it will stimulate the baroreceptors and cause
Very good. Round of
shock.
applause again. I was waiting for you to say that it will cut off the blood supply to the brain, which it does not. Because the blood supply to the brain, in the circle of Willis, you have vertebro-basilar system also. So you cannot stop the blood supply. So if you want to kill somebody in future, don't press just the carotids. Need to take care of the vertebro-basilar also. Is that okay? And we examine one at a time. Secondly, when you're actually mentioning in your examination, I didn't notice, maybe you mentioned, there were no clinical signs of thyrotoxicosis, eye signs or other signs. Then the examiner may ask you, may not ask you, entirely his or her prerogative. You don't need to do Pemberton sign in all. If you can see below, the swelling is below, no history, nothing. And as he rightly said, Cocker's test you don't do. How do you do Cocker's test, by the way, if you have to do?
Gentle compression on lateral lobes one at a time, and it produces stridor, then Cocker's test is positive.
So we don't normally do it because it is not right to the patient. It's the same thing as knee-elbow position. You don't need to establish it by pushing. There are too many false positives in this. You can press it too hard. But most people do a mistake of saying that we'll compress from both the sides. One hand is a passive hand, the other side you push. Then this hand becomes a passive hand, the other side you push. Otherwise you don't do it. It's not required.
You have described this as a ovoid swelling, but at the end you are saying involve both lobes and the isthmus. So once the patient, you have not shown the picture also, if both lobes and isthmus are involved, it is likely to be a butterfly-shaped swelling. And as I said, if you have a dimension being described, you describe the dimension of each lobe separately. If it is same, you say 7 by 5 cm on each lobe. Otherwise, saying a ovoid swelling single, it appears like a...
Yeah, right. Show the picture quickly.
No, there is no picture.
No picture, no? So he's right. But at the same time, with due regards, I mean, we know what we are talking, both of us understand that. A typical butterfly appearance may not be seen. So there is no need to bother about the shape. Now, your diagnosis could have been 51-year lady with multinodular goiter, clinically euthyroid, likely to be benign with no pressure symptoms. This is all you are saying. No shape here. The goiter means enlargement of the thyroid only. So don't unnecessarily talk about the shape. If it is, first of all, it cannot be ovoid if it is involving both sides. Unless you tilt it the other way around. And you have no business to do that. You describe the dimensions, that is enough. It is involving both sides. Let's come to your, the good points of your presentation. You mentioned 51-year-old lady, no question for that. Why is it multinodular goiter?
Multiple nodules were palpated.
One is, there are multiple nodules palpable. How do you define a solitary thyroid nodule?
Only one nodule is palpated and the rest of the gland is not palpated.
Excellent.
Good. Very
Why? If the rest of the gland is palpable, why does it become multinodular? Nodule is still one.
Hyper.
Because the normal thyroid gland is not palpable. It's an abnormal gland, and that becomes a nodule itself. That is one nodule plus one. So it becomes 1 plus 1. That's how it's called multinodular. Solitary is, yes, you're right. But some people have asked this question many times in very classes that we do across. The single, solitary, discrete, and the only swelling. So that's what they say. There is only one single, solitary, discrete swelling. They all mean the same. So you don't need to say there is only means one solitary, discrete swelling. It is a common jargon that we hear. So it is solitary thyroid nodule or multinodular goiter. There is nothing in between. Excellent. We will not ask you any more questions except two. One is, did you examine this patient or it's all a created case?
Examine the patient.
Was this patient anxious?
No.
Okay. How did you establish that?
Sorry, sir?
How did you establish that the patient is not anxious?
So her hands were not wet.
Brilliant. Give her a round of applause. It's a 50% answer. The remaining 50% I'll tell you. Therefore, all patients make it a habit to shake hands. The moment you hold it, you will know the tremors inside your hand. They don't have to do outstretching. They don't have to do outstretching. And don't mention about tongue tremors ever. Tongue tremors are not seen. When you're looking for the unintentional tremors, hand stretching. But when you hold the hand, the tremors can be felt. And the moistness can be appreciated. And the rest of the anxiety is with the pulse rate. Okay? So be happy with your diet. How do you proceed since you answered very well? We have 1 minute to go. What do you do for this case?
Thyroid function tests, then ultrasound neck.
What did I teach you yesterday?
What thyroid function test?
Confirm the diagnosis.
Yeah, speak into the mic.
So to confirm the diagnosis, we will do ultrasound neck. Then to support the diagnosis, we will take a thyroid function test, then FNAC. Then
All right, I'll answer that. There is triple test in breast? Yes or no? Yes. There is triple test in thyroid also. Established. In fact, there is a quadruple test also. The triple test in thyroid is, please note it down, remember it forever. Good history and examination, followed by high resolution ultrasound, followed by FNAC after doing the thyroid function test. Can you repeat what I said?
So, good history and examination, followed by high resolution ultrasound, and followed by FNAC after doing ultrasound examination.
Why? No, after doing thyroid function test.
Yes.
Why is it mandatory to do thyroid function test before doing FNAC?
So FNAC is an invasive procedure, so it might cause disturbance to the anatomical structure.
That is already covered. Don't reuse that again and again. If you do FNAC in a, yes.
In hyperthyroid state, we can't do FNAC because it is highly vascular and it may lead to hemorrhage in the gland.
And?
Thyroid storm.
Excellent. Round of applause. You answered it very well. Now add the third one now, which you won't find in your book. You may get false positive for cancer because atypia, proliferative cells will appear, so the cytopathologist may get confused. He or she may give a diagnosis of malignancy. So, repeating, vascular, so it will bleed. 2, you can precipitate thyroid storm, and 3, you can get false positive in the form of atypical cells, etc. So, triple test is done. Quadruple, some people call these together as quadruple. Some people call gene panel as the fourth part of it. So that's your answer. But your answer should remain. Before we conclude, we'll probably catch up some other time. Always say investigations to confirm the diagnosis, to support the diagnosis, to stage a disease, and to treat the patient.
This patient
it gets covered.
This patient is clinically euthyroid. When you say thyroid profile, what do you mean? What do you like to do?
This patient, in your diagnosis only you mentioned, clinically euthyroid. You're going to do thyroid profile, thyroid function test. So what are those tests?
T3, T4, TSH,
If you are allowed only one,
thyroglobulin.
TSH.
TSH.
Okay?
TSH is a screening test.
That's a test. Others are, they are doing it, so they do it also. So they are not so reliable. TSH is important. And you can do thyroglobulin, but that's not required at diagnostic stage. Okay? And based on your result, why I'm saying high resolution ultrasound, how do you report in thyroid? How do you report a mammography in breast? BI-RADS. So how do you report ultrasound in thyroid? TIRADS. How do you report it in prostate? PIRADS. How do you report it in liver? LIRADS. Easy? Round of applause. You all answered it. So we'll do the TIRADS. What is used for the cytological grading? What scoring?
Bethesda.
Bethesda scoring. Very good. Brilliant. Very good students. And if you know both of these, your answer is all done. Theory, practical, everything done. With that, we can actually conclude it. Is that okay?
You have done an ultrasound, and ultrasound reports came back saying that there are some complex cysts. What do you mean by that? What do you mean by complex cyst in a thyroid gland?
No.
Nodule, nodule, warm nodule.
Complex cyst is what?
Is a cyst with a complex, right?
It contains both solid and
cyst with a complex, I gave you a hint.
And then you want to do a FNA. From where you should hit the needle?
What should you hit? Cystic or the solid?
Solid.
Solid, yeah. Now, anything complex would mean any individual with complex. He is not normal, he is added baggage. So same, cyst should be fluid only. Cystos means bladder, fluid only, but if there is solid in it, it becomes complex cyst. And we always do guided FNAC, that's why I was saying. Otherwise you'll hit the cystic fluid. So then guided FNAC, you can go for the solid part.
The report is papillary carcinoma. What treatment you will offer this
You won't go then.
Papillary
He was
carcinoma
rushing
is
for the
report.
flight, so. FNAC is papillary carcinoma of thyroid. What is the treatment? Answer the question. Yes.
Total thyroidectomy.
Total thyroidectomy. Very good. Why?
To prevent, because of further complications, recurrence.
Papillary. He wanted to. No, you are right, but important question.
What you said, this is tumor, this is a multiple body involving both lobes. So this is more relevant if you are confined to one lobe, then question comes hemi or...
No, she said total only.
Yes.
You said total only.
Total thyroidectomy.
So if it is papillary or whatever, benign also, total thyroidectomy. There are only two thyroidectomies. Hemithyroidectomy means lobe plus isthmus. Total thyroidectomy means double of that. Done? If you are attempting total, when you are doing on one side, you can't find the parathyroid or recurrent laryngeal nerve, then you don't want to take a chance on the other side, so you leave a sheet of tissue, which is called near total thyroidectomy, also called as Hartley-Dunhill procedure. Repeat.
Hartley-Dunhill procedure.
Not Harley-Davidson. Hartley-Dunhill procedure. One lobe, isthmus, and most of the other side, leaving a sheet of tissue. There is no subtotal thyroidectomy now. It's obsolete. And especially bilateral disease, you can't do hemithyroidectomy. So that is it. You answered very well. Papillary, why do we do total thyroidectomy was the question which probably you couldn't answer. People feel it is multicentric. Number two, it spreads by lymphatics, which are intrathyroidal also. And yes, papillary cancer is where you talk about 20-year survival. It's a very good cancer if you want to wish somebody. Don't wish anyone, but this is to somebody at least a lesser curse. Lymph node involvement is another reason why you should be doing total, so that you can manage the patient better by following up the thyroglobulin level, which is a tumor marker for these, and following it up using the TSH levels and thyroglobulin levels to assess the outcome. But you did well. Well done.
Thank you, sir.
Thank you, Daphne, Nishida, Nitya, for that very well-prepared case presentation. I hope all our audience and presenters are now aware as how to manage your vivas. Thank you so much, professors, for evaluating our students. It gives me immense pleasure to have been part of a session with two of the greatest giants in the field of surgery, Dr. Chintamani sir and Dr. Makhanlal Saha sir, who flew all the way from their respective stations to SMIMS to grace our program with their presence. Sir, we deem it our greatest honor to have been in your attendance. On behalf of our audience, we extend our sincere most thanks and gratitude for gracing this session. To bestow a token of our love and appreciation, may I request the entire General Surgery Department SMIMS to join us on stage along with guest speakers. Please, Professor. Let us give a large round of applause. Come on, everybody. Thank you so much, professors. Well, guys, that brings us to the end of. I would like to thank our beloved professor, Dr. Pandey sir, scientific coordinator of this session, for making this session a one to remember. And on that note, you are all free to go for lunch. Please follow the drill and stay back until the faculty members have left the hall. Enjoy your meal and please be back by 2:15. Thank you all.
Now please hold on for a moment. I did not talk to you before I leave. I must tell you, this has been maybe, I don't know how many years I've been teaching, but it's one of the best batches of students that I've been involved in teaching. And for this, the credit goes to your mentors, the way they have taught. And of course to all of you for being so passionately involved. Some of you were chatting, but I thought you were chatting about what was happening, so that's fine. And especially for somebody to organize, Shailaal, such a pleasure to see you. It is such a joy to be part of an academic feast where students are involved and they're actively participating. We keep doing these courses virtually also, the Scrubs course that I do in Delhi. Join it anytime you feel useful. You will be able to get a lot of information. For us, it was a pleasure. So thank you all very much for bearing with us for 2 days. Thank you. God bless you all. God bless.
I just wanted to come and say hello to you.
Such a pleasure. I was asking.
Hello. Hi.
Let us give friendliest, guys. Come on, give a big round of applause.
Good afternoon, everyone. We are final years and here to perform a role play. I'm Sneha. I would like to introduce the characters in my role play. Satyanarayanan is the doctor, Dr. Purusho. Sri Lakshmi is the patient Simran, Sneha is the patient's mother Meena Kumari, Jisvya is the senior resident, Rohit and Shirin are medical students, Disha is the nurse, Ahasha is the receptionist. Simran has an asymptomatic swelling in her neck for a long time now. Since it's not troublesome to her, they decide to wait for it to resolve on its own. The daughter is preparing for her exam tomorrow. Scene 1 at home.
മോളെ പഠിക്കുന്നുണ്ടോ?
ആമാ പഠിക്കുന്നു.
മോളെ இன்னைக்கு என்ன சாப்பாடு வேணும்?
പുട്ടും കടലയും മതി.
ശരി. വെള്ളം എടുക്കണോ?
വേണ്ട വേണ്ട.
എന്റെ മോള് ഭയങ്കര പാവ. എപ്പോ നോക്കിയാലും പഠിച്ചോണ്ടേയിരിക്കും.
അമ്മ തൊണ്ട വേദനിക്കുന്നു.
ശരിക്കും വേദന എടുക്കുന്നു?
ആമാ.
നീ എന്നാ അച്ഛനെ കളിയാക്കുന്നാണോ?
അല്ല അല്ല ശരിക്കും നോവുന്നു.
என்ன இது குறைய நாளாயிட்டு உண்டല്ലോ. இப்ப பாரு இப்படிதான். என்ன பண்றது? அந்த ஓமன தெருவுல அந்த ஷெர்வனோட பையன் இருக்கான்ல ட்ரிக்கி.
அது யாரு?
அது சின்ன வயசுல சொப்பு ஜாமா விளையாடுனீங்கல்ல, ஞாபகம் இருக்கா? சொப்பு ஜாமா. அவன் கூட அன்னைக்கு ஸ்ரீமுகாமிகா காலேஜ் தான் போனான். அங்க போயிட்டு நல்ல ட்ரீட்மெண்ட் எடுத்தாங்க. நமக்கு அங்க போலாம்.
இல்லம்மா எனக்கு படிக்கணும்.
ஒரு நாள் படிக்கலன்னா ஒன்னும் ஆகாது. நீ வா.
இல்லம்மா நான் வருന്നില്ല படிக்கணும்.
வா.
Simran and her mother rush to the hospital. Scene 2 in the reception of the Sri Mookambika Hospital.
சிஸ்டர் இங்க ஹாஸ்பிட்டல்
நீங்க ஹாஸ்பிடல்ல தான் இருக்கீங்க.
இந்த டாக்டரை பார்க்க போனோம்.
ஓபி கார்டு எடுத்துட்டு வாங்க.
சரிங்க. மேம் இந்த ஓபி கார்டு எடுக்க சொன்னாங்க.
உங்களுக்கு இப்போ என்ன பிரச்சனை?
என்னோட பொண்ணுக்கு ரொம்ப நாளா இங்க வீக்கம் இருக்கு மேம். அதனால எந்த டாக்டர் பார்க்கணும், எப்படி
அப்படியா? நான் உங்களுக்கு ஓபி கார்டு ரெஜிஸ்டர் பண்ணி கொடுக்குறேன். நீங்க வந்து சர்ஜரி டிபார்ட்மெண்ட்ல டாக்டர் புருஷோத் இருக்காங்க, அவங்கள போய் பாருங்க.
புருஷனா?
இல்ல டாக்டர் புருஷோத்.
சரிங்க சரி. ஓகே.
Scene 3 in the surgery OPD of SMIMS.
ஏய் ஜிதின் வாங்க
சார். சொல்லுங்க சார்.
சரி கேஸ் எடுக்க சொன்னேனே, கேஸ் எடுத்தியா?
எடுத்தேன் சார்.
அப்படியா? என்ன கேஸ் எடுத்த?
சார் ஹெர்னியா எடுத்தேன் சார்.
இரு 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 உன் கூட இன்னொருத்த இந்த போஸ்டிங்ல இருந்தானே, அவங்க?
அனந்து சார்.
அனந்து அவன் எங்க இருக்கான்?
சார் அவன் வந்து கேண்டீன் போயிட்டான் சார்.
கேண்டீனா? போய் அவனை கூட்டிட்டு வா. என்ன பண்ணிருக்காங்க அங்க வந்து?
பொண்ணுங்களோட பேசிட்டு போனேன்.
பொண்ணு? டேய் போய் கூப்பிட்டு வா, கூப்பிட்டு வா.
ஹலோ செல்லம், சாப்பிட்டியாமா? இப்ப எங்க இருக்க?
அனந்து சார் கூப்பிடுறாரா?
டேய் இருடா இருடா, நான் ஒரு 10 நிமிஷம் கழிச்சு கூப்பிடுறேன். என்னடா
சார் கூப்பிட்டு இருக்காரா நம்மள?
என்ன சார்டா?
டேய் புருஷோத் சார்.
புருஷோத் சாரா?
ஆமா
ஐயா வந்துடா.
கேஸ் ரெடி பண்ணிட்டியா?
இல்லடா.
சத்தனி.
ஏய் நீதானே அவன்? வாட் நேம்? வாட் நேம்?
அனந்து சார்.
அனந்து எப்ப பார்த்தாலும் பொண்ணுங்களே பேசிட்டு இருக்குது. உனக்கு வேற வேலையே இல்ல. இவனை பாரு, ஜித்தனை பாரு, படிச்சுட்டே இருக்கான். எப்ப பார்த்தாலும் வார்டுல இருப்பான், என் கூட இருக்கான். உனக்கு கொஞ்சாச்சு இது இருக்காடா? அச்சே
சார், நீங்க வேற யார கூட நம்பலாம் சார், ஆனா ஜித்தனை நம்பவே கூடாது சார்.
ஏன்டா அப்படி? ஜித்தனை ஏன்டா அப்படி?
சார் அவன் போனை வாங்கி பாருங்க சார்.
போனா?
ஒண்ணுமே இல்ல சார் போன்ல.
சரி கடைசி வரைக்கும் யாருமே நல்லவனா இருக்காதீங்க. சரி ஓகே, ஓபில கேஸ் வந்திருக்கும், நம்ம போய் கேஸ் பாப்போம். ஓகேவா? சரி வாங்க கேஸ் பாப்போம். சைன் ஆகும்.
நியூ கேஸ் வந்திருக்காங்களா?
வந்திருக்காங்க.
என்ன கேஸ்?
தைராய்டு கேஸ்.
தைராய்டு கேஸ்.
டாக்டர் இருக்காரா?
மெடிசினா?
ஸ்டூடண்ட்ஸ் கூட இருக்காரோ?
ஆமா சும்மா பேசிட்டு இருக்காரு.
லைக் பேஷண்ட் ஸ்டூடண்ட்ஸ் அப்படியே காட்டிடலாமா?
காட்டிடலாங்க.
ஓகே பேஷண்ட் 2 days
சிம்ரன் உள்ள வாங்க.
அம்மா விളിക്കുന്നു.
நீ இந்த கேஸ் வார்டுக்கு ஷிஃப்ட் பண்ணிடு.
ஓகே சார், ஷிஃப்ட் பண்ணுங்க.
அந்த 19-year-old சிம்ரனா?
ஓகேவா?
இல்ல நான் பேஷண்டோட மம்மி.
அந்த இது
Yay, mommy superstar!
சரி சரி. ஓ நீங்க தான் பேஷண்டா? ஓ சாரி. ஓகே. நம்ம என்ன டாக்டர் புருஷோத்தை பார்க்க வந்திருக்கீங்க?
ஆமா ஆமா ஆமா.
ஓகே. டாக்டர் உள்ள இருக்காரு. இங்க வாங்க.
ரெண்டு அட்மிஷனா? ஓகே. ஏதோ எஸ்ஆர் வர.
எக்ஸ்கியூஸ் மீ டாக்டர்.
சொல்லுங்க.
தைராய்டு பேஷண்ட் வந்திருக்காங்க 19-year-old.
அப்படியா? ஓகே.
உள்ள வர சொல்லட்டுமா டாக்டர்?
உள்ள வர சொல்லுங்க.
ஓகே உள்ள வாங்க.
வணக்கம்மா. என்ன பிரச்சனை?
வணக்கம் சார். என்னோட பொண்ணுக்கு வந்து ரொம்ப நாளா இங்க ஒரு வீக்கம் இருக்கு சார்.
அப்படியா? முதல்ல நீங்க உட்காருங்க, நல்லா உட்காருங்க. உட்கார்ந்துட்டு நம்ம பேசுவோம்.
சார் இவ்வளோ நாள் ஒரு தொந்தரவும் இல்லை, ஆனா என்ன ஆச்சு இன்னைக்கு திடீர்னு சட்டுன்னு அப்படியே வாய்ஸே மாறிடுது சார். அது ரொம்ப கஷ்டமா இருக்கு சார். என்ன?
அப்படியாமா? ஆமாம்மா, ஆம்பளை கலர் மாதிரி இருக்கு. சரி பரவாயில்ல, பார்த்துக்கலாம். ஓகே சொல்லுங்க
சார். இப்ப என்ன பண்றது? இன்னைக்கு தான் ஒரு மாதிரி இது, நாளை எக்ஸாம் வேற இருக்கு. என்ன பண்றது?
பயப்படாதீங்க, நம்ம வந்துட்டீங்கல்ல, மூகாம்பிகா வந்துட்டீங்க, எல்லாமே சரியாயிடும். ஓகே. நம்ம இப்போ பண்றதுக்கு முன்னாடி நான் என்னை இன்ட்ரடியூஸ் பண்றேன். என் பேரு டாக்டர் புருஷோத், நர்ஸ் சொல்லியிருப்பாங்க. இதுதான் எங்க ஸ்டூடெண்ட்ஸ், என் ஸ்டூடெண்ட்ஸ். இவங்க தான் எஸ்ஆர் நர்ஸ். எதுக்கும் கவலைப்படாதீங்க. இப்போ பண்ண போற ப்ரொசீஜர்லாம் நம்ம சொல்லுவோம், பயப்படாதீங்க. இப்போ உங்ககிட்ட லைட்டா கொஞ்சம் கேள்வி கேட்போம், அதுக்கு நீங்க பதிலும் சொல்லுங்க. அண்ட் இது முதல்ல நம்ம இன்ஸ்பெக்ட் பண்ணுவோம். அம்மா கொஞ்சம் கழுத்தை கொஞ்சம் நிமிர்ந்தா இருக்கு பார்த்துங்க. சரி ஓகே. எஸ்ஆ நீங்களும் கவனிச்சுக்கோங்க, இன்ஸ்பெக்ட் பண்ணிருக்கோம். ஓகே. கொஞ்சம் எச்சி முழுங்குமா. ஓகே. உங்களுக்கு தெரியுதுல்ல? டேய் ஸ்டூடெண்ட்ஸ், யாரை பார்த்துட்டு இருக்க? போய் பாரு.
ஆண்டி கொஞ்சம் தள்ளிக்கோங்க ஆண்டி. தேங்க்ஸ் ஆண்டி.
டேய் உத்துப்பா, ஏன்டா இப்படி இருக்கீங்க? வாங்கடா. சரி ஓகே. என்ன தெரியுது உங்களுக்கு?
சார் நெக் ஸ்வெல்லிங் சார்.
நெக் ஸ்வெல்லிங், குட். என்ன ஸ்வெல்லிங் இருக்கும்? தைராய்டு, வெரி குட். எதை வச்சு சொல்றீங்க? ஏ சூப்பர்ரா, பொண்ணுங்கிட்ட மட்டும் இல்ல, படிக்கவும் செய்றீங்க. வெரி குட். பரவாயில்ல. ஓகே சரி. ஓகே சார், நம்ம என்ன எப்படி ப்ரொசீட் பண்ணலாம் சொல்லுங்க.
எக்ஸாமின் பண்ணலாம் சார்.
வெரி குட். ஓகே. ஸோ எக்ஸாமினேஷன்ல பால்பேஷன் பார்ப்போம். ஸோ what are the methods of palpation?
கிளாசிக்கல் மெத்தட்.
ஓகே.
லாஹேஸ் மெத்தட்.
ஓகே.
வேற தெரியாது சார்.
சரி விடு, நம்ம கிளாசிக்கல் மெத்தட் பண்ண தெரியுமா?
பண்ண தெரியும் சார்.
உனக்கு
பண்ண தெரியும் சார்.
டேய் அனந்து, இரு நீ பண்ணிக்காமி. இரு என்ன பண்ற? முதல்ல இவங்கிட்ட நீ போக்கே சரியில்லை, பண்ணிக்காமி. யாரா புடிச்சு கொல்லவாடா பாக்குற?
இது நடிக்கிறேன் சார்.
சார் நானா நடிக்கல சார்.
சரி ஓகே. இனஃப் ஃபன். நீ பண்ணு. இப்போ நான் பண்ணி காமிக்கிறேன் கிளாசிக்கல் மெத்தட். முதல்ல பேஷண்ட் உட்கார சொல்லணும். அதுக்கப்புறம் பேஷண்ட்டை நம்ம இன்ட்ரடியூஸ் பண்ணணும். ஓகே, இதெல்லாம் ஒரு லெசன். 2 நிமிஷம் தான்மா, பண்ணி முடிச்சுட்டு நாங்கள் வரோம். ஓகே. ஸோ வணக்கம் ஐயா, என் பேர் டாக்டர் புருஷோத்தமன். ஒரு சின்னதா ஒரு எக்ஸாமினேஷன் மட்டும் பண்ணணும், பால்பேஷன் மெத்தட். ஓகே. ஸோ ஸ்டூடெண்ட்ஸ், நம்ம இப்போ பண்ண போகிறது என்ன மெத்தட் சொன்னோம்? கிளாசிக்கல் மெத்தட். ஓகே. ஸோ கிளாசிக்கல் மெத்தட்ல என்ன பண்ணோம்னா, பேஷண்ட் முதல்ல உட்கார வச்சுட்டு அவங்க கிட்ட இன்ஃபார்ம் கன்சென்ட்லாம் வாங்கினதுக்கு அப்புறம் நம்ம பேஷண்டோட பின்னாடி போயிட்டு பேஷண்ட் கிட்ட நெக்கை ஃப்ளெக்ஸ் பண்ண சொல்லணும். கொஞ்சம் ஃப்ளெக்ஸ் பண்ணு. ஓகே. ஸோ அதுக்கப்புறம் நம்மளோட 3 ஃபிங்கர்ஸ் எடுத்து 2 சைடு 3 ஃபிங்கர்ஸ் எடுத்துட்டு அது நம்ம தைராய்டு கிளாண்டை பால்பேட் பண்ணணும். பால்பேட் பண்ணும்போது ஏதாவது ஃபைண்டிங் தெரியுதா? இதுதான் கிளாசிக்கல் மெத்தட். ஓகே. நெக்ஸ்ட் வேற என்ன மெத்தட் சொன்னோம்? லாஹேஸ் மெத்தட். ஓகே. லாஹேஸ் மெத்தட் எப்படி பண்ணணும் தெரியுமா?
சிங்கிள் லோபுக்கு.
வெரி குட். சிங்கிள் லோப்ல தான் பண்ணணும். அது பண்ண தெரியுமா உன்னால?
தெரியாது சார்.
ஓகே. லாஹேஸ் மெத்தட்ல, கிளாசிக்கல் மெத்தட்ல நம்ம பின்னாடி நின்றோம், லாஹேஸ் மெத்தட்ல முன்னாடி வந்து பண்ணணும். முன்னாடி பண்ணும்போது எப்படி பண்ணணும்னா, ஃபர்ஸ்ட் மறுபடியும் பேஷண்ட் கிட்ட இன்ஃபார்ம் எல்லாம் பண்ணிட்டு என்ன ப்ரொசீஜர் பண்றோம்னு சொல்லிட்டு, அதுக்கப்புறம் ஸ்வெல்லிங் இருக்கிற ஆப்போசிட் சைட்ல நம்மளோட தம்பை யூஸ் பண்ணி அந்த முதல்ல தைராய்டு கிளாண்டை பால்பேட் பண்ணி புஷ் பண்ணணும் டுவர்ட்ஸ் தி அதர் சைட். அது பண்ணும்போது there is a protrusion of the swelling to the other side. அது நம்மளோட இன்னொரு கை வச்சு நம்ம பால்பேட் பண்ணி பார்க்கணும். இப்படிதான். ஓகே. ஐ ஹோப் இட் இஸ் கிளியர். ஓகே. ஸோ there is one more method. அது என்ன சொன்ன? தெரியாதா? எஸ் சார், உனக்கு தெரியணுமே. கிரைல்ஸ் மெத்தட். Could you please show it? நான் உட்காந்துக்கடா, என்ன உட்காந்துருக்கே யூஸ் பண்ணிருக்கீங்களா?
ஓகே, நான் இப்போ உங்களுக்கு ஒரு எக்ஸாமினேஷன் பண்ணுவேன், பிரச்சனை எதுவும் இல்லைல்ல? உங்களுக்கு பெயின் இருக்குதா நெக்கில்? இல்லை, இப்போ பிரச்சனை இல்லை. நான் தொடர்ந்து உங்களுக்கு பெயின் இருந்துச்சுன்னா சொல்லுங்கள். Okay, so first, sir explained panna mari. First, I'll do the classical method. So, classical method, you're keeping your thumbs behind, like first warm your hands. And then you keep your thumbs behind the patient's neck and flex panunga. Okay. The 4 fingers vachu, you are palpating thyroid gland, margins and extension allan paakanum. And then, okay, sir, so on the live method, you push and palpate the other side. Because last one, stylish method. When you keep your thumb in the thyroid gland and ask the patient to swallow. Okay, sir. Okay, thank you. Thank you.
Super. So, உங்களுக்கு என்ன தெரிஞ்சிச்சு? ஏதாவது ஃபைண்டிங் தெரியுதா?
Non-tender solitary nodule swelling on either side is large and the swelling is also mobile.
Okay, that's good. So, நம்ம பேஷண்ட் கிட்ட சொல்லிடலாம். உங்களுக்கு புரிஞ்சிச்சு தானே?
புரிஞ்சிச்சு சார்.
ஓகே, ஸோ பேஷண்ட் கிட்ட சொல்லலாம். உட்காருங்க. ஓகே, அம்மா பெருசா பிரச்சனை ஒன்றும் இல்லை. ஒரு சின்னதாக கழுத்தில் ஒரு கட்டி இருக்கு. அந்த கட்டி லைட்டாக கொஞ்சம் பெருசாச்சு. அதனால பக்கத்தில் இருக்கிற ஸ்ட்ரக்சர்ஸை போய் கொஞ்சம் அடைஞ்சிருக்கு. அதனால தான் உங்களுக்கு மூச்சு முட்டுரும், அந்த ஆம்பளை மாதிரி குரல்லாம் வருது. பிரச்சனை இல்லை, நீங்கள் பயப்படாதீங்க. ஒரு பிரச்சனை இல்லை, நம்ம பார்த்துக்கலாம். சின்னதாக கொஞ்சம் டெஸ்ட்டுகளெல்லாம் எடுக்கணும். அந்த டெஸ்ட்டு எடுத்தால் நமக்கு ட்ரீட்மெண்ட் என்ன பண்ணணும் இதெல்லாம் பார்த்துக்கலாம். பண்ணலாம் இல்லை? ஓகே, நோ ப்ராப்ளம். ஸோ நம்ம எஸ்ஆரும் இவங்க கூடயும் போயிடுங்க, அவங்க சொல்லுவாங்க. ஸோ நீங்கள் போய் டிஎஃப்டி யூஎஸ்சி மட்டும் எடுத்துட்டு வாங்க. ஓகேவா? சரி, போயிட்டு வாங்க.
சார் எல்லாம் சரியாயிடும் தானே சார்? அவ வந்து பெரிய ஐஏஎஸ் ஆஃபீஸர் ஆகணும்னு ஆசைப்படுறா. அவ வந்து எப்பவுமே படிச்சுட்டே இருப்பா சார். எப்ப பாரு சாப்பிட கூட மாட்டா சார். அதனால பார்த்து பண்ணுவீங்க தானே சார்?
பயமே படாதம்மா, ஒரு பிரச்சனை இல்லை, நம்ம பார்த்துக்கலாம். ஓகேவா? சரி சார்.
சார் ரிப்போர்ட் வந்துச்சு.
டாக்டர், பேஷண்ட் யூதைராய்டு ஸ்டேட்ல இருக்காங்க. அல்ட்ராசவுண்ட்ல அவங்களுக்கு லார்ஜ் சிங்கிள் சாலிட்டரி நோடியூல் இருக்குன்னு வந்திருக்கு.
அப்படியா? ஓகே ஓகே, நோ ப்ராப்ளம்.
சார் எப்படி ப்ரொசீட் பண்ண போறோம்?
ஸோ பேஷண்ட்டை கூப்பிடுங்க. பேஷண்ட் சரி, ஓகே. ஸோ ஒரு சின்னதாக ஒரு ப்ரொசீஜர் பண்ணலாம். என்ன சொல்றீங்க? என்ன ப்ரொசீஜர் பண்ணலாம்? எஃப்என்ஏசி. ஓகே, குட். எஃப்என்ஏசி பண்ணலாம். ஸோ எஃப்என்ஏசி பண்ணலாம். அது சின்ன ப்ரொசீஜர் தான். ஆனால் அது இன்னைக்கு பண்ணால் கூட 4-5 நாளுக்கு அப்புறம் தான் ரிப்போர்ட் வரும். ஸோ மேட்டரில் ஒரு சர்ஜரி கூட பண்ணும். சர்ஜரி பயப்பட வேணாம். சர்ஜரின்னு கேட்டோன்னே இதெல்லாம் எதுக்கு பண்ணுறோன்னா அது மேலிக்னண்டா இல்லையான்னு பார்க்கறதுக்காக தான், வேற ஒன்றுத்துக்கும் இல்லை. பார்த்த வரைக்கும் நல்ல ப்ரோக்னோசிஸ் தான். சர்ஜரி பண்ணால் கூட நல்லா தான் இருப்பாங்க. அவங்களோட ஐஏஎஸ் ட்ரீம் எல்லாம் இதாகிடும். பரவாயில்ல. நாளைக்கு எக்ஸாம் தானே உங்களுக்கு? ஓகே ஓகே. இன்னைக்கு இந்த ப்ரொசீஜர் பண்ணிட்டு நீங்க வீட்டுக்கு போகலாம். அதோட ரிசல்ட் வந்ததுக்கு அப்புறம் நம்ம பார்த்துக்கலாம். ஓகேவா?
ரொம்ப ரொம்ப நன்றி சார். ரொம்ப உங்களை நம்பி தான் சார் இவ்வளவு தூரம் வந்திருக்கோம். நம்பிக்கை தான் சார்.
நம்பி வாங்க, சந்தோஷமா போங்க.
இப்படிதான் நம்பிட்டு இருக்கோம் எல்லா வாட்டியும்.
Thank you, finalists, for that absolutely brilliant session led by Dr. Purushu BP.
The investigations, ultrasound was done to confirm the diagnosis and a large solitary nodule was identified. In the TFT, to support the diagnosis, the patient is in euthyroid state. FNAC is to be done and the patient and the mother are consoled and Simran is asked to attend her exam and come back 3 days later for the FNAC results and further treatment. Thank you.
Moving on to the academic session. So far, we have discussed about head and neck surgeries, thyrotoxicosis. So are we missing out on something important here? How important the vasculature is to the body? So is the lymphatics equally important? In many of the cases, they are the first site to be affected and can be identified using so many procedures. Knowledge of lymphatics is very essential and no general examination is complete without assessing for lymphadenopathy. So, to educate us on the topic, surgical anatomy of lymphatic system in head and neck and approach to lymphadenopathy, we now have with us Dr. Nirmal Kumar Sir, Associate Professor, Department of General Surgery, Government Medical College, Thuthukudi, for the same. Please help me welcome Sir with the largest round of applause.
Hello. A very good afternoon, each and everyone. At the outset, I would like to thank the administration of Sri Mugambiga Institute of Medical Sciences, respected ma'am, and the whole surgery department, and most of them are my teachers, my PG teachers. So I extend a warm greetings to you all, and extend my warm greetings to eminent teachers, Shanai sir and Jailal sir. And I really enjoyed that role play. That was well made out by Purushottam team, excellently executed. So the postprandial session, I could see all bubbling with energy. So we'll move on to the session. Actually, it's 2 sessions clubbed together. Hope I will finish in time and it will be very crisp. Coming to the surgical anatomy of lymphatic system in head and neck. I bring greetings from Department of General Surgery, Thuthukudi Government Medical College. Coming to the learning objectives. Lymphatic system, what and why. Lymphatic drainage of head, triangles of the neck, levels of lymph nodes, approach to cervical lymphadenopathy, and neck dissection. So this is the things which you are going to learn, or you're going to refresh what you have already learned. So coming to the lymphatic system, what it is, the excess tissue fluid which comes out from the arterial end of the circulation is taken up by the lymphatic vessels, and it is taken to the lymph nodes located along the course of the vessels. This is lymphatic system in nutshell. And what is its role? The fluid is filtered and the foreign substances are phagocytosed, and in that process the node swells. The position of the nodes denotes the general location of infection. So coming to the development of lymphatics, anybody intrauterine life, at what week of gestation lymphatics develop? Any guess? 5th week of intrauterine life, the lymphatic starts developing, and the lymphatic vessels develop from lymph sac, which arises from the developing veins. So along the course of the veins, you will get this lymphatics. And there are 6 primary lymphatic sacs. Again, can anybody name them? Hello? Anyone? There are 6 lymphatic sacs in our body. One in the abdomen. Heard of it? At least cisterna chyli? Yes? Okay. So 2 jugular sacs, 2 iliac sacs, 1 retroperitoneal sac, and 1 cisterna chyli. This is how it develops in the intrauterine life. It develops along the internal jugular vein and IVC. So in this, on the right side you see the regional lymph nodes. There are 3 main groups of regional lymph nodes: cervical nodes, axillary nodes, and inguinal nodes. And in this, we are going to deal with the cervical nodes. So, coming to the lymphatic drainage of head and neck, all lymph from head and neck ultimately drains into the deep cervical lymph nodes. And from there, the efferents go via the jugular trunk. On the right side, the jugular trunk drains into the lymphatic duct. On the left side, the jugular trunk drains into the thoracic duct. Yes, good. So this is the picture. So you see, there is a bronchomediastinal trunk, jugular trunk, and subclavian trunk. On the left side, in addition to these 3, you have the thoracic duct. Okay? So fill in the blanks. out of total of how many lymph nodes in the human body? Yes, you are right. How much? 800. Around how many nodes are located in the region of head and neck? 300, yes. So 800 lymph nodes in the whole of the body and 300 nodes are located in head and neck. And the lymph nodes in head and neck region can be grouped into superficial nodes and deep nodes. So when you say superficial, they are superficial to the deep cervical fascia. So what are they? There are 8 groups of superficial lymph nodes starting from submental, submandibular, buccal, preauricular, postauricular, occipital, superficial cervical nodes and anterior cervical nodes. These are superficial lymph nodes. And what do they drain, the superficial lymph nodes? They drain the external acoustic meatus, lobule of the ear, angle of jaw, lower part of the parotid region, and it drains into the lower deep cervical node. So coming to the deep lymph nodes, there are 3 groups. One is the deep cervical nodes, Valde's ring, and nodes of midline. So what is this deep cervical node drain? All lymph from head and neck drains directly or indirectly. Indirectly through the superficial nodes, it comes into the vertical chain of deep cervical lymph nodes. And deep cervical lymph nodes surround the internal jugular vein, and it extends from the base of the skull to the root of the neck. So these deep cervical nodes are broadly divided into upper deep cervical and lower deep cervical. And we have specific names for that. Anybody? Upper deep cervical, what is the name? And lower deep cervical, what is the name? Jugulo-digastric is the upper deep cervical node, and it's located below the posterior belly of digastric muscle. And it is the principal node which drains the palatine tonsil. Then you have the lower deep cervical, which is nothing but the jugulo-omohyoid node, and it principally drains the tongue. So the afferents it gets from tongue, submental nodes, submandibular nodes, and upper deep cervical nodes. So what is this? Spotter? What is this? Yes. And the clinical sign is? Yes, virtuous node and Troisius sign. So coming to the arrangement, how they are arranged, we have an inner circle and outer circle of lymphatics arrangement. And the outer circle, this is just around the pericervical or the cervical collar at the junction of head and neck, and it extends from the chin to the occiput. It is arranged in the form of a circle, and it includes submental, submandibular, buccal, parotid, postauricular and occipital nodes. And the inner circle consists of the prelaryngeal, pretracheal, paratracheal and retropharyngeal nodes. This is how the circle is arranged. In the upper part you get the outer circle, and the lower part you get the inner circle, and they all drain into the terminal deep cervical lymph nodes. Ultimately they drain into it. So coming to the Valde's ring, what is this ring? This consists of paired palatine tonsils, lingual tonsils and pharyngeal tonsil. They form the Valde's ring. So coming to the triangles of the neck, you are well aware of that, so I just rush up through that. There are the anterior triangle, it consists of submental, submandibular, carotid and muscular triangle. You must know the boundaries and contents, it might be asked in your exams. And then you have the posterior triangle, that is again divided by omohyoid into 2 posterior triangles. So we have another classification which is commonly used. You are well aware of that. In the previous class it was discussed. So level 1 is submental, level 1A is submental, 1B is submandibular, level 2 is upper jugular, then you have the mid jugular, lower jugular, then 5 is posterior triangle, 6 is anterior compartment, and 7 is superior mediastinal nodes. And coming to the drainage part, so this is a primary drainage site. So level 1 or the submental nodes, they drain the anterior floor of mouth, anterior oral tongue, anterior mandibular alveolar ridge and lower lip. So it comes like that. And when it comes to lower jugular, you have an addition of the cervical part of esophagus. So you have to keep it in mind. And level 6, or the anterior compartment, you get the thyroid, glottic and subglottic larynx, apex of the pyriform sinus, and cervical esophagus. So when you are dealing with this, you have to think these in mind. And level 7 is superior mediastinal nodes. So coming to when you are given a case of neck node swelling in exam, how you are going to approach it? What are the things you must have in your mind? So coming to the causes of cervical lymphadenopathy, all this should be in the back of the mind so that you can approach the patient. So infective, neoplastic, and miscellaneous. So bacterial, viral or parasitic, and neoplasia we have primary and secondary. So the infectious causes, mostly it's viral, and then you have toxoplasmosis, which is very rare, and in the non-infectious causes you get lymphomas, leukemia, metastatic disease, histiocytosis, SLE, and Kawasaki's disease. So in history taking, it's very, very important. You take a detailed history, and it should include history of fever, systemic symptoms or constitutional symptoms, and head and neck complaints. The area which is drained by that node, that area, complaints pertaining to that area should be specifically asked for. And we usually miss the dental infection, and history of dental extraction or dental problems should be asked and should be looked for. And as per inspection, the routine inspection, the number, site, shape, size, surface, and skin, and face and upper chest, any venous engorgement, these have to be looked for. And in palpation, the size and shape, they are confirmed. The surface, whether it is smooth or nodular, and consistency, whether it is variable, hard, or rubbery. In which condition you get rubbery consistency? Yes. And hard, if it is hard, malignancy. Variable, when do you get a variable node in the neck? Maybe a tuberculous node, right? And you have to look for the margins and mobility, whether it is mobile or fixed. Then skin involvement, we get in malignant growths, acute lymphadenitis, TB lymphadenitis with cold abscess, skin involvements might be present. So whenever the submental group is involved, you have to look for the chin, central part of the lip, gingiva, floor of the mouth, and tip of the tongue. And in the previous class, sir showed a beautiful picture. Hope you remember that. And in submandibular group, if the submandibular node is enlarged, you have to look for the palate, tongue, floor of the mouth, lower lip, cheek, gingiva, antrum, and nose. And in jugular chain is involved, look for the tongue, mouth, pharynx, larynx, upper esophagus, and thyroid. If the supraclavicular node is involved, what are the things you have to look for? Yes? Virtuose is present. What are the things you have to look for? Commonly, stomach. Yes, then breast, chest, abdomen, testis have to be looked for. And this is the Jones and Campbell classification of peripheral lymph node, which progresses in 5 stages in a case of tuberculous lymph node. In stage 1 is lymphadenitis stage, and stage 2 is matted because of periadenitis, and stage 3 is the stage of abscess formation because of central softening, and in stage 4 cold abscess occurs because of liquefaction, and in stage 5 fistula is formed through a process of cholesterol abscess. And stage 4 you see the typical formation of a cholesterol abscess. And stage 5 is tuberculous sinus or an ulcer is formed. And this is a typical clinical picture of tuberculous node rupturing outside. And coming to the carcinomatous lymph nodes, usually the age will be more than 50 years. We are not dealing with thyroid now, so more common in males, and it will be a rapidly growing history. Painless and non-tender, there will be no local rise of temperature, hard or stony hard in consistency, and fixity to the skin and deeper structures will be present if it is a carcinomatous lymph node. And coming to the types of neck secondaries, we classify into 3 groups. One is secondaries in neck with known primary. So you are able to clinically locate the primary. And the second one is secondaries in neck with clinically unidentified primary. And the third is secondaries in neck with occult primary. So what is it? How we are going to deal with? So secondaries in neck with known primary. So most common primary sites are oral cavity, pharynx, larynx, and thyroid. So the primary is evident. So you take a biopsy from the primary site and secondaries from the node. And depending upon the staging, you proceed with radiotherapy or surgery. So coming to secondaries in neck with clinically unidentified primary. So you do the FNAC from the secondary node. And how are you going to search for the primary? These are the things you are supposed to do. First one is pan endoscopy. Pan endoscopy consists of, you are aware? Anybody? What are the things you do in pan endoscopy? Nasopharyngoscopy, laryngoscopy, esophagoscopy, and bronchoscopy. That should be followed by surveillance, biopsy, FNAC of thyroid and suspected areas, and CT scan. Can anybody tell where all you are going to take the surveillance biopsy? Anybody? Surveillance biopsy you have to take when the clinically you are unable to identify the primary. From where all you will take the surveillance biopsy? These are all the places you have to take surveillance biopsy. Fossa of Rosenmuller, lateral wall of pharynx, pyriform fossa, tonsillar bed, base of the tongue, subglottic region, retromolar trigone, and adenoids. So these are all the things you have to keep it in mind when you are not able to identify the primary clinically. And second is in neck with occult primary. When this occult primary occurs, probably they say because of an immune response, the primary has disappeared, or the primary is so small, with the available investigations, we are not able to find out the primary. That is occult primary, and the second is in the neck. So FNAC of the neck secondary is done. And if the nodes are in the upper and mid-cervical region, it's mostly 80% of it is from squamous cell carcinoma mets. If it is lower cervical and supraclavicle region, 40% is going to be from adenocarcinoma. So you have to plan accordingly your treatment. So coming to the nodal staging in secondaries, how are you going to stage them? N1 is single node, ipsilateral single node, less than 3 centimeters. N2A is ipsilateral single node, which is 3 to 6 centimeter in size. 2B is multiple nodes on the same side, less than 6 centimeter. 2C is bilateral or contralateral node, less than 6 centimeter. If it is more than 6, it comes under N3. So a word about neck dissection. Can you tell me what are the types of neck dissection you have heard of? Yes? Not audible. Anyone? Can you get up and tell? Anybody? Neck dissections? Fast. Okay, so you have one Medina classification and A and B, comprehensive neck dissection and selective neck dissection. In comprehensive, we have radical neck dissection and modified radical neck dissection. In selective, we have supraomohyoid, anterolateral, posterolateral, and anterior neck dissection. So this is Medina classification. So what is this radical neck dissection? It is removal of all lymphatic tissues in the lateral neck, level 1 to 5, in clinically positive case, clinically node positive case. And that is radical neck dissection. And coming to the modified radical neck dissection, in the next slide we'll go into it. So what are the incisions? Sometimes you might be asked, what are the named incisions you do for neck dissection? So you have the Kreil's method, something like a T. Then you have Martin's incision, which is like an I or H. And hockey stick incisions or McPhee's, 2 separate incisions can be made, and to approach the neck nodes. So what is this radical neck dissection? It is done, level 1 to 5 is nodes are removed. Along with that, sternocleidomastoid muscle, internal jugular vein, spinal axillary nerve, and submandibular salivary gland. This is radical neck dissection. Coming to MRND, there are 3 types, type 1, 2 and 3. And in type 1, you preserve the spinal accessory nerve. In 2, you preserve spinal accessory and sternocleidomastoid. And in type 3, you preserve spinal accessory, sternomastoid and internal jugular vein. So coming to selective neck dissection, supraomohyoid, in that you remove level 1 to 3. And in posterolateral, you remove the level 2, 3, 4 and 5. And in anterolateral, you remove level 2, 3 and 4. And in central compartment, you know it is level 6 nodes are removed. So this is about selective neck dissection. Are you all sleeping? It's wake up time. You're going to get some questions, right? So I want one volunteer from boys. Please come to the front, take the mic. Fast, fast, fast. Who is the class rep? You can choose one boy. First. The questions are very easy, don't worry. Okay, read it for me.
A 20-year-old male present with multiple swelling on right side of neck for past 2 months. Patient also complains of evening rise of temperature. On examination, nodes are of varying consistency. Jugulodigastric and upper cervical nodes are matted together. No other regional and generalized lymphadenopathy. What is your provisional diagnosis?
Yes, so clear cut.
Tubercular cervical lymphadenopathy.
Yes, so multiple evening rise of temperature, varying consistency, jugulodigastric, matted nodes. So probably tuberculous cervical lymphadenitis. Yes, good. But the thing is, most of the time patients will not come with this classical symptoms and signs. Case scenario 2. From this side, anybody from this side? Volunteers? Only clear-cut cases. Yes.
70-year-old male presents with a swelling on right side of the neck for past 2 months. No other specific complaints except loss of weight or appetite. On examination, a swelling of a size of 3 × 2 centimeter involving level 3 group on right side, hard in consistency and fixed. Other systemic examination unremarkable. The provincial diagnosis.
What is level 3?
Level 3, upper mid-jugular.
Yes. So, what is your provisional diagnosis?
Malignancy.
Yes? Malignancy. Yes or no? Why do you say it's malignancy?
Loss of weight and appetite.
Right from, start from the age. What is the age?
70 years.
70 years. Loss of weight, loss of appetite. Hard in consistency. Fixed. So probably a metastatic lymph node. Right, good. Thank you. Next. Last scenario. Any volunteer? Yeah. Yes, fast. Roll number 22. Roll number 22. Roll number 22. 72.
A 20-year-old male presented with pyrexia of unknown origin, weight loss, malaise, night sweats and swelling on both sides of neck. On examination, a swelling of size 8 × 8 centimeter on left supraclavicular region and 6 × 5 centimeter on right supraclavicular region. Both are ovoid, smooth and discrete. Patient also had hepatosplenomegaly.
What is your provisional diagnosis?
Lymphoma.
Why do you say that?
Sir, hepatosplenomegaly.
Yes?
Hepatosplenomegaly.
Okay, start from the first. Age 20 years. pyrexia of unknown origin, weight loss, night sweats, everything matters. Okay, swelling on both sides of the neck, ovoid smooth and discrete, and then hepatosplenomegaly. So probably lymphoma. Good. Thank you.
Thank you, sir. Our presenters, may I have the honor of welcoming Dr. Rajagopal Shenoy sir, Dr. Jailal sir and Dr. Nirmal Kumar sir to the dais.
I'm introducing the speaker. To introduce Rajagopal Shenoy sir gives me immense privilege because he is the author of the Manipal textbook of surgery, which most of us are studying, and I have passed just because of that. So thank you so much, sir. He is the consultant surgeon at the Associated KMC Hospital, Manipal Higher Education, deemed to be university, ex-associate dean of Kasturba Medical College, and has so many awards to his credit. We are so glad to have you, sir. He is a very well-liked teacher in Manipal. He is a very famous chess player, a very well-known dramatist, and he is also an excellent singer and a very well-known teacher. Thank you so much, sir, for joining us today. Up next is Dr. Jailal sir, Professor and HOD, Department of General Surgery, Kanyakumari Government Medical College, Asharipallam. He has held many positions as a state president, council member, senate member and vice president and of various institutions. He has various publications to his credit and various awards and appreciations. We are so glad to have you amongst us, sir. Thank you so much for taking time out of your busy schedule to be with us here.
So, good afternoon everyone, sirs and everyone on and off the dais. I am Abdul Tanil and this is Ajay, and we are here to present a case on neck swelling. So,
just a minute.
yeah.
Sir, what is the time duration and what is the pattern? I mean, Alex sir or something?
So, Mr. Raman, a 28-year-old gentleman, he is a farmer. He belongs to the lower middle class according to modified Copersam scale. He resides in Martadam. He came with the chief complaint of swelling in the right side of neck since last 1 month and fever for the past 1 week. History of preceding illness. Patient was apparently normal 1 month back, after which he developed swelling in the right side of neck for the past 1 month, which was insidious in onset, initially small in size and then gradually progressed to current size, not associated with pain. Then he had fever for past 1 week, which was low grade, intermittent in nature, usually comes in the evening, associated with excessive sweating in the night and not associated with chills, rigor and joint pain. Then there was history of loss of weight, which was 10 kilograms in 6 months and loss of appetite. Then there was no history of ulcer in the oral cavity, excessive salivation, difficulty in mastication, ear pain, ear discharge, difficulty in hearing, nasal discharge block or bleeding, difficulty in swallowing, hoarseness of voice and difficulty in breathing. There was also no history of chest pain, cough with expectoration, hemoptysis, dyspepsia, abdominal mass and pain, hematemesis, melena and bleeding per recta. There was no history of swelling elsewhere in the body. He is not a known case of diabetes, hypertension, asthma or any heart disease. Past history. Patient had a history of tuberculosis 1 year back and has taken medication for the same, completed his course of treatment over a period of 6 months. There was no history of irradiation to the neck, no history of exposure to any STD and no history of any surgeries in the past. Personal history. No, he had a non-vegetarian diet, reduced appetite, bowel and bladder habits normal, sleep pattern normal. He was not a smoker, alcoholic or a betel nut chewer. Family history, no similar complaints in the family. Then coming to the summary. A 28-year gentleman belonging to lower middle socioeconomic status came with complaints of progressive swelling in the right side of neck since last 1 month, associated with fever for past 1 week, which is intermittent in nature, associated with evening rise of temperature and night sweats. There is a history of loss of weight and appetite with previous history of tuberculosis 1 year back and completed his course of treatment.
Can I proceed?
You said modified Kupusamy scale.
Yes, sir.
What do you mean by that?
Sir, it is a scale used to measure.
What is that scale?
It is modified Kupusamy scale based on the
Per capita income of the person.
An occupation and economic education of the patient.
Education of the patient.
Because you are using the term,
Yes.
even if you do not use, no problem. When you use, you are used to modified Kupusamy scale, then we will ask you that question, specifically all the 5 criteria and how do you come to the conclusion and what criteria based you come to that. That is the one question we will normally ask. Better undergraduate scale, you avoid it. Even if you avoid, nothing much. If you say that, you must know that. And you said loss of weight also.
Weight loss.
What is the total duration of the course? Disease?
The patient had a swelling for 1 month and the fever lasted for 1 week.
Now, how do you come to your conclusion with the 1 month swelling, loss of weight? What is the definition for loss of weight in 1 month?
So significant loss of weight.
What do you mean by significant loss of weight?
Patient have 10% reduction in the weight over a period of 6 months.
No, your history is only 1 month.
Yes.
That is the standard definition for 6 months. So in a 1 month, how you come to here, it is a significant loss of weight.
Sir, in past history, patient also had a history of tuberculosis in the past. Sir.
1 year back he had a previous history of tuberculosis. For that he completed his medication.
Is it really a past history or it's a continuation of the history? The 1 year back tuberculosis and now it is continuing. Is it a continuation of the history or that is a separate?
That is separate.
Yeah, I will just take you to little away from the diagnosis because it's a straightforward case of there is a swelling, patient has fever and patient had tuberculosis. For the time being, you just go away from tuberculosis and just give me few causes for swelling and fever. This is how it is, because nobody will come and tell you I have got tuberculous nodes. This is a virtual presentation, but in reality it doesn't happen like that.
Sir,
Give me some examples of swelling and fever, that's all. Other than, okay, tubercular cold abscess.
acute lymphadenitis due to infection. Acute lymphadenitis due to infection.
Acute lymphadenitis due to infection. All right. Can you give me some examples for that? Which fever persists? Some medical illness. People can have multiple lymph nodes, fever.
Lymphoma, malignancy.
You can have lymphoma. All right. Anything else?
Infectious disease.
Infectious. Have you heard of brucellosis?
Yes, sir.
What is brucellosis? See, how the examiner wants to assess you is in this way. It is, no doubt, it's a common problem is tubercular cold abscess. What about infectious mononucleosis? Can you get some persistent viral infections which are not at all coming down? Anything else other than the infection? You would like to think of any hematological diseases? Fever, lymph node. 28-year young. Hematological malignancies? Come on.
Leukemia.
Sorry?
Leukemia.
Leukemia, yes. Please keep it in mind when you have a broader aspects whenever you examine the patient. You have two problems, swelling and fever. So you would like to think of tuberculosis. You would like to think of this. Sir has classified infectious, you know, the various classification, how we general. Can you think of any cysts in the neck which has got infected? Any cysts in the neck, young patient, 28. Cysts, lot of cysts occur in the neck, no?
Cystic hygroma.
Cystic hygroma. Anything else more common?
Branchial cyst.
Branchial cyst.
Yes, branchial cyst, yes. Suppose it's a midline, I think I have given a clue.
Thyroglossal cyst.
Thyroglossal cyst. So you keep in mind all the possible neck swellings. Soft swellings, cystic swellings, or firm swellings, hard swellings. Already classification has been given. What can fit in your case? Now tell me what is the cause of fever in tuberculosis? You said no, some evening rise of temperature.
Yes.
This is a very favorite question, and most of us also we know that evening rise of temperature, but then you can get many people giving different answers, that is all right, but just wanted to know from you. What type of fever is that? See, these are very basics. Is it a continuous fever, intermittent fever, or remittent bouts of intermittent fever? You know how to classify fever?
Yes.
So,
continuous fever.
is it a continuous fever? Yes.
Intermittent.
Now tell me, why do you get it? Any inflammatory agents, you know?
Yes.
What are those?
Cytokines.
Cytokines, anything else? COVID that time, I think all of you know about the cytokine issues and all.
Interleukins.
Any interleukins, you heard of that? Yes. Okay. Evening rays is probably due to, as you know, whole day you become fatigue, you know. The fatigue is one of the factors. Dehydration is one of the factors. Your sensitivity towards all the sensory symptom, fever, all gets more in the evening. Circadian rhythm itself. So body, you know, you yourself feel fever. That's why that so-called the evening rise of temperature. So keep it in mind, some differential diagnosis always, and then proceed. So this is not the place to think of secondaries in the neck. 28-year boy, but with fever. So we will not think of that direction. Not that malignancy cannot give fever, but lymphoma, tuberculosis, some other benign disease. Anything else you want to add?
Since you had a history of tuberculosis, I think you need a little probing in that. So has he completed the complete course, the treatment course?
He has completed the course.
How long and what was the regime he took?
He took the DOTS regime.
The standard regime was,
the
he took it.
regime.
He's not a defaulter or anything?
No, he's not.
Okay, he was Putam positive?
Yes. He was Putam.
Yeah, when did it become negative? All the things you have to probe, right? Okay.
See, have radiation?
Radiation, he might have a history of any lymphomas or any papillary carcinoma.
Now you are having a node.
Yes.
You are having an XLA.
XLA.
You are thinking in terms of irradiation causing that lymphoma.
No.
Previous?
May predisposed to any
thyroid malignancy, like papillary carcinoma of thyroid.
What is the age of the patient?
28.
28. So it is quite unlikely, no?
Yeah.
Even in a short case, this just to tell tuberculosis is not enough, because lymphatic tuberculosis is primary tuberculosis or secondary tuberculosis?
Pulmonary or extrapulmonary?
Extrapulmonary.
So it is always primary. Primary means it is not spread from the lungs or any other condition. Spine tuberculosis? Spine? Spine.
Second.
It's always some focus somewhere.
Yeah.
So it is
Secondary.
like a genitourinary tuberculosis. So where was the tuberculosis? This you have never mentioned. That's why I asked you, I think, the sputum positive, negative.
He has brought it to the past history. So that is the etiology. You are thinking it is a tuberculosis. So that should come in the primary history, present history. You should start with that history. Patient continuously is having this node.
Why did you ask that history of hemoptysis somewhere? No, so many things.
Yeah. Lot of things, ear pain, all those things. Now, if you have put, we will ask what is the reason.
See, always you should remember your patient is, what is the age?
28 years old.
What do you suspect in the mind? Tuberculosis. What is the intention of asking this full list?
Will any tuberculosis cause ear pain?
So, because it's given in the books that lymph node swelling, you ask. So you should try to use your, some discrimination power now. You are suspecting malignancy, yes, this list is very, very important. All that you have mentioned, so many things in that, right? Why did you ask hemoptysis? You should have told, not bronchogenic carcinoma. You should have told, you may be having pulmonary tuberculosis in relation to your case. Talk about your patient. Is it clear? Right?
You said difficulty in mastication. What are the muscles of mastication?
Sir, masseter, medial pterygoid and lateral pterygoid, temporalis.
Medial pterygoid, lateral pterygoid,
temporalis.
So, do you expect? You said the swelling is here in the neck.
Yes.
Do you expect it affects the mastication? So all your muscles are above that. The muscles which are, you are talking about only the neck swelling. So certain questions you need to ask which related to that. Similarly, another mistake you have made is a Kornofsky score. Kornofsky score we mentioned for a malignancy or patient who is a very terminal ill patient where he will not be able to tolerate. So for those people you need to mention the Kornofsky score. For when you are thinking in terms of benign condition you are managing, please don't bring, especially in undergraduate, unnecessary these scores. That will be difficult for you to proceed. So make it simple. What you are seeing, what is related to your question, case, ask that question and go ahead.
You are not even spared rectum here, see? Tomorrow somebody comes with a headache, you will ask, do you have bleeding per rectum? See? Correct? Okay. Yes. Go ahead.
Physical examination, general survey, patient consent was taken, examined in sitting position in a well-lit room with adequate privacy. Performance status 90 according to Kornofsky scale. Hydration status adequate. Patient was conscious, cooperative, oriented to time, place and person. Moderately built and nourished. BMI of 22 kg per meter square. Then no pallor, icterus, clubbing, cyanosis, edema and generalized lymphadenopathy. Vitals.
This BMI denotes built and nourishment. That's what you mean.
Yes.
Moderately built and nourished, BMI means what? BMI indicates built and nourishment.
Yes.
So suppose BMI is 100, he is well nourished fellow. Very obese means well nourished.
Malnourished.
Overweight.
Malnourished. He will be
Malnourished.
Overweight.
overweight. He will be overweight.
No. What is the relation of BMI here and built and nourished? What is built? What do you mean by built?
Built is,
BMI comes under what, man? Height and weight related? Or?
Height and
So then why did you bring nourishment here? So you have to have a very clear idea about that, no? What you are looking for, correct?
So built is a skeletal structure.
Skeleton.
And the patient, tall, height, all that you need to build. Just because he has come to the hospital, don't put moderately built, poorly built. If he is a built of your size category, it is a normal build. Nourishment, there are various categories to read. So just he is a patient, that doesn't mean he is a moderately built or poorly built patient. Whatever you see, you write. BMI is a separate entity. It is going to talk about, nothing to do, is going to talk, fully reflecting the nourishment. So don't put it on a bracket. If you want to put, you put it separately.
Vitals, pulse, rate 90 beats per minute, rhythm regular, volume normal, character normal, condition of the osmolar normal. Blood pressure 110, 70 millimeter mercury, measured in sitting position on patient's left upper limb. Respiratory rate 16 breaths per minute, temperature afebrile. Examination of neck, examination of left side was normal, examination of right side of neck. Inspection, solitary swelling of about 2 into 3 centimeter size located in the right side of the neck, ovoid in shape in the anterior triangle, extends superiorly 2 centimeter below from angle of mandible, inferiorly 6 centimeter above the clavicle, medially 4 centimeter from midline at the level of thyroid cartilage, laterally 1 centimeter from the anterior border of the sternocleidomastoid. Surface appears to be smooth, skin over the swelling appears to be normal, ill-defined margin, no visible pulsations, no scars, sinus, dilated veins and fistula. Tracheal position appears to be in midline, no other swelling in the neck. Palpation, all the inspectory findings are confirmed by palpation, no local rise in temperature, no tenderness, solitary swelling of about 2 into 3 centimeter size located in the right side of neck, ovoid in shape in the anterior triangle, extends superiorly 2 centimeter below from angle of mandible, inferiorly 6 centimeter above the clavicle, medially 4 centimeter from midline at the level of thyroid cartilage, laterally 1 centimeter from anterior border of sternocleidomastoid. Surface smooth, skin over the swelling normal, margin irregular, film in consistency, freely mobile, carotid pulse felt equally on both sides, tracheal position confirmed to be in midline. Then examination of oral cavity is normal, examination of supraclavicular fossa normal, examination of ear, nose, throat normal, examination of spine and cranium is normal, examination of thyroid breast was normal. In other system examination, abdomen, soft, non-tender, no organomegaly, bowel sounds here, external genitalia was normal. Respiratory system, normal vesicular breath sounds here, no added sounds. Cardiovascular system, S1, S2 here, no added sounds. Central nervous system, no focal neurological deficit, cranial nerves are normal. Summary, a 28-year-old gentleman came with complaints of gradually progressive swelling in the right side of the neck for past 1 month, associated with fever since last 1 week and loss of appetite. And patient had a history of pulmonary tuberculosis 1 year back and taken medication for the same completely. On examination, solitary swelling of about 2 into 3 centimeter size in the right side of the neck, ovoid in shape, extends superiorly 2 centimeter below from angle of mandible, inferiorly 6 centimeter above the clavicle, medially 4 centimeter from midline at the level of thyroid cartilage, laterally 1 centimeter from anterior border of sternocleidomastoid. Smooth surface, skin over the swelling was normal, margins irregular, film in consistency, freely mobile and non-tender. Provisional diagnosis, this is a case of right-sided tubercular cervical lymphadenitis, probably involving a level 2 group of lymphomas.
So a few things go to that inspection slide quickly. Yeah, just we'll sort it out. That. So most of the things, whatever you have written is fine. Inferiorly, medially, all that thing you have written, like a typical any other swellings you have to give a description. Smooth and all that thing. Ill-defined margin, no pulsations. What pulsations you are looking for?
Transmitted or expansional pulsation.
No, just be clear. There is a swelling there, which is occupying in front of what structure?
Carotid.
So,
Carotid.
okay, so be specific. Don't tell suddenly why did you say expansile? Are you suspecting aneurysm here, 26-year person? No. He's 26-year-old, correct?
28 years.
So you wanted to rule out transmitted pulsation, very important. No scars, no sinuses, all that you have written. Trachea appears to be midline, no other swelling in the neck. Next, here most of the things are fine. One important thing you need to mention always is, when you are giving a diagnosis of tuberculosis, you are written there smooth surface and irregular somewhere, wherever you are written, somewhere you are written irregular. We don't have the chance of examining the patient. So was there any matting or no matting?
No matting, sir, because the solitary lymph nodes, solitary swelling. So
you mean to say there's one single node,
Yes.
1 month duration?
Yes.
With the
The solitary and dominant are the swelling which we try to use in the thyroid, with a definite definition for solitary. Here you can say single node. It's better word is single, not a solitary word, because that is a very particular.
Margins irregular. Again, edge, when you have a talking about swelling, round borders, like that we say. Was it like that, irregular? And one important thing you should practice, that plane of the swelling. Plane of the swelling.
it's deep to deep cervical fissure.
No. You are written in relation to sternomastoid there, no? Somewhere there laterally. So anterior borders. So you should mention here what muscle to contract.
Sir,
Which side? You know how to contract the right sternomastoid muscle. By looking, ask the patient to
ask the patient to turn opposite side against the resistance.
against the resistance. So if this swelling becomes less prominent, it indicates.
It's deep to deep.
Suppose if this swelling is more prominent, what does it indicate?
It is above the.
Not above.
Superficial.
Superficial. So you should remember this point. Most of the significant neck nodes are all deep to deep cervical fissure. So this, especially here, you have to bring that, especially because this is not a thyroid swelling. Correct?
It is freely mobile, you said.
Yeah.
Yes.
So you are thinking it is an infection in there, adenitis. It is freely mobile.
Are you able to hold the swelling and move it freely?
Yes.
Okay. And this 2 centimeter from there, 4 centimeter from leg, 5 centimeter from this, what is the purpose in that?
So, to define the exact location.
That you know what is level 2?
Yes.
It is a defined location. Level 3 is a defined location. And if you can say that it is a level 2 node, even in your examination right from the beginning. And what you are going to talk about 2 centimeter angle, 3 centimeter angle, all that you are waste of time you are going to do. And nobody, even a clinician, no clinician is going to measure from where to this is going to be there. It is also not going to give any meaning on that. So if you can say instead of that, the swelling confined to the level 2 nodes or level 3 nodes, specifically if you can mention, that will be good for that.
Okay.
Please talk about these levels only when you are confirming that it is a lymph nodal swelling. Tomorrow if there is a branchial cyst in the anterior triangle, which is, don't say that it is a level 2 node. It is because there we use the word, yes, anterior triangle of the neck. You can add a word if you want in the carotid triangle. Suppose elderly people who come with the carotid body tumor with the prominent pulsation somewhere here. So digastric triangle classically is for what swelling? Digastric triangle is classically for what swelling? Digastric.
Submandibular.
Yes, submandibular node, submandibular swelling. So next you have got this anterior triangle. Here is the carotid triangle, correct? Yes. Muscular triangle is the lower one. So in other words, you don't have to say anterior triangle is fine. If the examiner asks you, say upper part of the anterior triangle.
That is more than enough.
Correct? Yes.
What carotid pulse you have felt? Which carotid you have palpated?
Sir, it's common carotids.
Common carotid.
Where?
At the level of C6 transverse process of C6 vertebrae.
Where is it?
At the level of upper border of thyroid cartilage.
Upper border of thyroid cartilage.
Cricoid cartilage.
So you are going to feel only the common carotid. C6 corresponds to the cricoid cartilage.
Yes.
So just above that you are going to feel. Or in the sternocleidomastoid muscle line, the middle part of the sternocleidomastoid, you are going to feel that. How did you confirm trachea in the midline?
Sir, by palpation.
Palpation. What you palpated?
Hold the mic, hold.
What you have palpated? You said both on inspection also you said trachea is in the midline.
Seems
So what is the way to say on inspection trachea is in the midline? What is the way to say palpation trachea is in the midline?
Sir, in inspection, trachea seems to be in midline, sir.
Now how do you come to the conclusion? Is there any signs if the trachea is deviated?
Traps.
So your lifeline is helping. Trial sign is there, okay. And a palpation? Trachea is very small, 3 to 4 rings of trachea is only there. So you can on either side you can push or plunge your hands and if you can look for that. Auscultation?
Breath.
Breath sounds. So all three are methods to see that the trachea is in the...
If you keep in mind that lymph node as a diagnosis, instead of that big list in the oral cavity, what else you should have mentioned? Tonsil, okay, that I've seen the big list of oral cavity. Show that next slide. There's so many nodes are there, no? Yeah, that one. That is okay. What else you should examine? Whenever you have a lymphatic system is involved, you should examine all the part of the reticuloendothelial system. Means?
Sir, liver, spleen. Liver, spleen.
All the lymph
thymus.
nodes in the neck. It is not just levels here, 1, 2, 3, 4, 5, 6, not like that. What are the lymph nodes? Especially in lymphoma, what are the nodes you get?
Supraclavicular. Epitrochlear lymph
So
nodes.
you should mention, I examined for all the group of lymph nodes, including axilla, very important. Never forget axilla, groin, right? And if it is a non-Hodgkin's lymphoma, what you said just now, epitrochlear and all this outer Walde's ring, right? So liver, spleen and all that parietic, all that is a part of lymphoma, but that it should be your habit. Whenever you have a patient who has lymph node and any suspicion leukemia is there, what else you have to examine?
Spleen.
No, that is over. Liver, spleen, lymph nodes, reticuloendothelial. So what else you will examine? Leukemia. Any sternal tenderness. This is how you should practice. This is what is practice examination. All right? Yes.
In the palpation of the oral cavity, what are the hidden areas in the oral cavity?
Sir, piriform fossa.
PVPR. Abdominal examination will not complete without doing PVPR. Similarly, oral examination. P stands for piriform fossa, V stands for vallicula,
Yes.
P stands for posterior 1/3 of the tongue, and fossa of Rosenmüller. How do you examine this?
Sir,
Ideal.
indirect laryngeal.
Ideal student will have an ideal.
Indirect laryngeal. Provisional diagnosis.
I think sir has given the full stages and all. What do you do from here onwards? Quickly.
Sir, first I will do investigation to confirm my diagnosis and support the diagnosis. Then treat the disease. First I will do ultrasound, then followed by FNAC. Then to rule out pulmonary tuberculosis, I will do chest X-ray. Then for metastatic workshop.
You are suspecting tuberculosis, no?
Yes, sir.
So FNAC you will send to whom?
Microbiologist and pathologist.
So you should send for both?
Yes.
Okay. When you are suspecting malignancy, you don't send to the microbiologist. But in a tuberculosis, when you are suspecting, you should send for both microbiology and pathology.
So just go back to that whenever you write in the theory as well as in our clinics, you should know why you are asking for blood test, you should know why you are asking for ESR, why ultrasound, why FNAC, every investigation listed there. If you think that tuberculosis can be proved by FNAC, why CT neck, CT chest, all that questions will be asked. Unless patient has got pulmonary tuberculosis active disease, in which sputum maybe will solve the problem. Then only you should suspect mediastinal lymphoma, etc. Then all that will come. In a young patient, of course, elderly people is a different issue.
Is the 28-year-old, is the Mando text is of any use?
Relevant?
It is not very relevant.
Not reliable.
What is CBNet?
Cartridge-based nucleic acid amplification test.
So for what purpose?
So to rule out any resistant to rifampicin and...
Good, very good.
Treatment antidote. Treatment anti-tuberculosis therapies.
So, do you have any question now? In the neck, your examination, do you have any doubt or any question to ask? This is an opportunity for you to ask question to the examiners.
No, is it clear to you what you are supposed to examine? That's all we want to know. Anything else you want to ask from us, you can ask. Then you go on describing all about the swelling, and then you give a diagnosis. Most common swelling in the neck is a lymph nodal swelling. Like that you discuss and go for the why tuberculosis, why not acute infections, why not chronic. If it is a chronic, tuberculosis comes first. Then comes why not lymphoma, then why not metastasis. These are three common problems. So that's how you try to eliminate one by one. Then is it a lymph node or something else?
Yes.
Yes. Then why should you take this the patient in a surgical OPD? Straight away you could have sent for the medical OPD, no?
Sir, patient develop cold abscess complication.
So if it is a cold abscess he develop, how will you manage?
We will do aspiration.
Aspirate.
Aspirate.
What are the two? What is a normal method of drainage of an abscess? You know what is Hilton's method?
Incision and
What is Hilton's method?
incision and drainage.
Incision. Okay. Where do you make incision? Where do you drain? Abscess drainage. How will you drain an abscess? Is there any difference in draining an abscess of an ordinary abscess and a cold abscess?
So cold abscess, incision. If we done incision and drainage, it will form sinus, sir. So we don't do incision and drainage in cold abscess.
Now, under anti-tuberculosis covering, you will do the trapdoor method. The skin and the subcutaneous area, we will not make in a single incision. You make an incision in the skin separately, the underlying what is abscess?
Say collection
of fluid.
Pus.
Collection of pus anywhere is abscess. Definition of abscess. Is it covered with something or? So you must know, don't stop with the treatment, with the medical treatment. All the lymph nodes will not respond to medical treatment. Even after giving the ATT, there may be the tumor, the node will be remain as such, or it's get fibrous. Sometimes we need to do excision. Sometimes if it is not responding, it will go for the cold abscess. You need to manage that. And if sometimes if it is developing an abscess, sinus, then again you have to know that. So when you are writing the case sheet also, don't treat, just stop with the medical management.
Okay. Thank you.
Thank you, sir.
Thank you, Abhijit and Ajay, for that case presentation. Thank you, professors, for assessing our presenters.
Okay, everyone. Up next, we have yet another important discussion. I'm pretty sure that this class was one to watch out in the UG days. But without proper review time, and again, this might become volatile as well. So fear not. To help us recap on the topic, approach to epigastric mass, may I have the privilege of welcoming back Dr. Rajagopal Shenoy, sir, Professor, Department of General Surgery, Manipal Hospitals, amidst us to broaden our knowledge. Please, sir.
Yeah. Okay. Okay. Yeah.
With the greatest privilege, may I have the privilege of welcoming Dr. Nirmal Kumar, sir, Associate Professor, Department of General Surgery, Government Medical College, Thoothukudi, who took time out of his busy schedule to be with us here today and teach us on the lymphatics. We are honored and very glad that you are here with us today, sir. Thank you so much. May I request the entire General Surgery Department to kindly join us on stage and help us felicitate Dr. Nirmal, sir. Please put your hands together and help me welcome the entire Department of General Surgery.
Sorry?
Let the cheers keep rolling for the entire team. Let's give them a large round of applause. Thank you so much, Nirmal sir, and thank you all for joining us on stage. Thank you.
So, very good afternoon to all of you. Thank you. I'm not going to tell you everything about whatever given in the books, because all of you read the clinical books. So I'm just giving you some important tips like this: simple scrotum, supraclavicular node, spine, swelling, sphincter. The reason is, very many times abdominal mass given to you, especially epigastric mass, is there in your CBME curriculum. You tend to neglect sometimes examination of these three things. So the reason why have a checklist. And remember, in men always it is not about examination of 9 quadrants. Always remember genitalia. Genitalia refers to testis. And remember, please do not do the external genital examination in a female patient. Remember, vaginal examination is not external genital, it's a different. So please remember the intention for which you are going to examine. I hope it's clear. So what may be the diagnosis here? Very, very concave, common epigastric mass. So carcinoma of the pyloric antrum. This is a typical, persistent, typical, profuse, projectile, painless, non-bilious vomiting. That's how you get. And what is this? So much distended abdomen, large epigastric mass. And what is this? Protuberant. Don't say that this is abdominal distension. What's the difference between distension and protuberance? Protuberance is obesity. Distension is what patient complains. Obese patient will never complain that I have got distension. That is his normal obesity. On the other hand, a thin patient will tell you my abdomen is tight. That is distension. Abdominal examination, we sometimes say superficial palpation to rule out some tenderness, some lipoma, etc. And that's called a dipping method when you do for a ascites patient, especially stomach can have a ascites. And when patient is holding tight, say no guarding, or voluntarily, he is not allowing you, then you use your base of this palm and press in the lower part of the xiphisternum. That's called a Nicholson's method. And this is not carcinoma stomach. This is just to tell you, when you do the head rising test, it is for abdominal wall swelling. Even though this is umbilical hernia has to come from inside the abdomen. But most of it is outside the umbilicus. Outside means outside in the abdominal wall. So it becomes less prominent. So now we'll come to our case. Our case is epigastric mass. Most common long case for you in your abdomen. So please remember, when you are given a case, think of not only about stomach, liver, pancreas come there, which everyone knows, no? Stomach, liver, pancreas. Think something can come from above, something can go from below, something can from side, retroperitoneum, etc. So if you have that in list, you are going to ask all this one by one. We talk about fullness, correct? You eat a little bit food, I feel full. Typical early satiety, we say. Stomach, cannot stretch because of wall is infiltrated. It is not like normal distension. Maybe after your passing party, you can eat so much like a glutton because your stomach can stretch. That is receptive relaxation. That is lost. So you get that early satiety. And typical loss of weight. Classical asthenia, anorexia, anemia, AAA. Always remember, when you ask the patient, do you have abdominal discomfort? Yes. How is your appetite? Can you eat the food? No, small quantity. That means you are mostly dealing with the stomach. Vomiting, is it persistent? Non-bilious? Yes. Maybe antral lesion, carcinoma, pyloric antrum. Distension, I already mentioned. Ball rolling refers to a wave of peristalsis. Like a ball coming from this side to that side. So this is how I have put the pain as last. Remember this? I have put the pain as last because carcinoma stomach rarely produces pain. That doesn't mean it can never produce. There's nothing like which is never in medicine. It is a late feature. So altered bowel habits, this is how you ask the question. one of the favorite question, why anemia in carcinoma of the stomach? Most of you will tell bleeding. And most of the time there is no bleeding. So that is the reason. The main reason I will tell you is the next slide. There is 5 causes, but important cause is this. Most of them have got achlorhydria. So you need that, that acid for the conversion of ferrous to ferric. That is main reason why you get 40% of them have anemia. And this is the classical bleeding lesion, and the other one is a diffuse variety. Diffuse is nothing but Lionitis plastic. So come back to now case of epigastric mass. You have to think of first stomach, no doubt. Then liver comes there, pancreas, parietic nodes, and others I have written. I am just keeping in mind your interest. Postgraduates can have 25 differential diagnoses. That is not the idea here. Idea here is not to confuse you people, but just to directly to the subject. So keep it in mind, stomach first. Then comes the liver, pancreas, backache. First clue. I said pain is last feature of carcinoma, stomach. Pancreas, it is the first feature. I am not talking about head of the pancreas. I am talking about carcinoma, body of the pancreas. If the stomach causes backache, what does it mean? Stomach cancers cause backache. It means it is infiltrating pancreas. That's how you should think. If a carcinoma pancreas patient starts vomiting or epigastric distension or a fullness, it is pushing the stomach from. This is how you should think. Right. Now, there's one important history which you may encounter, because 25-30 years back we would have done some surgery for peptic ulcer disease. Used to be very common. You heard of, I think, vagotomy and gastrojejunostomy. So if we have done vagotomy GJ, these patients may come now to you with a cancer there. So this, because you have done a vagotomy, it causes achlorhydria. Again the problem. So you produce more nitrosamines which are toxic, and you can get what is called a stump carcinoma. So you may encounter one scar, right? So you know the importance of pallor, jaundice, supraclavicular node. I think before that we have seen that, Rozier sign, pedal edema. This is the time, if you can put Karnofsky, very good. 100 means no disease. But ECOG is better for malignancies. It's Eastern, yes, Eastern Cooperative Oncology Group. It's oncology. It deals with that because cancer patients have to also receive chemotherapy, radiotherapy, in addition to surgery. So, better for a malignancy is ECOG rather than Karnofsky. Anyway, so this is how you are going to tell the description of abdomen, correct? You know how to divide it into 9 quadrants, and you know you are going to see one. If you see one small swelling, you are not very clear, like this. If you see there, you can't make out really mass, so you can only say as fullness. Fullness. So, mass means it should be clearly visible. Fullness is a diffuse. And don't say fullness moves with respiration. If there is a mass, then only you please use the word movement with respiration. Fullness, better to say vague. There's a diffuse fullness seen in the epigastrium. I can't make out the detail. Fine, over. If you say mass, then you need to describe like a swelling, size, shape, surface, border, skin of the swelling, in that order. So that's how you proceed with the inspection. Ascites means you know how to diagnose. Flanks are full, some epigastric veins you can see here. Few details can be made out here. Few details cannot be made out. Localized and uniform. Can you see that some movement here? I think you can see, I suppose. You can see the video there. This is not movement with respiration. It is anterior-posterior movement. Don't get confused. Movement with the respiration has to be up and down. This is anterior-posterior movement, right? So, not craniocaudal, right? Now, so now you see this patient here, where I have kept my fingers at the lower border of the mask there, just above the umbilicus. You can see some fullness, I suppose, in the epigastrium. A nodular mass is being felt, and I ask the patient take a deep inspiration, and you know that diaphragm moves down, so you get movement with the respiration. This is the favorite question. What are the structures move the respiration? Stomach, liver, spleen, all direct contact with the diaphragm. Hepatic flexure, close to the diaphragm because of the splenocolic ligament. Similarly here, colophrenic ligaments. Now you have tail of the pancreas is attached to the spleen. Kidney, enclosed by Gerotas fascia, which is blended above with the diaphragm. So kidney also moves with respiration. So keep your finger at the lower border and try for the movement with respiration. Yes. So you got the mass or fullness. Remember to, again, fullness has no dimension, but mass has got dimension. Look for Sister Mary Joseph's nodule. Very often it's a hard, some ulceration you can see. So she was giving the sponge bath and she brought out this something I am feeling to William Mayo in the Rochester Hospital, where there's a Mayo Clinic. So she was the head nurse. This case they opened, not this patient, and they found inoperable carcinoma stomach. So this is Sister Mary Joseph's nodule. So now you see this here. See? You can see something, but you will see better in the next slide. Just watch carefully. Yeah, I think you can see. Yes. Watch in the epigastrium. Wave of peristalsis. That's what is ball rolling. A classical case of carcinoma pyloric antrum. You see that wave is starting from the left side, right coming across on the right side and ending near the antrum. Can you see now? Look at that. Hope you saw the movement. You saw the movement or not? Say yes at least. So I'll play it again. So very classical case of VGP, commonly asked question. When do you see it? There's a growth in the pyloric antrum. If there's a body, there's not much of enough stomach. So you won't get that. So this is the one you should see. Now, here. Not every case in the epigastrium is carcinoma of the stomach. No doubt in the stomach we think of carcinoma. Pseudocyst of the pancreas is another common condition because of alcohol. So TENS, you can see is such a large swelling there, like a one big dome, but it will not move the respiration. You know, this is typical of a pseudocyst. One of the favorite questions to you, typically pseudocyst, because it has got no epithelial lining, right? You can have one more case like this. Look at this very carefully now. Yes. Does it move the respiration? Yes or no? No. Oh God. So nicely they are moving with respiration. Surface is smooth or nodular? Nodular or boscillated? Oh, looks very big one. Look at the lower border from this end to that end. Is it only in the epigastrium or both sides? Whole side, right side, epigastrium, left side, nodular. So what it can be? Moves with respiration. So, what is that? What is that structure anatomically? What is the, just now I said what structures move with the respiration? One is the stomach, other one is liver. Which ones extend from right to left? So huge. Liver. So which condition you get? Multiple nodular liver. Yes? Secondaries in the liver. Secondaries in the liver. So this is metastasis. Like you get secondaries in the neck, secondaries in the liver. Common is the stomach. Common condition is stomach. So when you have in the epigastrium, look for movement with respiration, stomach and liver mostly. Doesn't move, that large one, pseudocyst. These are the common three things you should remember. So, little homework for you is to read about visible gastric peristalsis. Everything cannot be told over a whatever limited time. Yeah, that's what it is. Yes, now we'll start the palpation. So you know what the things we have to palpate. Any other location, extent, tenderness, size, shape, surface, everything. Interestingly, every organ has got certain specific, like liver we say sharp border. In medicine also they will teach you that. Stomach, when you percuss some kind of a resonance you get because it contains air. We say pancreas, do not fall forward. I'll come to that. Don't make the patient knee, elbow and all. Nowadays we have stopped doing it. Just you can tilt the patient to see for any mobility. So, but important thing, remember, whenever you have an upper abdomen, stomach, liver, spleen, upper border cannot be made out. That is the one important test you should do, what has been mentioned as finger insinuation. Other way in the lower abdomen. In the right iliac fossa mass, in a women, females, lower border is very, very important. Because if you don't get the lower border, it is probably arising from pelvis. Something similar in the upper abdomen. If you cannot get the upper border, it's mostly liver or spleen. Right side liver, left side spleen. This is how simple it is. If it is in epigastrium, stomach you can get above, pancreas you can get above. So some of the very fundamentals you should know. You started palpating, you got tenderness. So, we always told you in the beginning, cancers are rarely tender. Even in the neck nodes, you don't get tenderness in cancers. Cancer is never tender, most of the time. Hepatocellular carcinoma can be very tender. This is something you should remember. And obviously, we don't give you amoebic liver abscess and all this list here. Tender masses we don't keep, but if you are asked what are the causes of tender liver, tender hepatitis, congestive cardiac failure, don't forget congestive cardiac failure. Somebody thought an amoebic liver abscess and put a tube, and patient started bleeding. It was a congestive cardiac failure and tender liver. Patient was having breathlessness. They thought it's amoebic effusion. So, but nowadays it is not all that common, right? One thing, always look, when you want to say pseudocyst or even sometime ovarian cyst, in the neck we tell you, have you checked for fluctuation? We always tell you, cyst means fluctuation. Don't mention it in the abdomen. You cannot do it. You can't hold that swelling properly. So don't mention that word at all. And yes, this is not common. The last one, ruptured aneurysm, impending. All this is your epigastric mass. So, for all practical purposes, since we are talking about carcinoma stomach for you, it is non-tender. So, epigastric mass, non-tender, hard, irregular, moves with respiration. I can get above. That's a classical case of carcinoma of the stomach. Now, if it is a pseudocyst here, pseudocyst, you can get tenderness. Anyone notice this tube in his nose? Does it have the color of the Ryle's tube or some different color? Blue, correct? It's a blue color. So, what is that? Any idea? Anyone has seen? It's a feeding tube. Feeding is a nasojejunal tube. He can't swallow because large cyst is compressing the duodenum. He can't. He is vomiting. So it has bypassed through the duodenum into the jejunum. Under fluoroscopy we put. This is called a nasojejunal tube. The second picture, so that's the tenderness there. And so here, again, as I mentioned to you, this is the lower border. You can see stomach has gone up to here. This is the carcinoma body as well as fundus. This is pseudocyst here. It was tender and thin patient. We keep the fingers at the lower border always and ask the patient to take a deep inspiration, and that's how you confirm under palpation the mass moves with respiration. Now, that's what I mentioned to you. Look at that. I have not drawn the upper border here because it's the liver. Whereas here 2 fingers are denoting upper border, especially in the stomach. This has been already mentioned to you. Now, movement with the respiration, very important finding. Please do not miss, especially epigastric mass. Don't confuse for anterior-posterior movement. Confuse always for up and down movement. Keep the finger lower border. Please remember the logic here. Any mass which is in contact with the diaphragm, diaphragm, it can have some amount of mobility. As I told you, in medicine there is nothing like this is impossible. It may be possible. So, we all tell about carcinoma, stomach moving with the respiration. But imagine advanced patient, it is fixed to the pancreas. It may not move with the respiration. So, just keep it in mind, the most probable confusion, most probable explanation. Yes, consistency anywhere in the body, morning neck, that afternoon class also anywhere my professors used to tell a 3 mantra for anywhere in the body to give a diagnosis of cancer. Hard, irregular, fixed. That's all. So you can just get through your examination. This is mantra. Neck also, hard, irregular, fixed. Anything. There may be exceptions, but undergraduates, you don't have to worry about that. Postgraduates have to be worried. We'll ask them the question, which thyroids need not be hard in malignancy? Which lymph node in the neck need not be hard in malignancy? Which is that papillary carcinoma thyroid. It can be soft. It can be cystic. Papillary carcinoma thyroid. It need not be hard. It need not be irregular. So there are some other examples. So that's how it is. So I already mentioned to you about don't say fluctuation. All these, including ovarian cyst, retroperitoneal cyst, pseudocyst, they are all tense. Now comes the intrinsic mobility. Remember the morning that swelling which he presented, he said freely mobile, this today just now, lymph node swelling. So in the abdomen, if you want to check for mobility, you have to hold it. If you can't hold it properly, you can't do the test. Epigastrium becomes sometimes difficult because area is small. Area is small, but lower abdomen, you can do easily mobility. So you can check that mobility here. You can see this is on table actually, during the operation table. See such a large mass, you can see how nicely you can move like this. Such swellings rarely are cancers, rarely, this type of swellings. So look at that large, it's just above the umbilicus. For postgraduates, if anyone is here, it's called as stromal tumors. Gastrointestinal stromal tumor, they are large ones. You can have a free mobility. I mentioned about sometimes knee elbow test. It's a very lot of inconvenience it causes. Putting the patient on knee elbow, most of the time, today means we are talking about 2024, we don't expect you to do. If you know the philosophy, it's fine. If you do it, nobody can tell you are wrong, as long as you already done the enacting the role. You take the permission from the patient and say, can you put me like this, can you do like this, all that thing. So it is not going to add you much, just a lateral position is better. So, but you should know why this test is done, to differentiate intraperitoneal from retroperitoneal. But argument is like, one analogy you can say, thyroid gland moves with the deglutition. Yes or no? Yes. So you need not do sternomastoid contraction test. You need not do chin test. You need not do neck flexion test. Why? You don't have to prove it is deep to the deep fascia. You don't have to prove it is deep to the pretracheal fascia. You don't have to prove it is deep to the sternomastoid because it moves with deglutition. That's how it is simple. So if the mass moves with respiration, there's no point in putting the patient like this. Fixed mass, just put a lateral tilt, that is enough. So, any other mass, when you have an epigastric mass, any other mass palpable. Remember, it's carcinoma stomach, your case. Whenever we have a malignancy, dictum is local, loco-regional, spread. Like in the neck, we said no, reticuloendothelial system, spleen, liver, like that. In a similar fashion, here also, if you think it's a cancer, look for the liver. Because liver can be site of metastasis. 38-year-old lady with the carcinoma stomach. 38-year-old lady. I give a clue, it's a premenopausal lady. Premenopausal. What do you look in the pelvis? What do you look in the lower abdomen? What do you palpate in the lower abdomen? Krukenberg tumors. The answer should be Krukenberg tumor. It's nothing but, it's a bilateral spread. What was initially called as transcoelomic, now we say lymphatic, or even now we say hematogenous. All right, let us not worry about that. So please look into this. That's what is the Krukenberg, typical premenopausal, bilateral, bulky, ovarian metastasis. You should have a vascular ovary in which the cells will deposit and they grow. So this is lower abdominal mass. You should be able to palpate, right? That is the Krukenberg tumor. We started percussion. One test, they may ask you if there is a patient who has got a persistent vomiting, that's succussion splash. So that you know there is a stasis. There are three important tests for a pyloric obstruction in a carcinoma stomach. One is visible gastric peristalsis. You saw that wave. It's a wave. Second is splashing sound, and third we'll tell you later, ausculto percussion test. So once you have palpated, now start analyzing. Is it liver? Is it liver, epigastric mass? Liver left lobe also comes here, but I could not get above, so liver is less likely. Is it stomach? Stomach moves with respiration. Liver also moves with respiration. Now we are going to have later percussion and say stomach gives some resonant note, correct? Liver does not give resonant note. What about mobility? Liver does not have intrinsic mobility. Don't get confused to movement with respiration. You can't hold the liver and move. So hard inconsistency, yes. Then percussion. Again here, so gentle and percuss and say, stomach contains air, no doubt, but you also have some growth there, cancerous lesion. So chances that it need not give a complete resonant note, like intestines. We say impaired resonant. Examiners are fond of asking that question, what is impaired resonance? I don't ask that question, but other examiners ask. So you just have to think in mind, air plus growth. That's how it is. Of course, you need to look for shifting dullness for shifting dullness is for ascites. if they ask you the theory, you should know. You keep your stet here. Remember, this is the lower border, stomach is dilated because of obstruction. Stomach is hugely dilated. We call it a J-shaped stomach actually. J-shaped. So you start, keep your stet there and percuss. And when this note, dull here, fluid, is the intestines are here, so resonant, that join these lines, you get the lower border. That's a dilated stomach. Normally you get lower border somewhere here only. Stomach is, on empty stomach, it's very small. So, ausculto-percussion test, you get lower border. So that's how you make a diagnosis of pyloric obstruction. So, I have mentioned to you these things. It is testis. I highlight not as external genitalia, I always highlight testis so that you know. In women, I will not examine external genitalia. Your importance is for testicular tumors. Testicular tumors presenting as only left supraclavicular nodes and some discomfort here. Young boy, some vague discomfort, and you find it's a testicular tumor. So, these are some for the postgraduates. If there's a varicocele, it's a renal cell carcinoma. Left-sided varicocele, if a recent occurrence, and an abdominal mass, always suspect RCC. There's a renal cell carcinoma, renal masses with a unilateral varicocele. So this is Troisier sign for a supraclavicular node. So that's how you make a diagnosis of combination of an anatomical diagnosis and combination of a pathological diagnosis. Always, if there's a malignancy, remember to stage. Okay, part 1 I will stop now. If there's any questions, quickly, I will be taking another 10 minutes. But if you have any doubts related to clinical examination of abdominal mass, if 1 or 2 questions, any questions, any doubts? Epigastric mass is a common case for you. Any doubts? Yes? No doubts? You understood well? Very good. So, I have purposefully put there, what is the differential diagnosis of a stomach mass? The common question which is asked. I am not telling it's a epigastric mass means a stomach, liver, pancreas you give, not like that. From undergraduate point of view, it's always a carcinoma stomach. Don't try to give some ultrasound diagnosis. Even for postgraduates, somebody will see the CT scan and tell, and they will tell the CT scan diagnosis. Please do not give that. To give a diagnosis of these two, you need to know what is the pathology of this, how does the gist happens, not for undergraduates, large tumors, young patients, mobility is present, GI bleeding, lymphoma, very difficult diagnosis to clinical, but you can do it, tender epigastric mass from the stomach. Otherwise, it's only one diagnosis, but give a complete diagnosis. See, carcinoma stomach, gastric outlet obstruction. Is there a metastasis? Stomach, left supraclavicular node. Krukenberg tumor. Carcinoma stomach, ascites. That adds to your staging. So, in other words, try to give a complete diagnosis always. Don't try to say only one. Then obviously, question they will ask is, naturally, get ready. Why stomach? Why not liver? Why not pancreas? So I think we have made the things clear. In a given case, epigastric mass, why did you tell it is stomach? We know that reasons. Moves with respiration, upper border can be made out, percussion note is resonant. So, falling forward if you do a knee elbow. Why not liver? Liver, you can't get the upper border. Liver is dull. So this is how you try to give 3-4 reasons. Patient has persistent vomiting, so it has to be antrum. Epigastrium is more of a large masses. They have that dyspepsia, early satiety, and fundus dysphagia. I think one favorite question in the exam, what is resectable and what is curable? Two things are different. You have a cancer which you can remove, resectable, but patient has supraclavicular node. So we can't give a curative resection. So that is what we mean by inoperability. Inoperability does not mean that you are not operating. Please remember this word. Inoperability does not mean that you are not operating. Inoperability means cure is probably not possible. So that's how it is. And this is the one chart you should know, how to differentiate a stomach mass from a pancreatic mass. Simple anatomical points. See here, moves with the respiration. Here does not. Mobility, resonant note. One important thing here. Pancreas is retroperitoneal structure, so aorta is in behind, so transmitted pulsations. You will not get if it is a stomach mass. So this is one. Moment you keep your finger there, mass and something pulsations are there, it is more going towards pancreas rather than stomach. So in the epigastrium, favorite first diagnosis is carcinoma of the stomach. Second diagnosis, they may ask you why not carcinoma pancreas. This is what is going to help you. And you will also tell, no, backache, weight loss, all those things. And why not a left lobe hepatocellular carcinoma? Why not? So this is how you should try to answer these questions to yourself. That's the best way to think. Use your common sense and brain, not just be the slaves of ultrasound and CT scan and investigation based. No doubt you will ask for those investigation and interpretation later, but keep it in mind, little bit of thinking you do. Why not it is liver? If it is liver, why not hydrated cyst? Why only malignancy? This is how you should try to think. So if you start analyzing each clinical method, palpation, inspection, lower border, surface, then you will get the answers for all the questions. So why not liver? Why not pancreas? Why not stomach? If it is liver, why not hepatoma? Why not hydrated cyst? I'm not sure how common is this area. Similarly in the stomach, why carcinoma stomach? Okay, why not you add a gastrointestinal tumor? In the pancreas, why not a carcinoma body of the pancreas or cystadenoma? At least two diagnoses from your point of view. Two at least each. So that's how it is. And then you already mentioned few points there. This is the features of the stomach we have already mentioned. And yes, somewhere I think when the next swelling was asked to you that what is the pathology maybe? Is it inflammatory or neoplastic? Good way to think in the mind. Lymph node swelling, inflammatory, neoplastic. Neoplastic benign or malignancy. Similar, inflammatory, acute or chronic. Acute, tender nodes. Similarly here, is it a cyst? Is it epigastric hydrated pseudocyst or hard nodular? Or is it para-aortic nodal mass? 20-year boy comes with a para-aortic lymph nodal mass. Testis, you're not examined. Straight failure because it was a testicular tumor. So this is how you give a diagnosis. So I think I will stop my presentation of epigastric mass, right? So if there's any questions from your side. No questions. Postgraduates, anybody is there in the audience? Yeah, yes? No. Yes, good. Any questions? I'll be leaving my slides here so you can use it. It also got some more is for other people. These are the few important things. Sorry, I think. Okay. Yeah. I said GIST occurs in a relatively younger patient. GIST is not a mucosal disease. It is in the wall, stromal. It grows outside than inside. Can somebody connect this? This? Just since she asked that question. No, this. 1 minute. Just your question. Look at can you read that? This is my actually postgraduate who did this picture maybe about 15 years back. 45-year-old pain, vomiting, 3 months duration. Look at that mass. Look nicely how the stomach has been put there, and look at that extraluminal mass. And see, this is on table. Carcinoma will never come such a big mass, and he never had vomiting. This patient has no vomiting at all. And look at that CT scan here, and look at this mass. The whole thing was extraluminal resected. And for your sake, this is a classical picture of endoscopy finding, where the tumor is ulcerated into the stomach. What is this appearance called as? It's called as cervix appearance. Cervix. When you do an endoscopy, you find a bulge. This large GIST nodule has ulcerated there. That's what is the GIST. Look at that specimen. So, and this is with the spleen. And this is a small portion of the stomach. This is all extraluminal. So, more mobile, young patient, resectable, you suspect. Any questions? No. Yes? Please. No problem.
Photodynamic therapy.
Sorry?
Photodynamic study.
What?
Photodynamics.
No, we'll not talk some other time. Theory. Talk related to this clinical aspect so that will not dilute the presentation. Like there are many things we can give, like this is the classical cartwheel of a hydrated cyst. This is that same hydrated cyst. Pancreas, pseudocyst, you can see all these are part of that large pseudocyst here. Then we have the typical cystogastrostomy. This is cystodenoma of the pancreas, large tumors coming from here. These are all the differential diagnosis from your point of view. You should know about related to this serous and rest of the things. Yeah, these are some of the quiz questions. Maybe they're tomorrow, so I don't want to say. Can any PG read this CT scan? Liver, one you can see here, correct? This is large retroperitoneal nodal mass, and look here, down, testicular tumor with the paratic nodes and the liver metastasis. So same thing, testis, if you don't examine in an abdominal mass, gone. So that's the important thing. So that's so few things like omental cyst and all that things are there. Yes. Okay.
Thank you so much once again, sir. For
quiz. Can we start the instructions for them? We'll have a quick quiz. It takes only 15 minutes. 2 of you form the team and leave one space and sit together. You can select any partner or any of your friends and select. One paper you take in your hand. Prelims. That side boys are bit, come to the front rows and start writing.
Hello.
Page. Third years and final years. Yes, come forward. Give it a try. Find your partner and come forward. We will give you the paper. Please come. Yes, second years.
Thank you. Come on, it's just a participation, so don't worry. Quickly you decide. Very easy. Postgraduates also can sit. Participate. We may not consider you for prizes. Participate. Those who are not participating, you should not give them the answers. Please keep quiet, because so till they say yes, I will just, so that you start having some fun, at least fun. Is it possible to connect now? Yes. Yes, sir. What? This
video play. Video play.
sound?
Video play.
Oh, like that.
Duplicate. Which one, sir?
That one, yeah, play.
That's one.
Sound.
Sound.
So till you settle down, just enjoy this acting by this girl.
तुमने कहा है देखो देखो मुझे सैया बोलो तुमको इकरार है हाँ है फिर भी इनकार है हाँ है ओ तुमको मुझसे प्यार है ना 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 बागों में बहार है
If you tell me the name of the movie, tomorrow prize will be given.
Once more. I think this video is becoming more popular than that.
तुमने कहा है देखो देखो मुझे सैया बोलो तुमको इकरार है फिर भी इनकार है ओ तुमको मुझसे प्यार है बागों में बहार है
Silence.
Correct. Those who said Aradhana will get prize. This is not the first question, okay? This is only a time pass. Ready? Yes, so we will. No. I won't give you much time. Just single word or the one. No, where is that pen drive? Just enlarge this. 1 minute. Go back. Can you open this final? Just open this preliminary. Yeah. You have to, 1 minute. You have to just enlarge that. No? It is not visible. No, that's okay. You, word file, no? You put it in the.
Okay. Ilana close பண்ணிடுறேன். சேவனா அப்புறமா எடுத்து. Okay.
There are 30 questions in this. 30 questions. You can start writing now. Your time starts now. No. Close this. Close. I wanted only that because the answers are seen there. There is a second page. Okay, then you ask him to see. I don't want this. Okay. You put it in separate page. It was I want only one page. Yeah, I want only. Yeah. That's 30. That's all. That's enough. Okay. That's fine. Okay. Yeah. You can start now. Yeah, that's enough. Okay. Don't go on writing pages and pages, okay? Either they are one word or two word or very small answers. So it will be start. Question number 1, which malignancy can present as fever, fatigue, fall, fracture? That's okay, we'll see later. Once they. I hope you have written your names, including name and your roll number or whatever. Roll number, semester. Attractive prizes are there, okay? So, anybody can participate. Which anomaly of the testis is found in ectopia vesicae? Read the question carefully. Which anomaly of testis? Commonest cause of bladder wall calcification is what? Cause. Interstitial cystitis is also called as what?
don't discuss, only the pairs can discuss. Two of you. What prevents horseshoe kidney in ascending upwards? Horseshoe kidney, what prevents it ascending upwards? Vomiting due to renal capsular stretch is mediated by which plexus? Please write the question numbers also. So we have just finished 6 now. 6th is that, yeah, it's very clear. You can go on writing, no problem. 7, thimble bladder is seen in which condition? Thimble. Thimble. Small. Sometimes I can give a clue because this is a UG. Thimble is, you know what is thimble? Grandma uses that small thimble. A bacterial acid pyuria is seen in which condition? A bacterial acid pyuria. Also they call it a sterile pyuria. Is seen in which condition? What is the relationship of ureter to iliac vessels in the pelvis? Relationship of ureter to iliac vessels. See, when they ask a relationship, here it's only either anterior, posterior, lateral, medial. That's all. Don't write anything else. Simple. What is Hasselbalch's fascia? Not triangle, okay? What is Hasselbalch's fascia? What is the shape of femoral hernia when it spreads into the thigh? The femoral hernia through the femoral canal comes out, suddenly it expands. So that shape, there's one particular name for that shape. What is Gaur? G-A-U-R. Indian, there are only few names of Indian surgeons' names in Bailey and Love, or one of them is this Durga. refer to. Absent carotid artery pulsation in the neck is called as dash sign. Absent carotid artery pulsation in the neck is called as, you look in malignancies, one sign. In malignancy, you look for one sign. Calcitonin producing parafollicular C cells originate from what structure? Parafollicular cells, also called as C cells, originate from what structure? Inferior thyroid artery is a branch of what artery? Inferior thyroid artery is a branch of the laparoscopic camera and cable are designed so that they can be sterilized by what? Yes, what is space of Bogros? P-O-G-R-O-S. 26, that one. 27th, what is circle of death or corona martis? What is cauterization? Tomorrow's quiz will be much more easier than today, because today we have to select. Tomorrow's will be very, very easy for the finals. Taxanes are used in which condition? Taxanes. Chemotherapy, paclitaxel and docetaxels are used in which condition? Common. We are talking about surgical condition. They may be used in a lot of cancer patients, but what is May-Thurner syndrome? No, we'll just minimize, no? 1 minute. No, it's not yet over. Just small few questions. That's all. Not much. Diagnosis. Don't go on writing on inspection, multiple nodules seen and all that thing. Diagnosis. One diagnosis. Very easy, I thought. I don't have to tell you that it is a testis, okay? Testicular skin, scrotum, okay? Diagnosis. Nape of the neck. Classical diagnostic feature. Classical diagnostic feature. Nape of the neck. Multiple pustules coming out. Diabetic patient. Large swelling here. He has undergone some surgery. Loss of weight. Some temperature. Here there's one swelling. Temperature. So, diagnosis. Write any diagnosis. Don't write thyroid, but write some diagnosis. No problem, you can tell. Look at the hand, look at this little finger, look at this ring finger, look at some muscles here, and the same patient in the lower end of the medial side, small big abscess like thing. Look at the hand like this, you know. Only one word diagnosis. Only one word. These are all, don't write sentences. We can't correct. One important finding in this scan. One very, very important finding in the CT scan. Diagnosis. I have already told you there are multiple pigment gallstones. Multiple pigment gallstones, but I want the disease. With this, clue has been already given. Clue, pigments. So, yeah, this I think all of you will tell, because today morning they have done some role play. Name the method. This is easy. I think now I can see some smiles coming from that side. I think this is the easiest one. Next one. 9. Where is that person who did the role play? Oh no, sit. Diagnosis. I want the diagnosis of this. Don't write tobacco, stained teeth, all that thing. What do you call this as? She is trying to open the mouth. I can't give more clue than that. What do you call this condition as? What do you call this condition as? What has happened? Write. No talking, only writing. These are some for postgraduates. What is this holy plane called as? So, these are the questions. Now, one question is there for last people who are sitting there. Special prize will be given. Can you identify this girl? Audience? No. Okay. Now, yes? Who? Lata Mangeshkar, she gets the prize. Now please give your paper to the next team and rotation like that, please. For correction. If you find any scratches, anything which is, cut, no marks will be given. So we'll start. Don't correct now. Now you have to only write 1 mark or 0. Don't write half mark, 1 or 0. Question number 1, renal cell carcinoma. Question number 2, what anomaly of the testis in ectopia vesicae? No anomaly. Testis is normal. No. Third is cystosoma, calcification. Fourth, Hunner's ulcer. 5. The reason why horseshoe cannot come up is inferior mesenteric artery crosses at the level of isthmus of L3, L4. The reflex of that is celiac plexus. Celiac plexus. Number 7, thimble bladder, tuberculosis. Golf hole ureter and thimble bladder. Number 8, abacterial acid pyuria, that is tuberculosis. Number 5, ureter crosses anteriorly. Okay. Anteriorly. Ureter crosses the iliac vessels anteriorly. Number 10, posterior wall of the bladder. Number 11, Hasselbalch's fascia. It's a cribriform fascia covering the fossa ovalis, nothing but saphenofemoral junction. There you get that. Femoral hernia comes out. It's called a retort. You know, retort. Obstructed femoral hernia, you get a dilatation of superficial epigastric vein, and that is called as Gaur sign. Aberrant obturator artery is medial side of the lacunar ligament, medial side. Vascular sign of Narath, congenital dislocation of the hip. The head of the femur pushes the femoral artery, so you get a prominent pulsation. The muscle which clockets hernia, which I was talking, is pectineus. 16 is pectineus. Incarcerated hernia is nothing but obstruction due to fecal matter. It's fecal matter causing obstruction. Madel's hernia, it is intra-abdominal segment is gangrenous, not outside. You know, it's a W. It's a W loop. Hernia which causes diarrhea is Rich's hernia, partial circumference. IPOM refers to the most commonly done surgery now, laparoscopy for a umbilical hernia and all, intraperitoneal onlay mesh repair. It is there in the UG also as a short note for you. The French position is nothing but reverse Trendelenburg, that's all. Reverse Trendelenburg. Absent carotid artery is, I think you have written there, no, Berry sign. Fourth, branchial pouch. Inferior thyroid artery is a branch of thyrocervical trunk. Cables and for laparoscopic instrument are supplied by glutaraldehyde. Those who have written, even if you write pre-peritoneal space, if somebody has written, you will get the marks. These are for PGs actually. The posterior compartment of that space, this is a very important space in laparoscopy. Aberrant obturator artery, which can bleed, and it's called as classical corona martis. What is cauterization? I think you know. Mobilization of the duodenum. Taxanes are used in Even if you have written LABC is fine, carcinoma of breast is fine. May-Thurner syndrome is, see that compression of the left common iliac vein by the right common iliac artery. Okay? Please total it now. All these are 1 mark questions. Total them quickly. No? Yeah, that is, they'll have 2 marks. Please total them. Now, all these are 5 marks now, 5 marks. 5 marks. Those who have written calcified multiple sebaceous cysts of the scrotum, full 5 marks. Those who have written strawberry scrotum, also you will get the same marks, no problem. Those who have written multiple sebaceous cysts also will get 5 marks. But if you have written lipoma of the scrotum and all, you will get minus 50 marks. Okay. This is carbuncle. This is pathognomonic, sieve-like, sieve, multiple sieve-like, carbuncle. Tubercular cold abscess, tuberculosis here. Tubercular cold abscess, 5 marks. Those who have written multinodular goiter, 5 marks. Colloid goiter, no marks. Multinodular, big. Anybody can tell the diagnosis? Ulnar claw, correct. Can you correlate with the claw? Some burns like thing here, no sensation. Very good. Who said Hansen's disease? Give her some prize. We'll give you prize. But you are not in the quiz, but you will get a separate prize. It's a Hansen's disease. Those who have written ulnar claw will get 5 marks. Those who have written leprosy will get 10 marks. Please. This is a good, difficult question. Don't change now, okay? Because your papers have been... Anybody? Anyone has seen this? What is this? This man was surviving with his heart in the peritoneal cavity. This is the heart in the peritoneal cavity. A rare case. Very, very rare. This. You can't see that. This. Huh? See, no? Cursor is... show them. This. See the shape of that. Hemolytic anemia. Those who have written hemolytic, any hemolytic is okay. Sickle cell, you have written sickle cell is fine. Anything, hemolytic should come. Pigelos method, all 5 marks. Lahaye's method. Trismus. Prolapse of the stoma, prolapse. You have to write prolapse. Word prolapse should come. Stoma means ostomies. healed. Holy plain, that may be difficult for them. Yes, now you total it and hand over the papers. So tomorrow we will announce the five winners. Huh? Healed. Holy plain. Okay, so I'll stop now. What's the time? 5:30. So let them select five teams. That's all. Tomorrow, two each. So, but you are selecting only.
Answer, but we look forward.
Time for some fun? All right. Up next, we have a solo performance from the Department of General Surgery, JR2, Dr. M.J. Shahar. Let's give it up for him, everybody.
So, hello everyone, how are you all? Okay. You might not know, it is called Konjam Konjam Dhaan Tamil Theriyum. And one more is called Ini Illai Hum. Okay. So rap song goes a little fast. We'll see how it goes. எனக்கு கொஞ்சம் கொஞ்சம் தான் தமிழ் தெரியும் என்று சொல்லும் இந்த அவல நிலை முதலில் ஒளி எனும் தமிழை தமிழ் என்று சொல்லுவது கேவலம் என்று இப்ப நம்ம மக்களுக்கு புரியும். இங்கிலீஷ் பேசினா பசங்கெல்லாம் மாஸ், இங்கிலீஷ் பேசினா பொண்ணுங்கெல்லாம் கிளாஸ். நீங்களாவே நினைச்சிட்ட என்ன செய்ய பாஸ்? இந்த கேடு கெட்ட நினைப்ப நீ முதல்ல மாத்து. ஆங்கிலத்தில் பேசுவது தவறொன்றும் இல்லை. இந்த காலத்துல பொழப்புக்கு ஆங்கிலம் தேவை. ஆங்கிலம் பேச கத்துக்கணும். இந்த உண்மையை எல்லாரும் ஒத்துக்கணும். ஏய் என்ன மேன் சொல்ல வர நீ? பிறப்புக்கு வேலை தரும் மனிதனை காட்டிலும் தாயின் மீது பாசம் வேண்டும். பிற மொழி இங்கு பல வளம் வரும் போதும் தாய்மொழி மீது நேசம் வேண்டும். வெளிநாட்டுக்காரன் தமிழின் பெருமை கண்டு தமிழை படிக்கின்ற போது அடங்கவில்லை நமக்கு வெளிநாட்டு மோகம். ஐயோ தமிழுக்கு ஏன் இந்த சோகம்? Kandasamy changed his name to Candy, Madasamy changed his name to Maddie, Harini changed the name to Hani. இந்த கொடுமை எங்கு போய் சொல்வேன் நீ? தமிழர் பெயரை தமிழில் சொல்ல அவமானம் வரும் நிலை வெறும் அல்ல. ஏண்டா இந்த மானம் கெட்ட பொழப்புன்னு நான் சொல்லவில்லை, ஒரு பசுமாடு சொல்லிச்சான். இங்கிலாந்தில் உள்ள ஒரு பசுமாடு சொல்லிச்சான். நானே மம்மி அம்மாங்கிற உனக்கு என்னடா? So now that we have an idea of what rap songs are, here's one for the ages. இருக்கரம் இணைந்திட 20 விரல் அல்ல ஒரு விரலில் மலரும் இல்ல மலரும் ஒரு எழுதி உனக்கு அனுப்பி வைத்தேன் காதலி உன்முக மனதுக்குள் தைத்தேன் பாராடி இருந்து மென்னை விட்டு நீ பிரிந்து சென்று விட்டு என் மனதை தொண்டுபட்டு என் வாழ்வே ரெண்டுபட்டு போனது போகட்டும் காயங்களா இருக்கட்டும் கவிதைகள் வெளியே நிம்மதி தேர் காதல் மாயை தெளியா போதை தெளிந்த பின்னால் நீ ஒரு மேதை யார் அவன் ராமன் தேடிய சீதை ராமன் சீதை கண்ணன் ராதை இதை போல் எனக்கு ஒரு தேவத்தேர் ஆணின் மனமது வீலக்காரனும் பெண்கள் வீசும் காதல் பார்வை தங்கத்தாமரை மின்னும் கேவதை கொஞ்சம் அவள் மனம் வெள்ளி தாமரை இசையால் அவள் குரல் கேட்கும் காதலை சிந்தும் தேன் அவள் பேசும் போதில் அன்பே ஆறுயிரை என்னவளை பொய்கள் பேசி சென்றவள் உன்னை நினைக்க முடியவில்லை நினைவில் இருந்தறியவளியும் தெரியவில்லை நெஞ்சம் பொறுக்கவில்லை வாழ்க்கை வெல்கவில்லை கண்ணீர் துளிகளை உண்மனம் அறியலை எனக்கு அது புரியல எதுவுமே சரியிட முடியலை என்னால் முடியல காதல் தோல்வி இந்த உலகத்தில் முடிவு இனி முடிவில்லை முடியிருக்கது முன்னில் இனி முடிவிருக்க போதும் இல்லை போ.
Guys, let's give it up once again for Sahar sir.
All right, everyone, let's switch things up now. Ladies and gentlemen, give it up for the newest generation of clinicians from the second year MBBS SMIMS with a smart and vibrant performance.
So it's time to announce the finalists for the quiz. Yes, you're excited? First, I would like to congratulate all the participants who volunteered. Yes, first place, it's a preliminary. That's what, sir, finalist. So I'll start from the last. The fifth team to get selected is Abhishek and Gautam from third year MBBS. So they got 31 out of 90. And the second team to get selected is Jasim and Nidish from second MBBS. So they got 32 by 90. And the third team to get selected is Muthu Kirtana and Madhura from final MBBS. So they got 33 out of 90. Followed by that, 2 highest scores we have. So 48 by 90 by Hema Priya and Hema Dharmi. Topper, any guess? Afroz Fatima and Mohana Shivani from final MBBS. So they got 49 out of 90. So congratulations all of you. So tomorrow we'll have the final rounds.
தனியா நடந்து வரீங்க, ஒரு பக்கம் அன்சிகா, இன்னொரு பக்கம் தமன்னான்னு அவங்களையும் சேர்த்து கூட்டிட்டு வர வேண்டாமா? வெளிநாட்டுல இருந்து வந்திருக்கீங்க, ஒரு வெள்ளக்கார பண்ணு கூட்டு வந்திருக்கலாம்ல தம்பி.
எங்கெங்க பொழுதனைக்கு படிப்பு படிப்புன்னு இருந்ததால லவ் பண்றதுக்கு நேரம் எல்லாம் போச்சு. நேரம் கிடைச்ச லவ்வையும் ஒரு கை பாப்போம்ல.
We're gonna blow the speakers, baby. Once again, with Jay Anthony. Oh, we think up with the hip hop. Ahala, ahala, mega hottie. Jump, 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 lady, jump. Move, 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 lady, move. Heartbeat you, heartbeat you. In the new age, heartbeat you. Heartbeat you, heartbeat you. In the new age, heartbeat you. Kulanalu kulichi kuli, kandanalu kasiki kakira, kansaya virgu mamane okmuroli. Sangi raga mokta mudai kai mudai, lati parai vira mailkan, nigane pore oli kayole mara. Manta mavadanda vada danna vana manta mudese matadage yundere vada adi chudi gadana vada. If you want to find a problem, adi chudi, tell me now. Come face makkalike varagam solli move around.
A mí me gusta tu descendencia entera. ¿Por qué? Porque ella me da.
La mamá de 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 la mamá
casi calentita con la abuelita. Mamá, casi calentita con la abuelita.
Give it up for the second year team for their absolutely fantastic performance.
Ladies and gentlemen, on that note, we have come to the flag end of the Sri Moogambika Academic Review and Training Program conducted by the Department of General Surgery, SMIMS. May I extend my sincere most thanks to Dr. Sridhar Sir, Scientific Coordinator for this session, for overseeing and turning this session. Well, we depart to meet again tomorrow, same time, same place. Thank you and have a great day.